Kumari ma'am.
Very good morning all. The chairperson of this program is Dr. Professor Sri Kumari Thamodaram. Madam has served the Tamil Nadu state government as professor and HOD of surgical gastroenterology, Madras Medical College. And Madam only first started the surgical gastroenterology department in Kilpack Medical College. And Professor Sri Kumari Thamodaram was selected as the first women Senate member of the Tamil Nadu Dr. M.G.R. Medical Institute for 2 terms and the first lady surgeon to be appointed. Over to you, ma'am.
Durga ma'am. You are fine to go, madam. Please, faculty, dear faculty, please, all of you unmute yourself, please. Durga ma'am.
Ma'am. Hello. Ma'am, Sri Kumari ma'am. Ma'am, please unmute, ma'am. Is it audible, ma'am? Hello.
Can you hear me now?
Ma'am, you can introduce the speaker, ma'am. Moderator, ma'am. Okay, please, ma'am. Yes, sir.
Hear me? I would like to the moderator of today's program, Professor C.K. Joshua, Chairman Hospital, New Delhi. Over to you, Dr.
Hello, ma'am. Good morning. Hello, good morning. I'm there.
If you log in too, ma'am, so please switch off YouTube, ma'am, because it's echoing. Okay. So in that case,
Thank you, Sri Kumari madam. Can I request Dr. Durga madam to start the proceedings, madam? Over to Dr. Durga, please.
Okay, good morning. I'm really very overwhelmed by this gesture of the Chennai City Branch chapter of ASI for organizing this beautiful meet of all the lady surgeons of India. I'm really, as a female surgeon, I myself feel honored, and at the same time, I feel humbled by your gesture towards all the lady surgeons on the eve of International Women's Day, that is tomorrow. And the topic of today's session, my session, is a safe cholecystectomy. Safe cholecystectomy is very important because of 2 reasons. It's a very simple operation and very commonly performed operation, and at the same time, any complication happening during this procedure can lead to very life-threatening and life-debilitating sequelae. So the importance of this safe cholecystectomy is paramount. To talk about, to lead us to a safe cholecystectomy, I have a very, very eminent panel. All the ladies, beautiful ladies, proved themselves in the field of laparoscopic surgery, and I'll be really happy to share, to bring their experiences to you people. And I have Professor Radha Verma, and I have Dr. Pinky Thapa, Dr. Rekha, whom I know personally, Professor Kanchna, and Professor Satyapriya. All my ladies, very, very warm welcome to you. And let us start the proceedings. What is safe cholecystectomy? It is safe for the surgeon. That means there is no litigation, and much more before that, it is safe for the patient. There should not be any injuries. Doctor, Professor Radha, are you there? Professor Radha, Radha Verma, please.
Madam, we have Dr. Satyapriya and I think Madam Radha Verma is having some challenges in joining us. So I
Okay.
think we can direct
So
this question to Professor Satyapriya ma'am. She is with us.
Satyapriya, welcome Satyapriya. Why this safe cholecystectomy is so important? Why you attach so much of importance to the safe cholecystectomy?
Hello, do you hear me?
Satyapriya, please speak on.
That is one of the safe cholecystectomy is one of the commonest lap surgeries being done all over the world, and I think anatomy, anomalies, all these are many problems are there with the cholecystectomy. So I think you have to be very safe while doing a cholecystectomy, remembering of the anomalies and injuries that can be caused.
Yes, I thoroughly agree with you. Even though the relative numbers are less, the injuries, but the absolute numbers are very high because the load of the amount of cholecystectomy is done all over the world. So if you count all these numbers, it will be a huge number. So as surgeons, it's our duty to have all the time in our mind about the cholecystectomy, which is safe. Is Pinky Thapar around?
Yes.
Pinky, are you
Yes.
there?
Yes, madam. Good morning.
Pinky, good morning. You have done so much work on this cholecystectomy. I'm so happy to have you on the panel.
My
And,
pleasure.
don't mind if I direct many questions to you. Don't get irritated.
Oh,
Okay.
it's my pleasure. My pleasure. My honor.
Pinky, what are the predictors you have for any difficult cholecystectomy which can lead to injuries? Come on.
One of the foremost is if you see from the demographic point of view, male patient, elderly patient who has diabetes, heart disease. These are the patients which, when the patient walks in the OPD, should be aware that these are the patients who can land up with complications, or they may be already having an existing complicated disease inside. Then the patient who has an attack of acute cholecystitis with Mirizi syndrome, stone impacted in the neck of the gallbladder. If we have such a report, he'll be overdistended. These are the patients who may land up with complications, and we have to perform with utmost safety. And of course, patients who have recurrent attacks of cholecystitis, because then the gallbladder is shrunken and contracted. So even shriveled gallbladder poses difficulty while performing the surgery. So these are some of the factors where we should be aware that these patients can have difficulty. Previous abdominal surgeries, it's a difficulty in terms of access. Otherwise, these patients, we change the access ports and we are prepared for any adhesiolysis, then they are okay. Otherwise, it's male gender, elderly patients, these are the main factors which one should be primed, and preemptively we should be anticipating difficulty. So once we anticipate difficulty, when actually in the OP, find things go smooth.
Yeah, that's very nice. And at this, we imagine by seeing the ultrasound, other imaging modalities, can you predict this gallbladder is going to be difficult. Satya, can you show some?
Yeah, with the thickness of the wall, if it's going to be more, like more than 3 millimeter, 4 millimeter, definitely we should anticipate difficulty in holding the gallbladder with our instrument. And then here again, small gallbladder, contracted gallbladder, the wall will be fibrous, thickened. Here again, we'll have difficulty. And same thing happens in a distended gallbladder also. It will be very flimsy and it will perforate when we try to hold the very distended gallbladder, and there can be spillage of bile and stones. And Merizel syndrome definitely we have to anticipate difficulty while dissecting the calyx. And cirrhosis and portal hypertension again, if it is diagnosed preoperatively, we should weigh the pros and cons, like whether it is really indicated, and we have to optimize the patient before entering into the abdomen.
That's great, Satya. Anybody else is there? Rekha, are you there?
Yes, ma'am, I'm here. Okay.
Rekha, this is
Yes,
for you.
ma'am.
Why at all injuries happen?
Well, injuries happen due to several reasons. As we all know, the hepatobiliary system is one that has a whole lot of anomalies, both in terms of the duct, in terms of the arterial supply. We find that there can be unusual pathology. We find that very often we misidentify structures. Find that injuries happen as a result of improper technique. It often happens as a result of bad instrumentation, either in terms of port placement, in terms of the energy sources that we are using. And you find it also happens as a result of surgeons either being in a hurry or not taking time to identify structures properly. It also happens during the early phase of the learning curve of surgeons. But the most important thing is failure to identify the structures correctly.
Satyaprem, want to add something?
Yeah, we should be aware of all the anomalies, all the cystic duct anomaly, cystic artery anomaly, and then hepatic arteries anomaly. So there can be multiple anomalies. So we have to be very much aware of this anatomy. I think that will give us problem during cholecystectomy.
So the most important factor is this misidentification of the structures. How will you reduce the misidentification factor, which is the most important factor? Satyapriya, this is for you.
So you have to go according to the anatomy triangles. So you have to first identify the triangle, and then you have to be careful while dissecting inside the triangle.
And what about this? Previous sulcus and this line, or is there any importance of these things?
Yes, definitely. You have to stop short once
You have to
we
keep
stop
one
short.
eye on this. Yeah, definitely these two things always keep in mind to reduce further complication, any other complication also. What is Pinky, this is for you. What is this hepatocystic triangle we are talking so much? Pinky, are you there?
Yes, madam. Initially, it was thought that if only we clear the cystic artery and cystic duct, that's enough for safe cholecystectomy. But that is not enough because still we have had cases of injuries. So the concept is to lift off the gallbladder from the bed. At least 1/3 of the gallbladder should be lifted off from the bed. That is called the hepatocystic triangle. It's widening of the field so that we are 100% sure only 2 structures are entering the gallbladder, and that is what we are clipping. Or else we can have a accessory duct injury. We can have a right hepatic duct entering the cystic duct, which we can clip by mistake. Hence, it's very important to lift the gallbladder off the fossa. That means do at least 1/3 or 50% of the dissection more, only then to clip. But most important,
You are unmuted.
Yeah, I feel the most important reason for injuries is hurry. It's a hurry to do the surgery, which leads to problem. We should be doing these steps very, very patiently and very, very meticulously. There is no second chance. So it's a zero error surgery. That's the reason if we lift the gallbladder up, then the chances of complications are actually zero.
And you tell the audience the importance of Suresh sulcus and R4U line.
Yeah, this is an arbitrary line made, and it's a Rubius sulcus is a natural anatomical line. Am I supposed to speak or?
Yeah, you are the boss.
Okay. So Rubius sulcus, sometimes it's not difficult to identify. It's very difficult to identify and exclude conditions. But if one has a panoramic view, don't have a very bird's eye view in laparoscopy. One moves backward, have a panoramic view, identify the duodenum, then go forward. Then you know that this is a line of bile duct. So the Rubius sulcus, we have to remain above the Rubius sulcus. No structure should be clipped below the Rubius sulcus. So this is the arbitrary line which is made from the Rubius sulcus, so that to the porta, so that we don't have a inadvertent bile duct injury or a hepatic artery injury.
So this line, even though you don't see it as a line, but keep always in mind.
Yes.
And this is a scene, the line. I want all the audience to have a mental picture of this line. The line will not be drawn there on the this thing. Okay, Pinky, thank you very much for explaining all this so beautifully. So, what is this Strasberg's critical view of safety? Who will take this? Pinky, you continue. Strasberg's critical view of safety.
Yeah, it's basically again identification of 2 and 2 structures in the gallbladder that are entering. That is the main critical view of safety. And we should have all the fibrofatty tissue in that area lifted off or cleared, either with an energy source, monopolar, or with a harmonic. That should be cleared. And only 2 structures should be seen. This is a very, very important thing. If one has a visual impression that, this is the end point of dissection, only then I'm going to clip the structures. Then we are 100% safe. However bad the gallbladder is, however difficult the situation or anatomical position is.
That's great.
These 3 points hold true. They have been, I think, told around 20 years ago, and they will hold true in eternity. It's not going to change.
Yes, it will not change. This, of course. You want to say a few words on this?
It's like owl's eye view. We should see the liver bed in between the artery and the liver liver in between the duct and the artery. So this is a beautiful image. This is possibly a simple gallbladder. One more beautiful thing in this picture is the lymph node also is lifted off with the gallbladder, which is the correct way of dissection. So it's a very beautiful picture.
At this juncture, Pinky, I would like to say, this type of gallbladders also can lead to some complications. What could be the reason of that?
Excessive traction, excessive lateral traction.
I think not only that, overconfidence of the surgeon. Oh, simple gallbladder, I will do it in 2 minutes. That kind of attitude will lead to complications in such simple case. Right?
Absolutely, absolutely.
I think others also must be. Satyapriya, what is this culture of safety in cholecystectomy? Pausic.
That is
Satyapriya, are you there?
Yes. And important thing
This
is
culture of safety.
hello. Important thing is we need to know where to stop. So that's the important thing in culture of safety in cholecystectomy. And if we need to know when to convert, and we need to know when to stop dissecting more. Because dissecting more and taking a longer time for dissection will result in injuries. And
So sometimes you may have to do subtotal
sometimes
cholecystectomy rather than only doing for 5 hours one gallbladder. So you should know when to stop. Okay? Any word about this 2 types of subtotal cholecystectomies? Can be restituting or fenestrating. So is Dr. Radha Verma on? Dr. Radha is in or out?
Madam, I am trying to reach her out, madam. You please direct the questions for the time being to the
So,
other participants.
Rekha, now come
Yes,
on
ma'am.
uh,
Yeah.
how to avoid injuries at each step.
Yes, ma'am. Now, just before we get started, I just like to add something with regard to the culture of safety. So this is something
Okay.
that we as teachers primarily need to reinforce and teach our junior colleagues. So you find that there is this sense of failure and there is conversion, and this is something that we have to so junior colleagues understand that it's not a failure as long as the patient is safe. So this
Exactly.
was something that was actually done as an exercise where they introduced this critical view of safety and made sure that everybody actually saw both the vessels, both the structures entering into the gallbladder before. And so this was a process by which they enforced it and then found that once they had this perfect so-called culture of safety with Strasberg, actually saying he actually made it look like a story. He said, I'm Erin, I'm the knight who does a good job if I have a critical view of safety. And then we have these errand structures coming if I don't. And they were able to make sure that people actually adhered to this concept. Now, the concept of saying subtotal cholecystectomy was what we used earlier, but today instead of saying it as subtotal, we use two terminologies saying penetrating and reconstituting. So when we say penetrating, we're actually talking about taking a suture on the inside, meaning that there is still some kind of a perforated or a seat-like opening. Whereas when we're talking about a reconstitution technique, we're using a complete suture. So in all of this, principle is that we try to make sure that we're not injuring the common bile duct at all. All right, if we will err on the side of the cystic duct, we will err on the side of leaving behind a little bit of G, but we wouldn't go on to the common bile duct side. So this would be the culture of safety in cholecystectomy. So Cortex is something that we need to train all our practicing surgeons about.
That's great, Rekha. Thank you for adding on. And now come to your own question. How to
Yes.
avoid injuries at each step? Avoiding injuries during port placement.
Yes, ma'am. So when we are looking at injuries, one of the first important things is that we need to have done a proper ultrasound prior to starting. All right, this is particularly important when we have a patient who has total hypertension, where we could anticipate varices in and around the umbilicus. So it is important to actually have the surgeon take a look at the imaging prior to putting the ports before starting the case. And this is something that senior colleagues tend to skip because you think it's a routine poly and you think that you can get away with it, but you can end up having a varix at the site of entry. Then a lot of studies to talk about open testicular technique of pneumoperitoneum. You find that the gold standard would be the Hassan technique, where you actually see for yourself before you enter. All right. But having said that, a lot of us do prefer the close technique rather than doing the Hassan every single time. Now, the injuries that can happen at the time of the first port, that is the critical time when you enter relatively blind. This can be avoided by using our safety trocars, or you find that the trocars with the vision added, so you find that you're actually seeing what you're entering into. You find you could injure bowel, you could injure bladder if it is not catheterized or if it's not empty. And you find that if a training surgeon is trying, you could injure the major vessel. The point here is that when you have put in the initial trocar, and then you see that the patient collapsed rapidly, as in the anesthetist says, the BP is dropping, the pulse is increasing, then you have to suspect a major vessel injury. When you're thinking in terms of a major vessel injury, it is important to leave the trocar in situ, convert to a laparotomy, rather than removing the trocar, because at that point, the tamponade effect offered by the trocar is lost, and you would lose valuable time in that.
Thank you, Rekha. Very well done. And
Thank you.
is Kanchana there around? Is Kanchana? No, she's not there. Pinky, this is for you. Your favorite subject. Injuries during dissection.
Yes, madam. This again occurs because of excessive bleeding. If we are a little fast and if we are not having a good tissue respect, of course, in acute cholecystitis, there is inflammation, but still one has to go meticulously slow in these steps. Like one of our intensivists once said, there are only two structures. Why do surgeons hurry? So I think we all should remember this. There are only two structures. So let us go peacefully and gently in that area. So misidentification of structures is because of our overconfidence and because of our hurry. So if we do patiently and we can use hydrodissection in this step, wherever there is frozen calots or any problem in identification of structures, we can pour some water, suction irrigation, and this is the cause, this is how it prevents, we can prevent the injuries. The gallbladder perforation, if it occurs, we can keep a gauze piece there, suck out the contents, and then clear off the field and then go ahead. So I think if we follow each step meticulously, each step at its place, then the chances of injuries are almost zero.
Right. Out of all this, the last on the list, CBD injury, at any cost we have to avoid. Right?
Absolutely. Absolutely.
Is Dr. Kanchana around?
Yes, ma'am.
Yes, yeah, I'm missing you. Injuries due to energy sources. Can you throw some light on this?
Durga ma'am, I think it is 9:30. I would request
Yes,
all
yes.
of you to stay safe because the national president and the vice chancellor madam are waiting for the inauguration. We will have a
Okay,
brief
okay.
inauguration program with the
Okay.
city branch and the state office bearers. Then we will continue the second half of the session, madam. Please bear with us.
Okay, done. We know.
And we will first have the Tamil Thai Varthu. For all the people who speak other languages out of Tamil, Tamil Thai Varthu is the traditional invocation song in praise of the Tamil motherland. So I would request all of you to stand up for the Tamil Thai Varthu.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராரும் மதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறந்தியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. It is Tamil tradition that we honor the faculty and the delegates. Unfortunately, due to the situation, all of them are at their home. Let me have the honor of inviting Professor Satyapriya ma'am to honor our beloved Vice Chancellor who have been all the help to us, Professor Sudha madam. May we all join us to celebrate this occasion. Thank you, everyone. Now, I would like to get the inauguration in order. Can I have the honor of inviting our Honorary Secretary, Chennai City Branch, to give his secretary's address?
Very good morning. First of all, I wish you all the very happy International Women's Day. So we deem it as a great honor to host a prestigious National Women's Surgeons Conference in this university auditorium as a hybrid program. So joined with Tamil Nadu Dr. M.G.R. Medical University. So our leader is Vice Chancellor Professor Dr. Sudha Seshan Madam, who is really advised and organized these functions. Really great privilege to invite our chief guest, Professor Dr. Abhay Dalvi, President National ASC. I cordially invite Professor Sudha Seshan, Madam Vice Chancellor, Tamil Nadu Medical Council. I take this opportunity to invite ASA Stat President Dr. A. Rajasekhar and Honorary Secretary, Tamil Nadu State Chapter, Dr. Balamurugan, and also have immense pleasure to invite all the ASA members, especially our Chennai City members and office bearers, Professor Dr. Vegananda Subramaniam, Professor Dr. Inda Sagayam, Dr. Sudipta Swain Kumar, and Dr. Pandya Raj, Dr. Inza. So, and all the ASA members of various, irrespective of all the branches, so really I invite you all to this program. So I have great pleasure to be present in this meeting. So today is a really special moment for all of us, because we have an opportunity to inaugurate these functions. So really thanks to the God first of all. So I really dedicate my speech to my mother. So mother is a special woman for all of us, because pampering the family as well as gratify the family, so in a great manner. So we cannot give back anything. There is no question of compensate of our affections, anything. That's why she is a visible God. That's why it's called visible God. That's one. Now another is globally we are celebrating the International Women's Day on 8th March. So tomorrow's onward, to honor the achievements of women in various fields. Certainly women have contributed significantly to the welfare of the society as well as the country subsequently. Moreover, this celebration is a sign of appreciation, respect, love and care towards the woman in our lives and in the society. It is a great responsibility to empower women. Also, it is a necessary for gender equality. The women are indeed making the world turns heads towards them. The participation of women in the most effective way to lift the community as well as companies as well as countries. They are making difference to the world around her. So another interesting thing I'm going to give according to the statistics, the women are living longer than the men. So the God showering the more blessings towards the ladies, because the ladies are affecting the diseases very less. So when you're taking the statistics, so that is one of the very great boon to the females. So thanks for giving this opportunity. Thank you, madam. Thanks a lot. Long live ASI.
Thank you, Dr. Uttar Kumar sir. It is indeed a pleasure to hear to you about the activities and the message. As the chairman of the Chennai City branch, I warmly welcome our national president, Dr. Abhay Dalvi sir, the person who inspired us and who has been all the help. And being a Sunday, she is present before us, and she is helping us to put every piece together for arranging this important meeting. Thank you, Sudha ma'am. This is more than a friend or more than a guide or mentor as a vice chancellor to help us to assemble this program. Thank you. Our heartfelt thanks on behalf of the ASI. And I also welcome all the senior faculty of the National Women's Congress. And then we also have the honor of being ably supported by the Tamil Nadu ASI, Dr. A. Rajasekhar, our chairman of the Tamil Nadu chapter, Dr. S.G. Balamurugan, the honorary secretary of the Tamil Nadu chapter, who has been always supporting us in whatever endeavors on academics or social welfare activities of the ASI in best possible way. They are all a phone call away for us, 24/7 available for making all the support for the program. Thank you, the state office bearers and the central office bearers. I warmly welcome one and all, and I also warmly welcome the surgeons and the medical practitioners who are watching through the Tamil Nadu Dr. M.G.R. Medical University YouTube channel as well as the ASI Chennai City channel. We warmly welcome to you. Thank you. Thank you for joining us today. Now I would like to invite Dr. S.G. Balamurugan, the State Honorary Secretary of the Tamil Nadu ASI chapter. Dr. Balamurugan sir, please.
Good morning to all. Am I audible?
You are good, sir. You are good to go, sir.
Good morning to all. Today is the Women's Day. Theme of the 2021 Women's Day theme, leadership in the woman. இப்போ நம்ம இந்தியாவில் ஆல்ரெடி உமன் வந்து நல்ல பொசிஷனில் இருக்காங்க. அதுக்கு ஒரு எக்ஸாம்பிள் வந்து நம்ம தமிழ்நாடு டாக்டர் எம்ஜிஆர் மெடிக்கல் யூனிவர்சிட்டியோடைய வைஸ் சான்சலர் மேடம் அவங்களுடைய லீடர்ஷிப்பில் நம்ம யூனிவர்சிட்டி நேஷனல் லெவல் இன்டர்நேஷனல் லெவலில் பெரிய சக்ஸஸ்ஃபுல்லாக போய்கிட்டு இருக்கு. அதுக்கு வந்து உமனுடைய கான்ட்ரிபியூஷன், மேடத்துடைய பிளானிங், அப்ரோச், ஸ்ட்ராட்டஜி, பப்ளிக் ரிலேஷன்ஸ் அண்டு அனலைசிஸ் அண்டு ஃபீட்பேக் எல்லாமே சேர்ந்து அவங்க ஒரு நம்ம யூனிவர்சிட்டியை உயர்ந்த நிலைமைக்கு கொண்டு வராங்க. இது வந்து ஒரு பெண் தன்னால் எந்த அளவுக்கு சாதனை பண்ண முடியும் என்பதற்கு ஒரு சிறந்த உதாரணம். இதுக்கு முன்னால் இருந்த மேடம் வைஸ் சான்சலராக லேடியாக இருந்தாங்க. இந்த மாதிரி பெண்கள் முதலமைச்சர் நம்ம ஜெயலலிதா மேடம் பெண்களுக்கு ஒரு எடுத்துக்காட்டாக இருந்தாங்க. இந்த கருத்தை பாரதியார் வந்து ஒரு கனவு கண்டார். சுதந்திரத்துக்கு முன்னால் வந்து பட்டங்கள் ஆள்வதும் சட்டங்கள் செய்வதும் பாலியல் பெண்கள் நடத்த வேண்டும். அந்த மாதிரி நிலைமை இன்று நடந்து கொண்டிருக்கிறது. இது நம்ம சமூகத்துக்கு வந்து பெண்கள் முன்னேறதும் சிறந்த இட் இஸ் பெஸ்ட் டு த நேஷன். அது நடந்துகிட்டு இருக்கு. மேலும் in this Women's Day, on behalf of ASA Tamil Nadu chapter, I wish all women to reach higher position and to participate in all endeavors. Thank you.
Bala sir, thank you very much for inspiring us to do this academic program, and thank you very much for always being there in all our academic endeavors. Thank you on behalf of the Chennai City branch. May I now have the honor of... Yes, sir.
I wish the Chennai City branch doing excellent work. I wish to continue the same in future. Thank you.
Thank you, sir. Thank you so much. May I now have the honor of inviting our state chairman, always available for us and making us the academics more stronger day by day. Can I have the honor of inviting Dr. A. Rajashekar, the chairman of the Tamil Nadu chapter of the ASI. Over to you, sir.
Good morning to all, and wish all women in your family and women surgeons a happy Women's Day. Respected Vice Chancellor of Dr. M.G.R. Medical University, Madam, President of National ASI, Dr. Abhay Dalvi, Own Secretary, Dr. Balamurugan, Dr. Chandrasekhar, the GC member and member of the Chennai City chapter, and Chennai City chapter Chairman Kanagabel, and Dr. Kannan and Dr. Uttarakumar. Thanks for organizing such a wonderful program to celebrate the Women's Day, inviting all the women. I think this is the first time. I think previously, sometime back, when a women surgeon, Dr. Sri Kumari, was there, such a program was organized. After that, so many years, this is being organized. It's a very good initiative. First and foremost, I congratulate the Chennai City chapter for organizing an excellent program. I think more than women surgeons, they should also come and get associated with the association. That is our only request. If you look at the members in our own association of Tamil Nadu chapter, there's only one lady surgeon who is the Dr. Sarada, the co-op member. So I think they are good in administration, and they should take part in association activities as well. And maybe we can think about having a separate EC membership for women specific. We can discuss. I think that is the way to take women to the next level and get actively involved. So I wish the Chennai team and the event a grand success, and I hope to take part in similar events in the future as well. Thank you. Thank you all.
A brilliant initiative of having a women exclusive executive membership in the ASI being mooted upon. I am sure this will be deliberated and made a definite possibility in the near future with the help of the state and the central ASI. Thank you, Dr. Rajshekar sir. Now I have the honor of our youthful and ever energetic always available national GC member, and incidentally is also the vice chairman of the Chennai City branch of the ASI. Can I have the honor of inviting Dr. Chandrasekhar, the national GC member, to give his address, please?
Good morning to all. We are very delighted to welcome our respectable Vice Chancellor of Tamil Nadu, Dr. M.G.R. Medical University, on this exclusive Women Surgeons Conclave. And I welcome our National President, Professor Abhay Dalvi sir, as a chief guest of this conclave. On behalf of ASI, National EC member from Tamil Nadu, I congratulate the Chennai team for organizing this wonderful academic event. This is our long time view and also one of the motto of Chennai City to create an exclusive women conclave and also women section for our ASI. I welcome all the women national EC members, senior lady faculties and students of all over India. I am very proud to say my student time chief was a woman, is a mentor, Professor Sri Kamal. In Tamil, on saying, மங்கையராய் பிறப்பதற்கு மாதவம் செய்திடல் வேண்டுமம்மா. My Women's Day wishes to all incredible women, shine on not today but every day. My salute to all. Thank you one and all, and once again I welcome to all to our exclusive Women Surgeon Conference.
Thank you, Chandrasekhar sir, and may I take the opportunity to invite our national president, professor of surgery at KM Hospital and GS State Medical College, Mumbai, and a surgeon himself who has been instrumental in creating various academic activities, inspiring us as the national head, national president of the ASI, and always student friendly, and he never says no for any academic activity or any innovative plan. In fact, when I asked for his permission, when we met in Mumbai last week, he said immediately, please go ahead. Thank you, sir. Thank you for encouraging us in all best possible way. May I have the honor of inviting Professor Abhay Dalvi, sir, the national president, to deliver his chief guest address. Over to you, sir.
Thank you, Dr. Kanakvel. I stand here on behalf of the headquarters, also on behalf of the Tamil Nadu State Chapter and Chennai City Chapter. Very good morning to all of you all on this International Women's Day, to be celebrated tomorrow, but you are doing it today. It's nice because it's a Sunday. It's a absolutely unique program. Let me go on record that out of 27,727 members, we have over 2,900 women members of the Association of Surgeons of India. I'm absolutely blessed looking at this program that three of my colleagues, Dr. Pinky Thapar, Aparna Deshpande and Shilpa Rao, all have worked with me and they are on your panel. Thank you for that. I can only say that I'm about to board an aircraft at Raipur Airport en route to Mumbai. So please excuse me for at least 1 hour and wish you all the best. It's a wonderful program. I managed to sneak into the panel discussion on safe cholecystectomy. It's going very well, and I hope that I'm able to join as soon as I land. Thank you so much. All the best.
Thank you, Professor Abhay Dalvi, sir. Thank you for coming into our program, sparing your valuable time in spite of your travel schedule. Thank you for continuing to inspire us.
Kanak, I can only say that I do not differentiate between women and men as far as any field and profession is concerned. Since I got a unit, I have been always working with females who have done excellent work, and in fact, sometimes I feel that I should, if at all I have to be operated, it should be gentle fingers of women. Thank you.
I appreciate the amount of trust and the confidence you have on the women surgeons of India, sir. I'm sure, let us together give them a platform. There are many leaders in surgery department and other medical specialties across the country and across the globe. let, on behalf of the ASA, part of the ASA, this is an opportunity for us to showcase the leadership and the expertise of the women surgeons on this forum. Thank you, Dalvi sir, for joining us this morning. Now, ladies and gentlemen, it is the most important privilege for me to welcome the Vice Chancellor of the Tamil Nadu Dr. M.G.R. Medical University, Professor Sudha Seshan. In fact, she is the ardent anatomist, academician, and she can deliberate on spirituality and Vedic verses for days together on a single-handed course schedules. She is a multifaceted person. She is always student friendly, and she always encourages us for any type of academic activities. The only discipline I have learned from her is to ensure uniformity, ensure discipline, and ensure a stress-free and protocol-based approach to any problems. With that few words, I have the honor of inviting Professor Sudha ma'am to give her inaugural address and officially declare the program open. Over to you, ma'am.
Vanakkam. Thank you very much, Dr. Kanagavel, for those lovely words. Professor Dalvi, Dr. Chandrasekhar from the National ECASI, Dr. Rajashekar, Chairman, Tamil Nadu ASI, Dr. Balamurugan, Secretary, Tamil Nadu ASI, Dr. Kanagavel and Dr. Uttarakumar from the Chennai City ASI, Dr. Kannan, the central and state office bearers of the ASI, the expert panelists from across the country, and all the participants. It's my privilege to wish everyone, both the men and the women folk, a very, very happy International Women's Day and Women's Week, which commences from tomorrow. Womanhood is special by itself. It symbolizes energy, compassion, and empathy. Operating on the basis of the same qualities is the healing heart. In other words, the medical doctor who practices the art of healing also symbolizes energy, compassion, and empathy. It is therefore very natural that these qualities expand and magnify themselves when womanhood and the healing art merge imperceptibly in a lady surgeon. Being a lady is the blessing bestowed on oneself by nature. Being a surgeon is her choice. When both these come together, the lady surgeon rises up as a beacon light. I will not be wrong if I place on record that the life of a lady surgeon is not a bed of roses, and it can never be. Much is expected out of her, professionally, socially, in the domestic front, in the official front, from her patients, and from amongst her kith and kin. Quite a lot is expected, and she is expected to stand up to all these expectations. And please note, very often she not only stands up but rises well above the boat. It is with this view of saluting such women of grit and greatness that the Tamil Nadu Dr. M.G.R. Medical University and the Association of Surgeons of India's Chennai City branch thought of a National Women Surgeons Conference to commemorate the International Women's Day. The theme of the International Women's Day this year, as announced, is women in leadership achieving an equal future in a COVID-19 world. That reminds us of the very virus that has transformed all our lives. SARS-CoV-2, the virus, has transcended all national borders. Disregarding all lines of control, the virus has crossed the district borders, state borders, all kinds of geographical borders, consequentially reducing distances. In a way, the virus has facilitated reduction of distances amongst mankind too. With the aid of technology, most of our scientific sessions, thanks to COVID-19, have become digital. Towing in line, this conference has also become hybrid, partly digital and partly physical. I am very happy that this conference is aired from the premises of this university, the Tamil Nadu Dr. M.G.R. Medical University, the first Vice Chancellor of which was a woman herself. I am confident that the proceedings and the deliberations of this unique conference would benefit not only the women surgeons, but the entire medical fraternity across the country. With that happy note and confidence, I am very glad to inaugurate this National Women Surgeons Conference, put up in commemoration of the International Women's Day of the year 2021 by the Association of Surgeons of India, Chennai City branch, under the aegis of the Tamil Nadu Dr. M.G.R. Medical University. I wish the conference all success, and I wish all the panelists and participants a very happy learning session. All the best, and thank you very much.
Awesome. Thank you, madam. Thank you for staying with us and supporting all our academic endeavors. And we look forward for more important and more international collaborations as well in the near future. May I now have the honor of inviting our dynamic treasurer of the Chennai City branch of the ASI, Dr. R. Kannan, to propose a formal vote of thanks.
Thank you, Dr. Kanagavel, the chairman of Chennai City branch. On behalf of Surgical Fraternity of Chennai City branch and ASI Tamil Nadu chapter, our heartfelt thanks to the Vice Chancellor of the Tamil Nadu Dr. M.G.R. Medical University, Professor Sudha Seshayan Madam, who inaugurated this unique day-long National Women Conference for the sake of women surgeons and as well as the World Women Surgeons Day. We once again thank you, ma'am, for this. Actually, it is an honor to us to inaugurate this session, especially by you, ma'am. Our special thanks to Professor Abhay Dalbe, the National President of Association of Surgeons of India, who graced the occasion as a chief guest of this conference. On behalf of Chennai City ASI branch, we extend our warm thanks to Dr. Rajshekaran, Chairman of Tamil Nadu ASI, Dr. Balamurugan, Honorary Secretary of Tamil Nadu ASI, Dr. Chandrasekhar, National GC Member and as well as Vice Chairman of the Chennai City branch, Dr. Uttarakumar, Honorary Secretary of Chennai City branch, and Dr. Pandi Raja, EC Member of Chennai City branch, and all other office bearers. I thank all the senior eminent faculties who are all part of this program, and they are sharing their experience and as well as knowledge in the sake of the younger colleagues and as well as the other budding surgeons and as well as the eminent surgeons all over the country to exchange their knowledge for their experience and as well as this Women Day conference. And my special thanks to Professor Sri Kumari Thamaram, my professor and as well as the mentor. Madam immediately accepts our invitation and grace the occasion. And also I extend my thanks to all the delegates who are online and offline, who are participating in this program, without whom this could not be a successful one. And our sincere thanks to Mr. Sundar Kumar and as well as his team, the Cool Events Private Limited, for their extended support, the help, logistic support, and as well as coordination and communication for this conference. And Madam, once again, we thank you for your extended support all the time, and as well as inaugurating this Women Surgeons Conference, and freely you have facilitated the venue and as well as logistic. Thank you once again.
Thank you, Dr. Kannan. I think we have just saved 1 minute on the inauguration front. So, thank you all the senior leaders, especially the national and the state leaders. With your permission of the national and state leadership, we pursue with the academic activity. Can I have the honor of requesting Durga ma'am to please share her the PowerPoint and continue the laparoscopic safe cholecystectomy panel discussion. Over to you, Durga ma'am.
Okay.
Yes, madam, you are up and on, and you have all the faculty with us. Please continue, ma'am.
Before we continue with this, I would like to compliment Madam Vice Chancellor. Beautiful speech she gave, very inspiring, and thank you, ma'am.
Thank you very much. Thank you, ma'am. I'm enjoying your session. Thank you. Learning a lot.
So, coming back to you, Satyapriya, let us continue with you only.
Yes.
Madam,
are you there?
We are able to see your PowerPoint. You please continue. All the panelists are available to take your questions, madam.
No, Radha and Kanchana, I think they are not there.
Madam, Dr. Radha has some challenges. Our event management team is helping her to get back online. Unfortunately, Madam Kanchana is in a rural village where she has some challenges mechanically. Please go ahead, madam,
so
as they join. Yes, madam.
You just inform me.
Yes, madam.
And so far, my three beauties are doing perfectly well. Satyapriya, this is for you. Injuries due to energy sources. We have to buck up. You have so much.
Yeah, this is very important while doing a laparoscopic cholecystectomy, because we use a lot of energy sources during cholecystectomy. And one important thing is lack of insulation. So we have to be very careful before introducing the instrument, because we have to check each and every time while introducing the instrument into the trocar, right? Because this insulation can be lost because of excessive use of reusable instruments. Even though we are using reusable instruments, as we are using for many times, so you have to be very careful. So this lack of insulation can occur because of excessive into the trocars. That also causes insulation damage. So we used to remove and insert it again. So this happens many times during our surgery. So repetitive introduction of instrument into the trocar also can cause lack of insulation. So we have to be very careful. Each and every time we have to be careful, and whenever we apply energy source, it should be under our vision. So it's better to apply energy source under vision, complete vision. And then frequent sterilization, mechanical sterilization also can cause loss of insulation. So you have to be careful about it. And regarding this coupling, so whenever this happens many times without our knowledge, because there can be a trocar like 10 mm trocar which is in the epigastric port, can be very close to the energy source. So coupling current can occur, and injury to the adjacent structure can occur. And capacitance, here again it's better to use a metal study. Many studies says that it's better to use metallic trocars rather than plastic trocars to reduce the capacitance current, because it affects only the skin. It is transmitted to the skin or not to the internal organs. And regarding this bowel injuries, so this can be evident many times. It can be evident only after a few days of injury. So we have to be very careful regarding this, and we have to observe the patient for 2 to 3 days later also, because many times injury to the bowel occurs a little later, but duodenal translateral injury, lateral passage of current can occur and cause damage to the duodenum. And this we have to have a suspicion if the patient develops any symptoms and signs of perforation or injury, bowel injury.
Thank you, Satya. Thank you. And Satya, there is one more question for you. The gallbladder extraction also can have some challenges?
Yes, definitely it can be. So many times the gallbladder wall is very thick, and if it contains multiple gallstones, it will be very difficult to remove the gallbladder. So I always do it with an endo bag, which is safer, because it will prevent the spillage of the stones also. So at one instance, I had an experience of converting to open to remove the spilled stones. So which is not good to know. So we always use endo bag to remove the gallbladder to prevent gallbladder injury, tear of the gallbladder, and leaking, and spillage of the bile as well as the stones. And
Beautiful,
epigastric port, many times we need to extend epigastric port incision. Even though we introduce a 10 mm port, we need to extend a little more, just 1 or 2 millimeters more to extract the thickened gallbladder with multiple stones.
Done. There is stay on. There is small thing more. While closing the port, what precautions? Like you said, you extend the incision. So what routinely you do, or only required whenever?
I always have the habit of closing the 10 mm port, umbilical and the epigastric
Hello.
port. The other 5 mm ports needn't have to be closed. Just addition is enough. But 10 mm port, I feel it has to be closed.
Yes, that I think will. Now coming back to Pinky, few words about this Tokyo 2018 guidelines for the safe cholecystectomy during acute cholecystitis. I know you have done lots of work in this field. I want to show your experiences, elaborate on this.
Yeah, basically Tokyo 2007, then Tokyo 2013, and later came 2018. But way before the 2018 was published, we already were doing these steps, but we failed to publish it in time. So actually in India, I think we all are following these steps. Many of us are following it. And it is just our inertia or lack of publication, we delay our publications. So I have been following Tokyo guidelines since 2007, and I've adopted the steps of doing these, doing the surgeries as per the guidelines, and it has really helped me. It has really helped the patients, I would say, to avoid any injuries. So what is Tokyo guidelines? It basically, when a patient comes to you, we have to disintegrate the patient into 3 categories, whether it is a mild grade of acute cholecystitis, moderate grade, or severe grade. So mild means a mild attack of acute cholecystitis, which does not add an added risk to the surgery from the patient's point of view, from the comorbid conditions, and the patient's condition is good. He's safe. It's like a mucosal gallbladder without severe sepsis, without any local complications. So that is mild or Tokyo 1. Then comes moderate category. If you have a patient who has come to you after 3 to 4 days of attack with a palpable lump, tender lump, or if the WBC count is more than 18,000, or if on sonography you have changes of gangrenous cholecystitis, perforated gallbladder, empyema gallbladder full of pus, such patients fall in the category of moderate category, where they do not have an organ failure, but they have a local complication, significant local complication like emphysematous cholecystitis. All such cases are clubbed into moderate category. So if I have a patient coming in the 2nd week of attack with a local complication, you know it's a moderate category, it's a anticipated difficult. Why these guidelines are helpful? To anticipate us that this is a difficult gallbladder. So we should be ready with all the steps to be dealing these cases safely. Then comes a patient who comes in the ICU with acute septic shock or with acute kidney injury requiring ventilatory support, or with thrombocytopenia, sepsis. Such patients fall in the category of severe category, and they are called Tokyo 3 classification. So these patients have an added organ failure. In such patients, if the patient is unfit for surgery at that time, the best approach is to put a sonography or a CT guided percutaneous cholecystectomy. This saves the patient because it drains the pus out. But again, this is possible if a patient has an over-distended or a thick-walled gallbladder. If a patient does not have a thick-walled gallbladder, does not have a distended gallbladder, I mean to say, shriveled gallbladder, then we cannot do this procedure. Then we have to resort to conservative approach if patient is unfit for surgery. But if the patient is fit to withstand the general anesthesia, go ahead and do. In our series, we have done upfront lap cholecystectomy in 64% of patients of even severe cholecystitis. So that, I think once you formulate the guidelines and the SOPs, then it becomes easier to operate these cases because the whole team is geared up. Whole team has only one goal, to do a safe cholecystectomy. So even the technician, even the nurse, everybody is geared up. If this is anticipated difficulty, we have to keep things ready. So Tokyo guidelines help us to plan the cases. So those who are not following it, I would say they should start doing it. It helps.
Madam.
Okay, Pinky, those old theory of waiting for 6 weeks all gone out of window?
Madam,
Almost,
we have
madam.
Professor Radha Verma also joined up today. We can take
Oh,
her.
that's great, Radha. Welcome, welcome. Okay, Pinky, thank you very much.
Sure, madam.
So to summarize what we discussed so far, so I just go through. Thorough knowledge of relevant anatomy and various anatomical landmarks and anatomical variations are a must for any safe cholecystectomy. Any understanding of mechanisms involved in the biliary and vascular injuries, most important. And of course, avoid misidentification. Identification of various preoperative and intraoperative predictors of difficult cholecystectomy is a must. A proper gallbladder retraction, so we always give to the first year PG this. This is not so easy. Safe use of various energy devices, most important. Understanding the critical view of safety, which we have already discussed at length. Awareness of various error traps like fundus first technique, until unless you know it properly, otherwise you will be pulling the CBD towards. Use of various bailout strategies. What are they? Subtotal cholecystectomy of various kinds, or sometimes converting to open. Should not feel ashamed of converting. Use of intraoperative imaging techniques, or taking this ICG is used more frequently now, and it is causing less injuries. I think this is a study showing, and the results will come out very soon. Understanding the concept of timeout. If you are tired, if you are not proceeding, ask for help, take a break. So now we have to go through some case scenarios because we are having how much time? 15 minutes. Okay. So Professor Radha Verma is around. Professor Radha? Is Professor Radha around?
Madam, Radha ma'am, please unmute yourself, ma'am. Madam is with us, Durga ma'am.
Okay, Radha ma'am. Hello, hi, welcome, good morning. Okay, I think still some glitches are there. I ask Rekha to come on the board. Rekha, Rekha, this is your case. Rekha?
Madam, Radha
Yes,
madam
ma'am.
is with.
I think Dr. Radha just came online, ma'am.
Okay. Professor Radha, we are waiting for you.
Morning, madam. Hello, can you see me?
Yes, yes, I can see you. Okay,
Yeah,
Radha.
good morning, and good morning, and I'm really honored to be on the panel, and I congratulate Tamil Nadu for such a wonderful event. Thank you for honoring women and celebrating women.
Yes, this is the feeling everybody is sharing, including me. Okay, Radha, this is your case. Intraoperatively, to find empyema gallbladder with thick walls, and you are not able to hold or grasp the fundus of the gallbladder. What you will do now?
Ma'am, we can use a traumatic forceps and we can aspirate this gallbladder in order to make it more so that we can hold it much better. Aspirate the pus. And then the dissection might become a bit better. easier. Because whatever that gallbladder which I can see, which was put on that PPT, so it is, there are not many additions. But if you put a trocar and if you aspirate it with a thick needle and then try to hold it, go ahead with the dissection.
Fine.
Is there anything, Pinky, is there anything you want to add along with this?
Pinky, you want to add?
Change the grasper to and aspirate the contents as much as possible.
Yes, absolutely.
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 And Rekha, you want to add something on this?
Bring the gallbladder near to the anterior abdominal wall, aspirate with the aspirating needle, and then try to hold the gallbladder. The picture I saw did not show a lot of additions. Once it is aspirated, and I think you can go ahead with the lap cooling.
Okay. Rekha, would you like to add anything on this?
Yes, ma'am. There are two things. One, when we are aspirating, we have to be sure that we don't end up losing the stone. Very often in a thickened gallbladder, when you grasp it, you find that the wall is end up having spillage happening. So whatever instruments that we're using don't get a good catch of the wall. So sometimes we are forced to use a tooth instrument, and that adds to the trauma. So sometimes what we like to do is through the abdominal wall, we try to put in a needle and aspirate rather than making a hole with a forceps or a suction cannula. Sometimes this helps.
Okay, thank you, Rekha. Thank you. The second scenario. There's something wrong. What happened?
I think the second one was
Yeah, the Keller's triangle is completely frozen and you are not able to proceed despite 45 minutes of action. What are the options? Pinky.
I would try hydrodissection in this case, and again have a panoramic view, then close-up view. Go with a suction cannula, 5 mm suction cannula through epigastric port. Try to lift off the gallbladder from the fossa at the point over here, and do a hydrodissection. When we infiltrate saline, it opens up the planes. If in spite of doing that, we are not getting the vision by going clockwise, anti-clockwise, we are not getting the encirclement of the critical view of safety, then I would go for a fundus first method in such a case where we are not able to proceed to achieve a critical view of safety. So first hydrodissection, going clockwise, then anti-clockwise, and then fundus first if it is not proceeding further.
Radha, you want to add something on Pinky?
I was just asking if she would go for fundus first. That's what she responded. If not,
Okay.
then fundus first.
Okay. Now third.
Would you do a partial cholecystectomy in this case? Pinky?
Actually, most of the cases we can do a complete cholecystectomy in such cases also. Once we reach the near the neck of the gallbladder, suppose we can't, we have to milk the contents out, remove the stone from here. That's very important. I have seen couple of patients who have come back with a residual stump cholecystitis because of incomplete removal of gallbladder. So that shouldn't happen. We have to go. This here it looks. This is the bile duct. So we know this is the neck of the gallbladder. So we can proceed safely.
Would you consider opening the patient? At any point would you consider? At any point would you consider opening?
Opening, I will not consider in this case.
Converting?
No. Not in this case.
Once you get the critical view of safety, there is no need of conversion. Conversion is not an option.
Yes.
Okay. Next, Rekha, are you ready?
Yes,
My computer is troubling me, right? Yes. This is a thick walled gallbladder with colon and stomach added to the gallbladder in a 65-year-old female. There are also multiple periportal lymph nodes. How will you proceed? What is your suspicion on this?
So the moment you're having a thick gallbladder, there are two possibilities that we think of. One is obviously carcinoma gallbladder and a chronic cholecystitis. This is further substantiated by the fact that I'm having multiple periportal lymph nodes that points me towards a diagnosis of a carcinoma gallbladder. Now, whenever we're thinking in terms of carcinoma gallbladder, you find that there are two options. One, proceed with a radical cholecystectomy if it is possible. But obviously in this case, given the fact that it is adherent to the colon and the stomach, we're talking about a T4, a T3, probably with invasion of the vessel, which we're not able to see it from this angle. The fact that the nodes are periportal also indicate it is metastatic. At the moment it is going toward the superior pancreaticoduodenal, you find that those lymph nodes now become N2, even considered metastatic by some studies. So in this particular case, we wouldn't be attempting a radical cholecystectomy in this patient. But the question that we actually have to address is that sometimes we do not have this knowledge preoperatively, and we go in, we think it is a routine cholecystectomy, and then we find that it is adherent and there is a suspicion. There are two options. One, if we have the facilities to go ahead with radical cholecystectomy, we can, provided the center is geared for doing resection of that tumor bed. The point to remember here is that there is no serosa on the gallbladder, so just doing a simple cholecystectomy is not considered radical. We need to go ahead and do some amount of resection. So one can do it laparoscopically itself if we have the expertise and we have the backup. Point two, you find that if we're thinking it is, say, gallbladder, there is no harm in closing and referring to a higher center. All right, you find that if we think that this patient can benefit by a flap cholecystectomy by a surgeon who has the expertise, that is something to be considered as well. Third option, you find that if we feel that we can't do it laparoscopically, but can do a radical cholecystectomy by an open procedure, you could still go ahead and do it. Option four, you've done a simple cholecystectomy thinking it's just a routine GP. But you find on the histopath report, we have a diagnosis of malignancy. It's important to go back and do a re-resection of the GB bed. These would be the take-home points as far as carcinoma of the gallbladder is concerned.
Ma'am, what is the role of closing section in this case?
We routinely can do within aspiration. You can do an FNAC and go ahead and do it. But you find that like we have in this particular case, you have nodes, you see it is adherent, you know that there is no difficulty in making a diagnosis. The challenge would be when on the serosal surface, everything looks normal and you have a histopath report. But yes, role for laparoscopic guided FNAC is there. You can also do endoscopic ultrasound as well to stage the disease.
Okay, Rekha, we have many more cases. I think we have to buck up. This is the case for Pinky. Are you there, Pinky?
Yes, madam.
This is while doing a difficult case, you find a bile leak. I think this is very close to your heart. And you see 0.5 centimeter rent at the junction of cystic duct and CBD. What are the options now?
If we are well versed with suturing of the bile duct, I would like to put a T-tube over here and suture the bile duct. I would not wait for a drain to come and then later on do ERCP. Since we have identified on table, we have to do a thorough job on table. So since it was a difficult scenario, the bile duct rent will not suture primarily without leak. So best is to divert the bile, put a T-tube laparoscopically and put a wide bore drain in the porta. So most likely nothing will happen later on. We won't require to go for a ERCP or anything later on. But if we just primarily suture it without putting on T-tube, the patient may leak because it is a complex gallbladder, then may land up with doing ERCP post-operatively, which I think we can avoid if we do tackle the situation on table.
On table. It's always better to tackle. Thank you, Pinky. Thank you very much.
Thank you.
And Satyapriya, this is the case for you. You encounter a gallbladder filled with multiple calculi and the dilated CBD. Preoperatively, the patient's alkaline phosphatase was also on the higher side. What should be done now? Satyapriya.
Yeah, this should have been a pre-op diagnosis. That we should have diagnosed preoperatively about the dilatation of the CBD, and we need to exclude whether the patient has got multiple stones in the CBD also. And then in this patient, I think we should have done ERCP PR preoperatively, and we should have cleared the stones in the CBD and then proceed with cholecystectomy.
That was in the ideal situation. This situation, what you will do?
So we can still proceed with lap cholecystectomy with T-tube placement in the CBD if we are not very sure about the clearance of the CBD.
Okay.
Could I chip in there, ma'am?
Okay, you're done with? Rekha, you want to say something? We are running short of time. Say fast, 1 minute.
Yeah. If we have facility, we can put in a choledocoscope into the duct at that point in time and have a look what's happening inside. If we don't have a choledocoscope and our urology colleagues are available, we can request their services to take a look inside the TNMGR.
I was thinking of the same choledocoscope.
Okay. This is also for you, Satyapriya. A 32-year-old male for lap cholecystectomy. Intraoperatively, you find nasal, mild ascites, large cavernomas at bottom.
Yes.
What do you think it is?
Yeah, this again should have been diagnosed preoperatively, cirrhosis, portal hypertension with gallstone. So preoperatively, we should have optimized the patient, and then we should have hydrated the patient well, vitamin K, correct the coagulation profile. We could have given. We should give vitamin K if necessary. We should have given FFP also preoperatively. And then optimizing the patient. If really there's an indication for lap cholecystectomy, we should have optimized this patient preoperatively itself. And this should not be a surgical surprise during our lap cholecystectomy. This should not be a surgical surprise because this has to be diagnosed preoperatively. Intraoperatively, we have to be very careful, meticulous. We still can proceed with lap cholecystectomy because it was 30 years back. It was a relative and absolute contraindication. Cirrhosis and portal hypertension was a absolute contraindication, but nowadays it's not so. We still with the use of energy devices, we can still proceed with laparoscopic cholecystectomy. Only thing is we have to be very meticulous and we need to use a liberal usage of electrical source. And another thing is we have to use much of bipolar diathermy rather than using a monopolar diathermy. And then we have to be very careful. If there is multiple collateral veins, that has to be ligated between clips, not with diathermy alone. And another clue is we have to stay closer to the gallbladder rather than towards the liver bed. So bleeding is the dreadful complication which can occur during surgery. So we have to be very careful. Liberal use of electrical source is one of the key point in doing a safe lap cholecystectomy in this particular patient. So no more is it's a contraindication. No more is a contraindication for lap cholecystectomy. And
preoperative.
One more thing we should have assessed if it's going to be CTP 1 child scoring. If it's going to be class A, it's not going to be very difficult. Only class C we will have much difficulties in proceeding with lap. And I feel lap cholecystectomy is more easier than an open cholecystectomy because of the magnifying view of the veins.
Okay. Thank you, Satyapriya. Very well done. So, at the end of the day, it is a preoperative diagnosis more important rather than a surgical surprise on the table. Yeah?
But if you are in a peripheral hospital, you are in an institute, and we find a situation on table, we have not picked up pre-op. Best is to abandon the procedure if you don't have a good energy source. So that should be the message for people who are not having an institutional backup or do not have an energy source. Secondly, as Madam said, it is very close to the gallbladder, but if possible, leave the gallbladder wall attached to the liver. If it is densely adhered, rather than causing bleeding.
So, thank you. And there will be many more possibilities and scenarios. There is no end because gallbladder is surgery most common and full of surprises. So these scenarios will keep on demanding, developing, but we have to decide on the table and do the correct thing at the correct time. So I'm really grateful to all my panelists. They are really enlightened me thoroughly. And I'm thankful to all the panelists. Now I hand over the mic to Madam Sri Kumari for her final comments.
Hello, ma'am.
Yeah. Now, thank you very much for having organized a very nice panel. And
Can't hear. I can't hear.
Hello.
Oh, there's a difficulty in the hearing.
Submission, madam, system, madam. Please go ahead, madam.
I think Madam Sri Kumari has got some mic problems. Beginning also there was a problem.
Hello, ma'am.
Madam, please use any one system, madam. Madam.
yes.
Madam, please off any one. Please use any one system, madam. Off the mobile phone. Madam. Switch off the mobile phone and use the system or use the system only.
Nothing else. Only my laptop.
Okay, madam. Durga, madam, please go ahead, madam. Please go ahead, madam. And
I request Dr. Kanakavenu to sum up, or as well my good friend Chandrasekhar, you please sum up on
yes, madam,
the whole
please.
proceedings.
Okay, madam, please. Madam, please finish it, madam, and tell thanks to each and every moderator, madam. Thanks to our C.K. Durga, madam, is a very active national EC woman surgeon. Thanks to all are coming and sharing your thoughts, and they helpful and very useful to all our postgraduates and all our teaching faculties in all over India, madam. Thanks to all the panelists and moderator. Thanks to.
Thank you.
Durga ma'am, I put on record that I took the liberty of calling your phone and inviting you, and you have been gracious in accepting our invitation on behalf of the Chennai ASI. I'm sure Chennai ASI look forward for more academic collaborations with you, Delhi chapter, and the entire national faculty for other programs as well. Now I formally thank the faculty members for this session. Professor Sri Kumari Damodaram, our teacher of teachers and one of the first surgical gastroenterologists of the country, and who's been instrumental in setting up many units of surgical gastroenterology in our state and has been the Dean of the ESI Medical College. I thank the moderator, Professor C.K. Durga Madam from the Dr. Ram Manohar Lohia Hospital, New Delhi, for brilliant moderation and covering up on various issues of safe cholecystectomy. There have been some challenges for the faculty to join us, but in spite of that, Professor Radha Ma'am could join at a little late, but thank you, Radha Ma'am, for sharing your expertise. Thank you, Dr. Pinky Ma'am. Pinky Ma'am is always energetic and always willing to share, and we are very happy to have you amidst us, Madam, to listen to you this morning. And our own state professors, Professor Rekha Madam and Professor Satyapriya Ma'am, who has been always one among us. So they've been very kind enough to be part of it. In fact, Satyapriya ma'am was the first to arrive in the university campus for the hybrid physical session. Thank you, Satyapriya ma'am. Thank you, Rekha ma'am, for joining us on all endeavors. With this, I call this session a close, and I now welcome the next session for the day. May I now have the honor of calling up the next session chairperson. Other faculty can remain in the WebEx. May I now have the honor of inviting Professor Kona Lakshmi Kumari Madam for the laparoscopic groin hernia meeting.
Hello.
Hello. Madam, please, it's
Good
our
morning,
privilege to
everyone.
welcome Dr. Kona X. Lakshmi Kumari Madam, the Senior Consultant Surgical Gastroenterologist and Minimal SS GA Surgeon and Bariatric Surgeon. She has a keen interest in research and academic and enjoy the mentoring the beginners of minimal SS surgery. She held the position of Vice President of IAGS, and she performed more than the 25,000 minimal SS surgery and 1,000 bariatric surgery and more number of single incision scarless bariatric surgery in AP and Telangana. We welcome our madam to moderate all the session. Thank you, madam. Welcome, madam, please.
Thank you. I first thank the organizers of this Women Surgeons Meet on the occasion of World Women's Day. And I would wish a very happy Women's Day to every lady, not only surgeon, but everyone who is done so much for the society and the world. And we will start this panel discussion on groin hernias. I have with me Dr. Anjali Davle, who is from Nanded, and she's doing a lot of good surgical work in Nanded. I visited her place also. It's very great. I have Dr. Meenakshi Sharma. Is she there?
Yes, I am. Good morning.
Meenakshi, good morning. Paras Hospital, surgeon from Paras Hospital, Gurgaon. And then who else have joined? Do we have the other panelists?
Madam, we have Professor Dr. Meenakshi Sharma ma'am from Paras Hospital. Madam is already with us. Professor Kalevani madam, he is the chairman of the Bangalore City chapter of the ASI. Kalevani madam is from MS Ramaya Medical College. And we have our Dr. Jacqueline. Sister Jacqueline is from Deep South Rural Hospital, Leonard Hospital from Dindikkal. And we have Professor Usha Rani Ratnam, the Professor of Surgery from the ESA Bengaluru. All of them are available with us, madam. Please carry on with your panel. Thank you.
Yes. So, I will say hello to all the panelists because this is a hybrid conference. We are not able to see face to face. But I would welcome all the panelists and the moderators for this session. And then we would start. Groin hernia is a very common surgical problem, and now minimal access surgery. Lot of people are opting for minimal access way of management.
You are muted. Dr. Lakshmi, you are muted.
Please unmute yourself and
Okay,
speak,
okay.
madam. I request
So
the
can
other
you hear me?
panelists to keep you muted.
Yeah.
Yeah, so we are also seeing a lot of ladies coming with groin hernia. So I would, and it's a very important topic. So I think we will start the session. So,
Good morning, Dr. Lakshmi, and good morning to all the other panelists too. This is Kalayani from Ramaya Medical College.
yeah, so Anjali will be
Yes. Can I share the screen? Am I audible, Dr. Lakshmi? Okay.
Yes.
So I will start sharing the screen. Is it seen, Dr. Lakshmi?
No,
not yet. It's not been shared still. Good morning, Dr. Kanadil sir, and good morning to the other organizers.
think have Durga madam, have you stopped sharing the screen?
Madam, if you have any challenge, you please WhatsApp me the PowerPoint, ma'am. We can show from our side.
Optimized. Okay, okay.
Ma'am,
Now is it seen?
Yes, we can.
Are you able to see it, Dr. Lakshmi?
Madam, we are able to see your slides, ma'am.
Okay, okay. Am I audible clearly?
Perfectly, madam. Perfectly. Please take over.
Yeah, yeah. Good morning, all and everybody. On this special day of International Women's Day celebration, I welcome you all. It is said that a woman with a voice is by definition a strong woman. So on this very special morning, in association with the Tamil Nadu University and the Chennai State Chapter, I welcome you all. So, ladies and gentlemen, before I begin with this event, I have to mention that the chief guest of today's program, our eminent professor from Maharashtra, Dr. Abhay Dalvi sir, today's Chancellor of Tamil Nadu University, Dr. Mrs. Sudha, Professor G. Kumar, the Secretary of the ASI Chennai City, Dr. Professor Kanagavel, who is the Chairman of ASI Chennai City Chapter, all the office bearers of the Chennai and the Tamil Nadu State Chapter. I am very thankful on behalf of my panel for giving this special opportunity. And to begin with, our today's topic is groin hernia. As Dr. Professor Kanagavel has requested me that you have to go with the basic motto of informing or motivating the most of the people to have their
we lost your audio, Anjali.
Okay, okay. I think with this, we should give a clear message that many of us should go with the laparoscopic groin hernia repair. As with the ages, when we were a medical student, the open hernia repair was a standard of care. But with the moving concept of the minimal invasive surgery, in a lot of big ways, the groin hernia surgery has taken up by the laparoscopic repair. So on this special day, it has been said that anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young, and the greatest thing in life is to keep your mind young. So all the young and lovely ladies, go ahead, we will move ahead.
Anjali ma'am,
Now,
I have a request, madam.
Of this today's our groin hernia repair, the very much important is groin hernia or the anatomy of the laparoscopic hernia repair.
Madam,
now, I request my esteemed panel. In the esteemed panel, Dr. Lakshmi Konakumari is known to all, and she is doing a wonderful minimal invasive fellowship director at Hyderabad. Dr. Meenakshi Sharma, who is at Gurgaon and doing excellent.
Madam Anjali. Madam Anjali, can I request you to make it to full screen, madam?
Okay, okay.
Thank you, madam. Thank you. Over to you.
Okay. Yes, yes.
Madam, you please go to the slideshow on the top, madam. It is the sixth thing in the slideshow. You just click on it, it goes to the full screen, ma'am.
It is actually because of this Cisco WebEx actually.
Ma'am, on the left upper corner, you have File, Edit, View. On that row, you have the slideshow on the left top, madam. Top, madam. Top, madam. Over the upper end, left upper end. Yes, madam. The sixth one is the slideshow. If you slide over, keep coming. Yes, madam. Next one, yes, madam. Yes, madam. Yes. The first one, madam. please cancel, madam. Cancel. Yes, madam, you can press OK here also. Yes, please go ahead.
Just a minute.
Take your time, madam. Above, madam. First one, madam. First one. First one. Above. Yes, yes. Thank you. And you are good to go, madam. All yours.
Thank you so much, sir. Now, before we begin with the laparoscopic discussion of the groin hernia, the most important thing is how we could see the anatomy from the tap or tape perspective. So, my first question in the panel to Dr. Meenakshi Sharma, that madam, how do you look at the anatomical perspective of the open hernia which we have been seen through the ages together, and what is the difference to look as a laparoscopic anatomist to begin with a laparoscopic hernia repair? Dr. Meenakshi Sharma.
Yes, thank you, Dr. So let me just state what is important in endoscopic hernia repair. The first thing is that the open anatomy is very different from the endo hernia anatomy. So your entire perspective is changing. When you go inside the peritoneum, you are looking at it posteriorly. So while in an open hernia repair, you are looking at it anteriorly. So you need to learn your anatomical landmarks for the endo hernia repair, whether it is TAPP or TEP. So the ligaments, the vascular landmarks, the bony landmarks, everything has to be learned. So as is seen in this diagram, which is a very important diagram for the endo hernia repair, we need to begin with the medial and lateral umbilical ligaments. We need to learn our bony landmarks. For example, in TAPP, we need to learn how to raise the flap. So where to begin it from? So anterior superior iliac spine. Then the lighthouse of the endo hernia repair, which is the pubic symphysis. So how to identify that? Then we come to the iliopubic tract, the Cooper's ligament, the lacunar ligament. And remember, we are looking at it from a different view. So this is what is important about the endo hernia repair, that the entire view changes. We are going in a different view posteriorly, and we need to also learn the importance of the vascular triangles there, the triangle of doom, the nerve supply, the various nerves. You can see very clearly. Now as you move from medial to lateral, what are you going to view? We are going to view the inferior epigastric vessels. You are also coming across the internal iliac, and how to avoid the vessels and how to make sure that you don't injure any of the nerves lying laterally. So why it is very important to identify the iliopubic tract is that any tacking has to be done above that. I think, Anjali, are you muted?
Yes. Now, as rightly said by Dr. Meenakshi Sharma, that the important anatomical landmarks are very much important, and always remember that you don't have to touch below the iliopubic tract. That is important. And I must say on this special occasion that a woman routinely looks different, but you cannot believe that the same woman looks different on her marriage day. That is the message, that in an open inguinal hernia and in an anatomical or a laparoscopic anatomy is totally different from one and all, if you agree with me. Now our next, it's not moving actually. Now, looking at the current concept, that what is the lifetime risk of developing inguinal hernia and what is actually the recurrence rate and all. I asked to the each of the panelists here that many of the ladies, there are different perspective or the different working modalities. Meenakshi is working in a corporate sector, Lakshmi Konakumari is working in a bigger sector, other rest of the panelists, they are working in medical college, one is working in the rural area. So what is the percentage of presenting a male groin hernia at your routine practice? Please, I will request to comment Dr. Usha Kumari, Usha Rani. that what is the percentage of the male inguinal hernia that you operate within a year or within a month? Am I audible, Dr. Usha Rani? Okay, if she's... Hello? If she is muted, I think Dr. Kalaniveni, Dr. Professor Madam, can you address?
Yeah, Dr. Anjali and Dr. Kalaivani, thank you. Now that being in a medical, I work in a medical college, and we do see, I mean, the inguinal hernia is a commonest surgery performed in all medical colleges. I hope the other panelists will agree with me. And since it is like a PV, basically. Basically, a PV has to learn from this. So what happens, the number of cases that present to us are almost every day minimum of 1 or 2 cases. Means every day we do 1 or 2 cases, definitely. But those number of cases will be divided because of postgraduate also learn an open surgery, and then the consultants will try to do the laparoscopic surgery. So we have a good number of cases, and we can do a good number of cases both open and laparoscopic surgery.
Okay.
So I think, yeah.
Good. Okay. So what about Dr. Jacqueline? Dr. Jacqueline, is she there?
Dr. Jacqueline is with us, madam.
Yes. Please comment. Being a female surgeon practicing in a rural interior area, what is the percentage of your male groin hernia surgeries? Or overall, what is the percentage?
Percentage wise as a whole, out of 100, maybe 90, around 90% of the hernia repair is done for the male patient, and even 99, only 1% of the women, 1 or 2% of the women are diagnosed to have a hernia, and so it's almost 1:90, 99.
Okay. Dr. Lakshmi Gona Kumari?
Yeah, hi. Yes, similarly, like Dr. Jacqueline said, majority of the hernias are community groin hernias, and maybe around less than 1% would be groin hernia.
Okay. So wonderful. So it is clear and loud that the maximum percentage of the groin hernia patients are male patients, and very minimal percentage of patients are female patients. Now, before we begin to think about operating a inguinal hernia in a laparoscopic setup, there is a definitive role of how your OT should be, what is the lie of the patient, how will you select the patient. So in such scenario, what is advice of the panel? I will request, is Dr. Nagalakshmi has logged in? Dr. Nagalakshmi madam? Has she logged in? Okay. If she has not logged in, again I will request Dr. Kalaiveni madam to say something about this OT setup and lie of the patient. Madam.
Yeah, thank you, Dr. Anjali again. The patient will be in supine position with the hands being tucked by the sides, and as shown in this slide here, we usually keep the camera at the leg edge, and we either stand on this side of the shoulder, or preferably behind the head of the patient. So especially if it is bilateral hernia.
Okay.
See, we have some little difficulty because probably our hands are a little shorter. So we have little difficulty. So I prefer standing on the other side of the shoulder.
Okay. So this is very, very important. Anything you would like to add, Dr. Meenakshi Sharma, to this?
No, basically, that is how it should be. So, one should always be open to evolving a little bit in case you need to adjust a little bit. So, as I can see in your OT setup, is it S for surgeon, right? And C?
Yeah. S for surgeon and SN for the staff nurse.
So my setup goes basically like I am on the opposite side of the hernia. So for a left-sided hernia, I'm on that side. My camera person is either to the opposite side of me or is standing behind me at times. So I try to evolve according to the ergonomics present in that particular patient. The staff nurse, of course, the monitor lies at the foot end of the patient, and the staff nurse is standing on the side of the camera assistant. Anjali, you're muted.
So, ladies and gentlemen, it is utmost important that the layout in the OT and where you are going to stand for which side hernia is very, very important. Now, my next question will be, as we are going ahead, as I think it's repeatedly getting held up. My next question to the panel is, now before we go inside, what is your take home on the sterilization of the equipments? One by one, please answer. I will request Dr. Usha Rani to say how will you go for the sterilization, starting from the camera, then telescope, then light source, then the battery cables and the hand instrument. How will you go with it, Dr. Usha Rani?
Hello, ma'am. Good morning.
Yeah.
Usually the camera is sterilized with hypochlorite solution. It is already ready on the table. We go ahead with the.
Yes, go ahead.
Hello?
Yeah, you are audible. Dr. Usha Rani, you are audible.
Yeah. So we clean up the camera with sterile.
We have lost your voice. Dr. Usha Rani, we have lost your voice.
Hello?
Yeah. Dr. Usha Rani?
Yes, ma'am. Can you hear me?
Yeah. Now I can hear you. Go ahead.
Yeah.
Okay. So in this, I will ask the same question to Dr. Professor Kalaivani Madam, that how do you go for this camera, telescope to the energy source devices? What is the mode of sterilization in a government setup? You are muted, madam. You are muted.
I'm sorry. Yeah, ours is a private hospital and we have almost all the facilities, and our mode of sterilization is autoclave. We autoclave every day. We have a very good setup for sterilization. And
excellent.
Earlier, we used to have, initially in the beginning, we have had this glyceraldehyde sterilization, chemical sterilization. However, few patients did have some infections and one or two tuberculosis also. So since then, the standard protocol is autoclave.
Okay. Now, what about the energy source devices, the battery cables and camera, madam? What you do for it?
Hello?
You are not audible, madam.
Yeah. We have even gas sterilization in our.
Okay, excellent. Now, why I am insisting on each of these, because if you want to attempt for a laparoscopic groin hernia, the first and foremost important thing is you should enter into the abdomen with a proper 100% sterility. Unless and until you have to follow all these norms, your mesh is going to trouble you in lot of way if you are not handling this properly. So my next question to Dr. Meenakshi Sharma is, what are the special occasions or every time do you catheter the patient or anything external manipulation you do before you put the Veress needle inside, Dr. Meenakshi?
So my policy is to, when I enter the operation theatre and before the patient enters the operation theatre, the patient has to go and pass urine. I tell my anesthetists to keep the IV fluids very slow so that I do not have to catheterize the patient. The guidelines clearly show that any catheterization leads to an increase in rate of infections, can lead to an increase in rate of infection. So I avoid catheterization. However, if I am having large hernias, large inguinoscrotal hernias, even of one side, or a previous lower abdominal or inguinal hernia surgery, a recurrent hernia, of course, or large bilateral hernias, I definitely go in for catheterization. Anjali, you are muted.
Happening, Dr. Meenakshi. I am so sorry for it. What is your take on this, Dr. Usha Rani, regarding catheterization and the external any changes you do? Dr. Usha Rani, is she there?
Hello.
Hello. Yes, madam.
Ma'am. Yeah. Ma'am, we usually catheterize the patient in all patients.
Okay. Okay.
Yeah.
Now, my next question to Dr. Lakshmi Konakumani. My next question is, now, Dr. Lakshmi, do you do the scrotal wraps in a big inguinoscrotal hernia, or what is the role of it? Do you advocate it?
No, we don't put any scrotal wrap, but for every hernia, the scrotum is totally clean, painted, and draped in a sterile towel. Especially when you're doing large immunoscrotal hernia, you may sometimes have to give compression on the scrotum from outside to reduce the content.
Okay.
So the preparation or the sphincter should be up to the mid thigh, and the scrotum should be totally cleaned and draped.
Okay. Now, in the recent SAGES guideline, it has been mentioned that the scrotal wrap is going to help you in a big way. That is why I have taken it into special consideration. Now, we have taken the patient on the operation table. We have to decide whether we have to go for the TEP or TAPP. That you have to take decision beforehand. Now, if we want to go for a TEP repair, what is your take on this, Dr. Kalaivani madam? How will you decide whether I want to put the port for TEP? How will you go for it?
Yeah, since I'm basically a person preferring that, so I would, especially, but if you go on the literature for a simple hernia, probably I would go for a TEP, and more large hernias and difficult ones, I would prefer a tapping. But my preferable choice even now is skin tap. Hello? Dr. Anjali, again you're muted. I think you can use the cursor away from the...
I will request Dr. Jacqueline to say something that whether she would be able to decide depending upon the anatomical configuration externally that where should be the location of the ports. Dr. Jacqueline, if she is not there, I think, are you there?
I'm there. I think I missed your question. Could you please
Okay.
repeat it?
Depending upon the distance of the umbilicus, pubic symphysis, the configuration of the abdomen externally, how will you decide whether to put the ports? Can you judge? Can you look at some points externally? So as there are many budding surgeons in the audience, in the auditorium, many female surgeons are there. So externally also some factors we have to take into consideration as a surgeon. So would you like to tell something? If not, then I will request Dr. Meenakshi Sharma to say something that whether she will decide some important landmarks. Dr. Meenakshi?
Yes, so it's very important to do a kind of a mental choreography before you put your ports. So it's always stay, helpful to take a marker and a scale and mark the midline, mark the recti, mark the site of the hernia, mark the pubic symphysis, and measure the expect between your ports. So, for example, when I am planning a TC, I will measure the distance from the pubic symphysis to the umbilicus. So, ideally, it should be more than 15 centimeters to have good ergonomics.
If it's very much less than 15 centimeters, I can do TEP, of course. But most of the time, I prefer to do an extended TEP and move my umbilical cord a little bit superior to umbilicus, which is 5 centimeters above and lateral to the umbilicus on the side of the hernia. And then, depending on my initial camera port, I go in for my secondary or my working ports. One is at the umbilicus level, and the second one is below the arcuate line. These are both 5 mm ports. So, ergonomics is very important, even in TAPP. When you have to put in your camera port, remember to measure the distance, and ideally it should be a supra-umbilical camera port, so it will give you ergonomics.
Okay. So anything, Dr. Lakshmi Kona Kumari, you will add to it? Anything?
I would see if the patient has a previous lower abdominal surgery, then we would always prefer to do a TAPP. Otherwise, we always do a TP for any primary or recurrent hernia. For very large inguinal total hernia, we take short distance between the symphysis pubis and the umbilicus. We would do a E-step.
Okay. Now, I want a word about if you enter inside. Some have the habit of entering inside by the Veress needle, and some use the open technique. So, which is the preferred method at your side, Dr. Professor Kalaivani, madam? You are muted, madam. You are muted.
Someone, it's getting muted. I mean, fine, okay. Anyway, for all my laparoscopic surgeries, I have been doing Veress method only for so many years. Ideally, but it is Hassan's technique is definitely better if it is for that. For any laparoscopic entry for that matter. My preferred choice is Veress needle. Hello.
Whether you use the Veress technique or the open technique? Dr. Usha Rani?
We do the open technique, madam.
Okay. Now I will read technique. Okay. Okay. Now, see, it is depending upon the learning curve or depending upon the routine protocol. It is ideally either the Veress or the open technique, whichever is okay with the person. Now, I will request Dr. Lakshmi Kona Kumari to say something about when we enter inside, to say something about the anatomical landmarks or how to locate that it is a direct hernia, it is an indirect hernia. So please, Dr. Lakshmi Kona Kumari.
Yeah. First, once we enter into the extraperitoneal fluid, either through TAP or TEP, we ultimately go into the same place. First is to clear the and find where the symphysis pubis is. It is the lighthouse. All your anatomical consideration should be in relation to the symphysis pubis. Then when you dissect little lateral, above the Cooper's ligament, then it is a direct hernia. If you can locate the inferior epigastric, that is good, but in a obese patient or in a very large hernia, sometimes the inferior epigastric could be misleading. So you can think that this looks like a direct hernia, but it could be actually an indirect hernia. So that's why any lump going into the abdominal wall over the Cooper's ligament is direct hernia. Anything going literally lateral is indirect hernia. Anything going little down could be a femoral or a obturator hernia. Hello? Can you all hear me?
Now, this anatomical figure which we could see on the screen, this is a beautiful technical video which has been made by Dr. Rudrajit Sinha. Everybody should see it. He has made the complex things very much simplified in the way that how the inferior epigastric has an important role in the vertical division of the direct and indirect,
how the ligament, that is the iliopubic tract, how we should not go below. This is one of the important anatomical figure which every learning general surgeon should keep in mind so as to avoid the disasters. Now the principle of either TEP or TAPP is that by in the open hernia we used to patch only the defect which is visible, but here we could see a larger surface area, and in a one goal we are actually placing a mesh to obliterate the inguinal orifices, the obturator and the femoral also, so that they are not going to develop in future also. And with this I will come to the indications of the TAP. Dr. Usha Rani, will you take it? That in which situations will you go for the TAPP? Dr. Usha Rani?
Yeah, hello ma'am. In difficult, very large hernias, very large inguinal flaky hernias, in case of complicated ones, in case of recurrent inguinal hernias, which have been operated by open method earlier, so it is advisable to go for abdominal approach. Then, when they are irreducible, then in case of obese patients also, you can do a tap hernia.
Okay. Okay. So, as you could see that in every situation you could do for the TAPP, except for the principle that if it is a it is a recurrent hernia of previously TAPP, then you should go for the TEP. Now, steps of the TAPP operation, I will enumerate that we have to go into step by step. Now, here I will request Dr. Meenakshi Sharma that before going into the dissection plane, will you say something, one or two sentence each about the safe TAPP? How will you go with it? One or two sentence in each step. Or you could say you will enlist the 5 and rest of 5 will be done by the Lakshmi Konakumari. Dr. Meenakshi first.
Yes, so coming to the very first step, and this is actually a very critical step in laparoscopy, establishment of codes. So having safe access followed by a supra-umbilical port with proper ergonomics, and then the lateral ports at bilateral mid-clavicular lines, a little bit below the camera port. And then when we go inside, identify the median, medial and the lateral ligaments. Identify the kind of hernia we are dealing with in relation to the inferior epigastric vessels. Coming to the reduction of content. So you may have different situations. You may have a situation in which you go inside and then the contents can spontaneously reduce. In other situations you may have a few adhesions. So again, very important to define here what is the adhesion width. Is it the bowel, is it the omentum, and carefully do a cold adhesiolysis with cold scissors. You can take a very important thing I have realized is to take the bipolar forceps in my left and the scissor in my right, and carefully pull out the bands or the adhesions and carefully cut them in the correct plane. Creation of the peritoneal flap. So the rough estimate is 5 centimeters above the defect, but also 2 centimeters above and lateral to the anterior superior iliac spine is the point at which you carefully give the first point of the incision, and then you tattoo the entire extent of the flap. So once you make this flap, and you just have to take the peritoneum in your left hand, and you give the first incision, you will see carbon dioxide rushing in. Yes, you can we can see this in this particular figure, and the carbon dioxide rushes in and starts helping you with creation of the flap. And as long as now I'm talking about a flap on the right side, so as long as you keep on following this tattooed line, you will have a very good important flap ready, which will cover your entire mesh. What was the next step, Anjali? I think you've gone on to the next slide. The previous slide.
You have illustrated wonderfully, Meenakshi. Now, step by step, I will, you have done wonderfully. I will request Dr. Lakshmi Konakumari that looking at this first picture after our telescope has went inside, what you will enumerate the highlights. Dr. Lakshmi Konakumari.
Yeah, first once you put the scope inside, first you have to see the anatomical landmarks from inside.
Okay.
You can see the inferior epigastric vessel. You can see it's a direct defect. Okay, and then you push from the anterior superior iliac band from the outside and go 2 centimeters above it and make the first nick as said by Dr. Meenakshi, and then reduce or create the flap, keeping at least saying 5 centimeter above the from the edge of the defect and go into the extraperitoneal plane. So when making this flap, make sure that you take the peritoneum along with the layer of the transversalis fascia. Otherwise, only if you take the peritoneum, it would be very thin and you will create lot of buttonhole defects in it. So once you go into the correct plane, the pneumoperitoneum or the gas will actually help you to develop the plane, and then keep on going it, but first go from laterally, you sweep medially and identify the space of Ritzius. That is the, and then you see the symphysis pubis. As this is a unilateral hernia, you will see the symphysis pubis, then you see where the right Cooper's ligament is, and then you create the space around the hernia sac. So you will see few contents going into the abdominal wall. Those contents will be your hernia and your iliac vessels and then your cord structures. So first, that's why don't jump into directly going and tackling whatever are the structures going into the abdominal wall, but go around it and clear these spaces and then come out a little, because at the level of Cooper's ligament you will have the iliac. So you have to come out, come anteriorly a little, and then you start reducing the whatever are the fat or fascia going into abdominal wall. Just above the Cooper's ligament you will have the direct sac. So the reduction of the direct sac is easy. Even if it's a big hernia, it is by traction and counter traction. As you give traction on the contents going into the direct hernia sac, you will visualize the white stretched fascia transversalis or the pseudo sac, which will be in the topmost part of the hernia. So gradually by traction and counter traction, you push the stretched fascia transversalis towards the abdominal wall and reduce the hernia contents into the abdomen. And coming to reduction of a indirect sac, here you pull the sac medially and push the cord structures laterally. Remember, in a hernia, the peritoneum will not contain any vessel. Any vessel, any fat, everything belongs to the cord. So make sure the peritoneum or the sac is completely denuded of any vascular structure, and then keep reducing till the point where you reach the sac narrows down at the apex. If it's a large inguinoscrotal sac, you can take it down. No need to completely reduce a large indirect sac. You can take it down at the apex, but before that, make sure that the sac is empty of the all the contents. Sometimes if you face a large irreducible inguinal hernia, then you have to carefully open part of the sac, reduce the contents, and then excise the rest of the sac. So then once the sac is resected, but make sure that the
Yes. Dr. Lakshmi, now I think the indirect sac management, if it is long, I will ask Dr. Kalaiveni madam, as she is a TAPP person, to say. Okay. You have wonderfully illustrated the anatomical landmarks. I will request madam to say something that if there is a long indirect sac which is extending up to the bottom of the scrotum, how will you deal with it, madam?
Thank you, Dr. Anjali.
Dr. Kalaiveni.
Yeah, I think I'm audible now. So the long sac, we should try to separate the sac out, as Dr. Lakshmi was telling, separate it from the cord structures, and we have to divide the sac. If it is too large, extending up to the bottom of the scrotum, go beyond the neck and divide the sac. And the proximal part of the sac, which is open, has to be closed. Maybe you can use a ligature. You can use the loop which we use for appendectomy can be used to close it. Or if you want to suture it, it can be sutured. But I preferably use the loop which I use for the appendectomy, the catgut loop. And that will cover the sac. And then the distal part of the sac should be divided and left behind. Otherwise, they can result in formation of hydrocele. Okay, so this is a very, very important point in a large sac. They have to be dealt with. Have I answered?
So, you have mentioned a very important point, madam, that how to handle the sac, that the distal sac should be left open, otherwise it will give a pseudo recurrence and which will be annoyed to the patient. Very important. Now here there are some situations in which there is a irreducible hernia and the omentum is very much stuck like anything. You are many of the time unable to take it out even with whatever energy sources you have. In such situation, what will you do? Dr. Usha Rani, madam? Are you there? Dr. Kalaivani, madam, will you like to answer that in such situation? Yeah.
Yeah, every attempt will be made to remove the entire omentum up to the bottom of the scrotum. In case we feel some part is left behind after the surgery is done, maybe in the scrotum a small incision can be done later and the rest of it can be removed.
Okay, wonderful. Okay, now one important thing is, now we have taken the superior flap, the inferior flap, we have created a sufficient space inside, we have taken care of all the important vessels, and we have dissected the sac, ligated if it is indirect, direct if it is there, we have pushed it, we have made the sufficient plane. Now there is a placement of the mesh. Now before we place the mesh inside, what are the important landmark events that you should do or think before pushing the mesh inside? Dr. Meenakshi Sharma, please. Dr. Meenakshi, I think I will request organizers that intermittently they are putting us on a mute mode, which is very difficult to coordinate. It is taking a lot of time. So I will request for some time you keep everybody on the unmuted mode. Dr. Meenakshi, are you there?
Yes, I am there.
Yeah.
So once you have done you have defined you have made a clear space, a large space is there for the mesh to be placed. The parietalization has been achieved, which means you can lift up to the peritoneum and the mesh won't be folded. So the structures have been pushed behind. You have to look at the adequate space. So in the midline, beyond the midline, is what you need, especially for the direct hernia. Remember, you need to be at least 5 centimeters from the edge of the defect. Then, when you come superiorly, when you see the reflection of the peritoneum and you look at the important structures, so the vas should be seen turning medially. For that, very important to cut the transversalis length. And then the peritoneum has been pushed down on the lateral side. Iliopsoas has to be bared, and you should be able to see the anterior superior iliac span clearly. And that is when you are sure that we have created an adequate space for your mesh. Always remember, you do not have to try to see the nerves. Keep the fascia on the nerves intact so that you do not injure them.
Very, very nicely said. And there comes, Meenakshi, the critical view of myopectineal orifice, where we should see the reflection of the peritoneum, the triangle which was formed, the angle which was formed by the vas and the testicular vessel. Now that will form a triangle with the reflection of the peritoneum. Very important. Now we had enough discussion on TAPP. Now there are specific indications for the TEP, and very few surgeons are directly first start with the TEP. Only maximum surgeons, they start with the TAPP, as we have the peritoneal anatomy or the vision better. But I will request to the every audience and many learning general surgeons in the audience that whenever you are doing any laparotomy, any ventral hernia surgery, please do visit the inguinal plane. Please try to see how the Cooper's ligament looks. Please try to see what is the Doom's triangle, what is the triangle of nerve, so that you get familiar with the vision, that how it looks laparoscopically and how it looks open. That will make our job easier. So these are some of the TEP indication. Instead of discussing this, we will go with the how to enter into the safe TEP plane. Now I will request Dr. Lakshmi Konakumari to say something about TEP. How safe we can enter inside.
Yeah, we do the open technique. So one finger below the umbilicus, either to the right or left of the midline. You should not cross the midline when you are trying to do a TEP. So make a 10 mm incision and go up to the fascia. Then you see the anterior layer of the rectus. Make a small nick on the rectus, but make sure that you are not dipping the knife into the muscles you bleed profusely. And once you make a nick, make two stay sutures on the rectus sheath, and then you will see the rectus muscle. Pull the rectus muscle laterally. Then you will see the posterior layer of the rectus sheath. So put a blunt forceps, or people who want to use a balloon, or people who want to use the double force technique of using on a suction cannula. But we prefer to just use a blunt forceps to create the pain and then put in the sternum and trocar through it. We prefer to use a Hassan cannula. Hassan cannula will prevent the gas leak from this skin region. So once you put the Hassan cannula into the plate, start insufflation and make sure the gas flow goes full, not at low flow. And you have the proper abdominal pressure. So you put at least 12 millimeter of mercury pressure and let the gas go at full flow. So that will open the space and gently with the scope go through the cobweb layer, which you can see in front of the scope, and till go straight. Don't go sideways, go straight till you hit the pubic bone. So put the scope on the pubic bone and move a little right and move a little left with the scope, and that will create the space of Regius.
Okay. So nicely illustrated, Dr. Lakshmi. Only thing is the critical view of safety. Will you like to comment on it? What it is and how we should define it?
Yes. Critical view of safety is that you should be able to see your corona mortis area. You should be able to see the triangle of doom, and you should be able to see the quadrangle of pain. So these are the areas which should be visualized, and make sure that you never go below the iliopubic tract. Once you see the Cooper's ligament, you should always stay above the level of the Cooper's ligament all through the dissection, and not using any cautery below that plane. Hello?
Yeah.
Dr. Anjali, you're muted, Dr. Anjali. Please unmute. Dr. Anjali, please unmute. Dr. Anjali, please unmute.
Anjali ma'am, should you have a challenge, kindly log out and log in, madam. We are not able to hear you. Now we are okay, madam. You are okay.
Basically, yeah. Now we have a large sac in the TEP. So there are special tips while we are handling the sac. that we should confirm that there is nothing inside the sac, that is one. And step by step, you should, while opening this peritoneum, you should see that you open first the posterior edge or the lateral edge, and accordingly you can enlarge. And proximal, as madam has said, that you need not have to worry about. So here important thing is, what about the space of Regius and the space of Bogrons? These are very much important spaces when you are dealing with a TAPP procedure. Now, the one more important thing in the audience I wanted to highlight, that even though you do a TEP or TAPP, actually you are dissecting into the same plate. But only difference is, we are approaching from the peritoneal cutting reflection inside by TAPP, and we are entering through the anterior abdominal wall through rectus canal in TEP. That is clear and loud. So here I will just ask Dr. Kalingveni madam to important or highlight within a very short sentences that what is the triangle of pain and what is triangle of doom and what is importance of it.
Yeah. Thank you, Dr. Anjali. See, the triangle of doom, as it is visible on your slide, is the triangle between the cord structures, the testicular vessels, and the peritoneal reflection below. So in this, you find the iliac vessels. So it's very important for us to know the triangle of doom, because you have to be very careful while dissecting the peritoneum out over here, so that you do not injure these vessels. Then the next thing is important point is the triangle of pain, which is again from the testicular vessels medially and the iliopubic tract superiorly. So always the area below the iliopubic tract is the most important area, wherein you have to be very careful with dissection and do not try to make the muscles bereft. Keep the fat there so that the nerves get retained over there, because in case your mesh goes in between the nerve and the muscle, then you are in deep trouble. So see that your reflection or your dissection is over the peritoneum itself, and retain that fat over the muscles, the psoas muscles, so that you safeguard the lateral cutaneous nerve of the thigh and the femoral branch, which is an itofemoral nerve. Never try to intervene in this area, and do not use any packs in the area of pain. So the packs should be above the iliopubic tract only. Anything else I should add, Dr. Anjali?
Now, one more important thing is the layment of the mesh. How much should be the surface area over which your mesh should rest? I will request Dr. Meenakshi Sharma to highlight in a short two or four sentences that where should be the maximum and minimum extent of the mesh, please, TAPP or TEP.
Ma'am?
So the minimum size of the mesh required is 15 by 12 centimeters. So 15 centimeters is the threshold, 12 centimeters is the...
Hello, ma'am, sorry for the interruption, ma'am. Since we are running short of time, can you finish it in next 5 minutes, ma'am? Can you sum up?
Yes, sure. Yes,
Thank
sure.
you, ma'am. Thank you
sure.
very much.
Yes.
So it is 15 by 12 centimeters, minimum size of the mesh, but you can put. You have to put 15 by 12 centimeters, right?
So one more thing is, now complications in the laparoscopic hernia repair is the reflection of the learning curve and the patient selection, and not inherent to the technique. So I will say that complications do occur, but if we enter and exit in a safe manner with keeping in view the anatomical landmarks, we can definitely avoid the subsequent complications, like the sterilization will avoid the infection of the port, the seroma will be avoided, and handling the triangle of doom and the triangle of pain, you have to take care. Neuralgia is a big challenge. So if you think about all this, I think it is all avoidable. So because of the lack of time and excellent panel which we have taken, and the panel has given very active participation, I think Dr. Durga madam and all the Chennai and ASI city chapter and Tamil Nadu state chapter, we could give able to justice to this. And to enumerate that the take home message at the end of TEP and TAPP is that The pre-peritoneal space is same in both TAPP and TAP. Only thing is the way of approach or the way of entry is something different. Learn, unlearn, relearn the laparoscopic anatomy very well. Sterilization of the instrument is the first and the foremost criteria to learn or to attempt any laparoscopic hernia repair so as to avoid the disasters of the mesh. Dissection below the level of arcuate line is actually the hallmark of the successive operation. Dissect always between the fascia transversalis and the peritoneum. Keep in mind that peritoneum is only a one cell thick layer which you cannot attempt, so you could not attempt the buttonhole. Parietilization of the vas and the vessels and not skeletization. As Dr. Meenakshi Sharma has rightly said that don't rub on the bone, don't rub on the nerves so as to avoid neuralgia, and no fixation below iliopubic tract, that will avoid the tacker and tacker related issues. And with this, ladies and gentlemen, I wish you the happy International Women's Day, and with all of us, all the male organizers and all the female organizers, we together are going to achieve everything. So thank you very much.
Thank you, Dr. Anjali. Thank you so much. Thank you, Dr. Lakshmi.
Thank you, everyone.
I'd like to take this opportunity to say the men's day, all the men's day, and thanks to all the men folk who are there behind us. Thank you so much.
Thanks.
Thank you all the panelists. Dr. Kona Lakshmi has brilliantly chaired the session, and Dr. Anjali Diwale moderated the session in excellent manner. In fact, it is very much useful for the budding surgeons and also the experienced ones also. And we thank all the panelists, Dr. Meenakshi Sharma, Paras from Gurgaon, and Dr. A. Kalaivani, Ramaya Medical College, and also Jacqueline Leonard from Dindigul, and as well as Professor Usharani from ESI from Bangalore. Thank you, ma'am. Thank you once again for the wonderful session.
Thank you, the eminent faculty panel of the hernia session. Now I would like to move on to the next important session. We have the honor of inviting the next chairperson, Professor Kumkum Singh ma'am. We request all the faculty of the other sessions to stay back. Now I hand over the session to the National EC member of the ACRSI South Zone for handling this session. Over to you, Dr. Kannan sir.
Thank you, Dr. Kanagavel, Chairman, Chennai ASI. It is a pleasure to introduce the chairperson of this session. It's a benign anorectal conditions. Professor Kumkum Singh. Madam is serving as a vice chairman of the Fellowship Board, Association of Colon and Rectal Surgeons of India between 2018 and 2020. And served as President Association of Colon and Rectal Surgeons of India from 2015 to 17. And Madam has served as Head Examiner in MBBS, MS, RPS, and as well as the FSI examinations. And Madam has served as a General Council member, Association of Surgeons of India, Rajasthan from Rajasthan chapter between 2010 and 16. Currently, Madam is Director of Education West Zone, ABSI, between 19 to 21. And Madam has authored and published in many publications and national journals of surgery in India. And Madam has presided as keynote speaker and delivered lectures, orations at various conferences in India, China, and as well as in Egypt. Madam has awarded Ethicon Visiting Fellowship and Zuentus Fellowship in colorectal surgery. Over to you, ma'am. Thank you, ma'am.
Good morning, everybody. Thank you, Dr. Kannan and Tamil Nadu chapter for inviting me and for your kind words. Today we have a very important topic to be discussed, and that is benign anorectal conditions, because these anorectal conditions are very troublesome, and the patient is very aware of these problems, and we deal with these every day. So I would call upon the moderator, Dr. Prabha Om. She is a professor of surgery at SMS Medical College, to invite the other panelists. Prabha would be moderating the session, and we have the other esteemed panelists, which is Professor Geeta from Mumbai, Professor Ambujan from Karaikal, Professor Aparna Deshpande from Mumbai, Professor Salu Gupta from SMS Medical College, Jaipur, Professor S. Sharda from Coimbatore, and Professor Tejaswini Vallabha from Solapur. Over to you, Dr. Prabha, please, to moderate the session.
Good morning, madam. Thank you, madam, for introducing me. And uh, I thank the Tamil Nadu chapter for starting this initiative. I also greet all the women in the world for the International Women's Day. Environmental diseases being a feature which uh, women don't want to tell to anyone. So, and they need, actually, they search for women surgeons to tell all these things, all these problems. So, I am inviting my panelists, Dr. Uh, Dr. Geeta from HBT Medical College, Mumbai, Dr. S. Sharda from PSG Medical College, Coimbatore, Dr. Ambujam from BMMC, Karaikal, and Dr. Tejaswani Vallabh. Uh,
Good morning, madam. I am from Bijapur.
She is from Bijapur, Karnataka. Yes. And Dr. Aparna Deshpande from GS Medical College, Mumbai, and Dr. Shalu Gupta.
Good morning.
Ganesh. Good morning, Ganesh. My screen is visible?
Yes. Yes, it is visible, Prabha.
Okay. Welcome to this panel of benign anorectal conditions. The most common condition which we face, which a women faces or others face in the anorectal condition, is the fissure in ano. So I request Dr. Geeta to tell us something about it, about the cause and something.
Good morning, everybody, and I would like to invite on International Women's Day. Coming to the causes, the anal fissure is a very common condition, very common problem that we see in our day-to-day practice, and there are multiple causes, but the most commonest cause of anal fissure is passage of hard stools. Because of the lifestyle problems, drinking less water, or change in the dietary habits, people develop constipation, or they cannot pass motions on time and land up getting hard stools. And while passing, initiation of the fissure occurs with the passage of one episode of passing hard stools, which leads to a tear in the anal area, and that leads to initiation of fissure formation, and then that gets compounded, or it gets progressively increasing if it is not managed or not taken care properly. That is the most common cause that we see in our practice. Followed by that occurs commonly in people who are working in with odd timings. It can be also seen in elderly patients who are having constipation issues. So older age groups it is seen. Also, if patients have frequent diarrhea, or patients are suffering from certain conditions which lead to inflammation of the intestinal mucosa, like inflammatory bowel disease or ulcerative colitis, that can lead to formation of fissure. Many a times post pregnancy, post delivery, it is seen as an extension of the tear, or because they are suffering from constipation, it can occur. Also, I have seen it in patients who are receiving chemotherapy. They tend to develop constipation fissure, for which they need to approach the surgeon. So these are the most common causes of fissure formation that we see in our practice.
And how do you manage it at your end?
Generally, when the patient comes with the first episode or first incidence of formation of fissure, always I try to manage it conservatively. First, ask history. It is generally an episode of passage of hard stools. So one has to advise the patient lifestyle changes. That is the first thing. That drinking lot of water, make dietary changes, include lot of roughage in your diet so that motions are smooth. Increase fiber content. You can give a laxative which is fiber containing, like isabgol containing laxative.
Yeah. Dr. Shalu, can you tell us about your experience with deltagesic or nifedipine ointments?
Actually, both are the chemical they both use as chemical sphincterotomy, and the diltiazem and nifedipine, they are both used in acute and the chronic fissure also. And in diltiazem, nifedipine, they are the calcium channel blockers, and they causes the smooth muscle relaxation, plus they increase the blood supply, though which enhance the healing of the fissure. So nowadays, these both are very useful in the both acute and the chronic fissure in nano.
And for how long do you need to use it?
Actually, we give a in nifedipine and the diltiazem, in what they have a, we give a exact amount, because they have if we give the more than a limited amount, so it causes the headache. So it is given for the 6 week. Actually, whenever we give the conservative treatment for the fishery nano, at least we try it for the 6 week, and then if patient is not treated and not relieved by the conservative management, then we will go for the operative management.
Hmm. So, Dr. Aparna, can you tell us about when do you plan for lateral sphincterotomy? Dr. Aparna?
Yeah. So I agree with the panelists before me that largely most of the fissures would be treated by conservative management. Sometimes there is extreme spasm which may not respond to diltiazem, and the pain may be extreme. If you rule out infection, and if antibiotics additionally can also sometimes reduce the pain, but all this doesn't work, then a lateral sphincterotomy may be required, or in severe chronic fissures that are also not responding to the chemical sphincterotomy. So if they don't respond to diltiazem, and also very important that the application of diltiazem, the timing is important, the manner in which it is applied is also important. So I think information to the patients regarding when to apply and how to apply becomes essential. Sometimes they just apply it outside, which will not act,
Yes.
and they do not apply it at the bedtime, then there is not enough time for the diltiazem to act. So the detailed instructions have to be given, and if all that fails, then a lateral sphincterotomy can be planned.
Yes, so when we come across a patient of fissure in NO, we usually see where it is present in the midline or in the lateral position. And initially, we want to treat with non-operative management, like topical ointments or botulinum toxin. Then we proceed to the operative treatments, like lateral internal sphincterotomy, or again examine if hypotonic sphincter is present, then fissurectomy with advancement of flap can be done. And if it is hypertonic, then again consider the sphincterotomy. Madam Kunkum, do you have?
Yeah, I would just like to add two things. That the main problem which the patient comes with fissure is pain. The pain is so severe that the patient is really afraid to go to the toilet. And so we have the main problem is to alleviate the pain, which can be treated. Also, one thing is, along with the fissure, there is a sentinel pile. And sometimes because of infection, that sentinel pile gets infected or inflamed. So most of the time the patient has pain. If you just touch the sentinel pile, you will see that it is also tender and painful. And here I would agree with Dr. Aparna that sometimes antibiotics and anti-inflammatory help to alleviate or to decrease the inflammation which is present in the sentinel pile, along with treating the. Also, dietary modification is very important. The patient should not be laxatives are very very important, and as I agree with Dr. Aparna, that the proper application technique should be explained to the patient. And sometimes, if the pain is very severe, I also recommend xylocaine jelly before and after motion. If the patient is going, if she applies jelly inside 2 minutes before and again afterwards she applies xylocaine jelly 2 minutes. After that, it gives a lot of relief to the patient, and also I give to the patient sits bath, so which helps in the pain relief. So the main important thing is that once the pain is relieved, the stool is for consistency is changed, the fissure would gradually heal.
Hmm. Thank you, madam. Any other panelists want to wish to say something? Dr. Geeta?
Yeah, I think it has been correctly summarized by Madam that you have to encourage them lifestyle changes, drinking lot of water, bulk forming laxatives, and sitz bath and local application of the ointment to be applied properly. So the proper instruction followed by, if need be, antibiotics and definitely analgesics.
Yeah. Okay, thank you. Then let's move on to the next uh, disorder for anorectal. Most common which we come across is hemorrhoids. The patient comes with bleeding per rectum. So, Dr. Ambujam, Dr. Ambujam, how will we grade the hemorrhoids when the patient comes to you? Dr. Ambujam?
Madam, I think Ambuja madam is
Dr.
having.
Ambujam.
Madam, Dr. Ambujam is having some challenges in joining, madam. I would request the
Okay,
other esteemed
Dr. Shalu?
faculty to take up this question, madam.
No issue. Dr. Shalu?
Yes, yes, ma'am.
Can you
patient, they are usually patient with the bleeding PR. They are coming actually whenever the patient come to us, any patient of the anorectal disorder, he always said to us कि मैडम हमारे piles हैं, whether he is having piles or is a fissure or a fistula is a common is commonly patient said कि I am having a piles. So whenever patient comes to you, always properly inspect the patient. In hemorrhoid patient, there is bright red bleeding. There is history of the bright red bleeding, and we grade the hemorrhoid according to a different classification. There is Goliger classification. According to that, there are four types of the piles: first degree, second degree, third degree, and the fourth degree piles. In the first degree piles, they only patient giving history of the spontaneous bleeding, and in second degree piles, patient gave history of the bleeding with the prolapse with spontaneously reduced inside the anus, and in third type it manually patient have to manually replace reduce the piles inside, and in fourth degree of the hemorrhoid they are the prolapse pile, they have a thrombus pile, and they are strangulated piles. And according to also they are internal piles and the external piles. Internal piles which are above the dentate line, on external piles they are below the dentate line.
So how will we like to manage these patients? Dr. Aparna?
Yes, again, very rightly said that first we need to grade them with a proper proctoscopy, and if they are internal bleeding hemorrhoids, I personally feel that rubber band ligation is very good option for these kind of hemorrhoids if conservative management fails, because if bleeding continues to happen, then patients become anemic, and then that is something that is not desirable. So if with stool softeners, with proper stool habit, as in patient should not strain while passing motion, motion should be soft, they should not spend too much time on the toilet seat. So in spite of all this, if bleeding is continuous, if constipation is still there, for grade 1 hemorrhoids, rubber band ligation is a good option, along with medication. And if there are external hemorrhoids, in those patients, surgical treatment can be definitely offered, whether it is a malignant organ hemorrhoidectomy, can definitely be offered. I personally don't do a closed hemorrhoidectomy. I always do an open hemorrhoidectomy for all grade 3, grade 4, and prolapsed bile masses. Uh, People do prefer stapled hemorrhoidectomy also nowadays. in case the patient is proper, is proper indication for stapled hemorrhoidectomy, that is another option that one can execute.
Dr. Geeta, you want to add something?
Dr. Aparna has summarized the complete in addition, till the patient is waiting for surgery, we can add some agents like tranexamic acid or role of probably diathlon in decreasing the congestion of the blood vessels, so that pre-operatively, if you use that, probably during surgery, it is claimed that the bleeding is less. And I think for grade 3 hemorrhoids, maybe stapler hemorrhoidectomy will be, when there is prolapse, that will be helpful.
So Dr. Tejaswini, should we staple the hemorrhoid? When should we staple and when should we not staple? Dr. Sharda? Dr. Shraddha? When to staple or when not to staple?
Madam, I would request the other faculty to take up this
Okay.
question, madam. Few of them
Dr.
have challenges.
Dr. Aparna?
So I am not a very big fan of stapled hemorrhoidectomy because the number of patients with the proper indication, so to have three grade 3 hemorrhoids, uh, if the patient has that, as Geeta has mentioned already, in that case, and if the patient can afford, then you can definitely do a stapled hemorrhoidectomy. Only thing, such category of patients that are very limited. And secondly, the complications, if not performed well, can be harrowing. If you get vaginal fistula, rectovaginal fistula, that is something that can be very difficult to deal with if the technique is not properly done. So it is not that stapled hemorrhoidectomy is bad per se, but when you perform it, then you have to be absolutely sure of the technique and of the indication of the patient. Otherwise, a standard Stephen Morgan is a good procedure for hemorrhoidectomy.
I agree with Dr. Aparna, especially in female patients, you may tend to take more tissue and you will probably develop a rectovaginal fistula while doing stapler hemorrhoidectomy. That is quite likely. So proper training, and if that training is not there, then it can lead to complications.
That's true. So some of the absolute contraindications are anorectal Crohn's or ulcerative colitis, anal stenosis. If it is already there, you cannot introduce the instrument. Relative contraindications are rectal surgery, previous rectal surgery, where there is decreased sphincter tone or muscle disruption. Madam Kumkum?
Pelvic.
Yes, somebody. Aparna wanted to say something. Dr. Aparna, please say.
I was just going to say that in female patients, trying to know the condition of the pelvic floor is very important before attempting all these procedures. So a lot of times it is a pelvic floor descent or a weak pelvic floor, and the stapler hemorrhoidectomy may not be really the answer for all the problems. So assessment of pelvic floor is also equally important.
Yes.
So I agree with Dr. Aparna that this should be done. And when we are assessing the patient, it is important to know whether we are dealing with hemorrhoids or it was a rectal mucosa prolapse. That is what she wanted to say. So if we differentiate early at the initial stage, then this problem would not arise. I have just 2 or 3 points to make. One was in the classification. I was just wanted to say that the Association of Colon Rectal Surgeons of India has made guidelines for the hemorrhoids, and where we have classified it, the stages 1, 2, 3, 4 remain the same, but we have added A and B, in which A means, if the pile mass is less, occupying only, there is a single pile mass. B is when there is more than one pile mass, but on one side of midline. And if the third C is the circumferential hemorrhoids. So this way we can differentiate. If I say something like it is 2B, then you would know that there are more than one piles on one side. But if I say 2C, you would know that there is a circumferential hemorrhoids which we are dealing. Because sometimes a single pile and a circumferential hemorrhoid, the treatment is slightly becomes, we know, and that classification, we know the anatomy what we're dealing with, and the management becomes slightly different. The second is in grade 1 and 2 hemorrhoids. Uh, there is a lot of role of the MPFF, that is the micronized purified fibrinoid fractions, that is the diosmin, benismin, and the Deflon. All these drugs have given very, very good results. So in the initial stages in grade 1 and 2, these drugs have been found very effective. There are many studies, randomized trials, which have proved the efficacy of these drugs. If they fail, then I agree with Dr. Aparna that rubber band ligation is the treatment of choice. Uh, Regarding stapler hemorrhoidectomy, it is mainly done for the grade 3 and 4 hemorrhoids, and especially in the circumferential hemorrhoids. When there are circumferential hemorrhoids, which are the grade 3 and 4, and I agree with Dr. Aparna that Geeta, that we should have a proper training, because once we are trained, then we do not make mistakes like taking the vaginal mucosa in females, and we always have to take only the mucosa, and the submucosa and the muscle is to be avoided. The why staplers have fallen out on the besides in India, finances are not a problem now because it doesn't cost much, and in many institutes, government institutes also, it's available freely. But the only problem is stapler embryodectomy has got a lot of recurrence rate. The recurrence rate with stapler embryodectomy is more, and that is why it has fallen out of vogue, sort of fallen out of practice. So the traditional open and closed embryodectomies still remain the gold standard for treating the hemorrhoids.
Dr. Shalu, the main problem which is in stapler hemorrhoidectomy is bleeding. So how do you control that bleeding?
Whenever we are doing stapler hemorrhoidectomy, we first, after completion, when we remove the stapler, we see the there any bleeding. If there any bleeding that time during the surgery, we'll go for the another. We have taken the another suture there, and if bleeding is stopped, then it is okay. And if there is no bleeding, many times what happens, patient will come after 5 to 7 days bleeding. That time you go for the proctoscopy and find out where is the bleeding. If bleeding is very small, in a minimal bleeding, then you will only go for the packing. If bleeding is not relieved by the bleeding, then you post the patient in the OT and then see where is the bleeding site. You have to take the suture, or you have also go for the IRC. Actually, in one case, in my one case, there is bleeding after the patient comes after 7 days with the bleeding at the staple site. So in that case, we go for the packing, but the patient is not relieved by the packing, just packing. So I go for the IRC, which we are using for the hemorrhoid treatment. We go by the argon laser, and that bleeding was stopped.
You can always underrun the bleeding point with mitral suture. This will, in majority of the cases, stop the bleeding.
Yeah, that is true. Just one, someone please tell us about the indication for a pregnant woman. What will you tell the pregnant woman if she comes with hemorrhoids bleeding per rectum?
I think that is a nightmare for most of us surgeons, is to have a pregnant lady coming with bleeding PR, coming with piles. And as much as possible, I think we need to avoid performing any kind of surgery, because most of the times these problems will reduce significantly after the delivery takes place. And as Kumkum madam mentioned already, that we have very good medications now. So flavonoids, we can, and they are safe in pregnancy. So we can put the patient on Daflon, put them on proper conservative treatment, position while sleeping, and try to tide over as much as is possible up to the postpartum period. But spite of that, a few times you do need to operate if the problem is significant and if the prolapse is significant. In that case, it is best to operate near to term, or at least after the second trimester. Again, the anesthesia is an issue, because regional anesthesia causes hypotension. We cannot afford that. So I think this is a very difficult question that you have asked, Prabha ma'am. It's a nightmare, to tell you the truth, to manage these patients. But yeah, we do need to operate sometimes.
Main treatment of hemorrhoids in pregnancy remains conservative. Patients do respond with conservative treatment all the time. But if there is a prolapsed, extrangulated thrombosed hemorrhoid, it can be dealt with under local anesthesia. You can easily
Local
remove it in
incident.
any trimester of the pregnancy. It is not contraindicated, and they will hemorrhoids will aggravate during labor, especially it is a uh, natural labor. Then the patient, when strains, this will become. So we should always tell the patient or in that during labor these hemorrhoids would increase in size, but they would regress once the labor is over, the delivery is over. These hemorrhoids would regress automatically. But there is no contraindication of doing under local anesthesia. This hemorrhoidectomy can be done in certain situations.
Yes, madam. Well, like local anesthesia has become a boom nowadays. Most of the anorectal procedures can be done under pudendal block or local anesthesia in these cases. So let's move to the next disease. Dr. Parna, can we? I, uh, is anyone else also present in our panel? Dr. Geeta, Dr. Tejasmi, Dr. Ambujam, have they joined?
Yeah, I'm here.
Tejasmi, then you tell us about fistula.
Okay, I think madam, you have given me the toughest topic.
I know. I think all these topics, all anorectal disorders are tough.
Yeah, I agree. Probably, I think fistula management remains the basically most often it is the lifestyle modification to start with, local cleanliness, and as a personal experience, I think most of you might also have observed in addition to all our basics what we talk about the fistula, it is the local cleanliness and the hygiene maintenance which prevents especially soddening and in obese individuals if the anorectal skin tends to remain moist, these complaints tend to exaggerate. And fistula classification still remains, I personally prefer to go by the standard classification, and depending on the need, depending on the facilities available, we either going for a proper fistulogram or wherever possible an MRI fistulogram, so that the clarity regarding the further procedure can be easily planned there. Once the extent and the involvement of the anorectal tissue and the pelvirectal area is decided, the line of management is basically surgical, depends on the type different. As a standard, I personally prefer complete fistulectomy with scooping and expecting the wound to heal by secondary intention. But yes, it has its own major limitations. It takes time, then the chances of residual tracts are there. If we are not careful, the varieties of modifications are available now, right from including sit-on or flaps or packing it with glue and then only scooping and coming out. Probably the most essential point which we need to keep here is ensuring that the tract has a free drainage. Second is it heals from the uppermost part so that the fibrosed and the epithelial tract does not remain anywhere in the bone channel there, irrespective of the size. I also wish to know the seniors' experiences here.
I think Tejasmi has nearly summarized the topic. So these are the types of anal fistulas. One is subcutaneous, submucous, low anal, high anal, or pelvirectal. Or we can also classify like intersphinctic or supralevator fistulas. So all these classifications are there. And Dr. Panna, what about the Gupta's rule?
Yeah, so I think that's a very good rule and stands true even with time. That if the fistula tract is anterior, then it is very likely, if the fistulous opening is anterior, then it is very likely to be a straight tract opening into the anterior aspect of the anal canal. If it is a posterior tract, most of them are curved and opening into the midline posteriorly, but anything more than 3 centimeters away from the anal verge, they are likely to be very complex horseshoe kind of fistulae. And most of these patients would present to us with primarily with an abscess. Again, depending upon, usually these infections start in the anal crypts, and then the path that they take will decide whether it is a perianal abscess or whether it is an ischiorectal abscess. And most of the times, the perianal abscesses will be what we labeled as the as the low anal fistulae or the submucous anal fistulae. And the ischiorectal abscesses will probably end up being the transsphincteric or the high anal fistulae, or sometimes the supralevator, so the pelvirectal fistulae. Sometimes the patients do not even remember the previous episode may have been treated with antibiotics, and then they come directly with a fistulous opening, and they do not correlate the two. So that is also happens at times. And I think with the MRI imaging,
This is the
white
question I wanted to put up. Mm.
Okay.
What is the role of MRI in fistula?
I think that is quite revolutionized our understanding. I think it gives us a good roadmap. Essentially, this is one condition where there is no conservative management is not going to work. Though for prevention of recurrences, lifestyle modification is extremely important. But primarily, once a fistula has happened, then a surgical treatment largely, unless it is a very small subcutaneous fistula where you may be able to get away with proper laxatives and stuff. Most of the times, these are surgical candidates, and having an MRI helps us to know exactly how deep, how what is the contour, where it is going, and you are going to be able to try and remove at least most of the fistula if you want to do the lift technique. Try and go complete intersphincteric, remove the fistula and ligate the fistulous tract as close to the internal opening as possible. So at least unless it is a very small fistula, most of my patients, I recommend to get an MRI done.
Dr. Shalu, any experience about lift? Dr. Shalu?
Lift we usually we are doing in those cases when the external opening is very far away from the anal orifice. So in that case, it is very good procedure. We just go in the intersphincteric groove and we find out the actually whenever we are doing the lift, it is necessary you have to find out the internal opening. Internal opening is visible. Then you go for the lift procedure. So you go in the intersphincteric groove and find out there you find out the track and ligate the track and cut there, and for the external opening you scoop out whole of the track, you keratize the whole of the track, and then internal for the internal opening you by the vital suture you close that internal opening. So I did in my 2 3 cases. In one cases I have one problem in that case कि when I did what happened in that case कि internal opening vital suture is give way, and the track from that opening, and where I like it, a small track is remained which later on I have to remove.
Hmm. Dr. Geeta, any experience about all these procedures? Any of the procedure?
We have
Dr.
attempted.
Geeta?
Hello. Yeah.
Yeah.
We have been, as Dr. Shalu has said, when the opening is quite lateral, you can attempt lift, and it helps to remove almost the entire track, but you have to locate the internal opening. We have attempted laser, but with laser, as I wanted to point out that you may require multiple sittings. Patients do ask for laser nowadays, but one requires multiple sittings.
That is.
Yeah, and there is a chance of recurrence. The fistula does come back with laser. That is what has been observed. I don't know what is the experience of others. Even I have very limited experience of laser because of the expenses, and I'm in a government setup, so we arrange for it and then attempt. But you do need multiple settings, and maybe there is a high recurrence rate. That is what is reported.
What about satin tiles?
I think when Dr. Aparna was talking about MRI pelvis, if you know the extent of the fistula, then you are mentally prepared. Your roadmap is ready, and you don't get surprised on table because you have mentally prepared yourself that yes, it is high, maybe I will not be able to exercise this completely. So you are ready with set procedures like passing a seton, and I have a good experience with setons that you can tie it loose and then gradually on the follow-ups you start tightening, and we in fact teach the patient that the end has to be pulled at regular intervals, and it does help patient if you train properly, they follow that, and setons help very well in cases of high fistula where you are worried about the sphincter.
Yeah, I agree about that because I think that's an excellent way of treating these patients where we can actually avoid a stoma and avoid large wounds, and patients can still be treated with minimal distress. I do
Anyone,
not know
madam?
about
Madam?
WAF. Yeah, I mean, I
Mm,
have seen WAF since many years, but I don't think it has really taken off because
no, it has
finally,
not.
yeah, finally the treatment is eradicating that granulation, the dirty granulation which lines the fistula tract. And if you can do it with any other, standard fistulectomy, I think it is just as well. WAF probably also leads to a lot of high recurrence rate, and it doesn't, it's not as
Yes.
good as it was
Small
promised.
single tracts, fibrin glue has helped in few of my patients, if not all of them. Complex, tortuous tracts really do not respond well to the glue, but simple, straightforward tracts where, if especially the residual tracts, when somebody else has operated and they come to us, they are not very keen for a second procedure. To some extent, I think about out of 60, 70 patients, around 30, they were quite happy, but I really do not have extent detailed data. On an average, I think in 50% people it helps, provided the track is straight, simple, and easy to manage.
So I think in fistulas, if they are simple tracks, anything works. It's like that.
Yeah.
I think. And if they are complex tracks, everything is a challenge. So I think all the apart from sit-on, I think sit-on is one thing which is kind of a savior maneuver for most of the fistula tracks.
Tumko, madam?
Yeah, I would just like to add a few points. When you started with the cause, I think nobody mentioned that it is because of the cryptoglandular infection, which leads to a fistula, and always perianal abscess, which has been drained about 80 to 90% lands up in a fistula. Second was important thing which we have missed in our discussion is location of the internal opening. Normally we can see the external opening, but sometimes what happens is the internal opening is difficult to visualize. So in those cases, we have to inject either methylene blue or you inject hydrogen peroxide to locate it. It is to be remembered that one should not forcefully push a probe to locate the internal opening because in that case we create a false opening. So either push this thing, or if you the third method to identify the internal opening is just dissect out the external opening and dissect it till wherever you can go, and then you pull the tract. Whenever you do a traction, and if put a speculum inside, and then you can see when you are
See
pulling where the mucosa is being lifted up or pinched inside. That is the location of the internal opening. So these are 3 points to locate the internal opening. Then regarding MRI, I would not recommend it as a regular procedure or regular investigation for a routine fistula nano. MRI is very good and very important investigation in a recurrent fistula because we know that
Recurrent.
fistulas are a nuisance. They do recur off and on even in the best of hands. And in those cases, MRI is very good because there you can exactly locate where the tract is going. Again, sometimes when we are doing a fistulectomy, why recurrence occurs is because the tracts are branching. If we deal with only one tract and we leave behind the second tract, because these are very branching tracts, the external tracts may be two or three, but the internal opening remains one. So if we have removed one branch and left the other, then the chances of recurrence are more. Again, about plug, anal plug has been discarded because results are very bad, because it passes off very fast and it is a very costly affair. Fibrin glue also has not stood the test of time, and setons are also good because we all have been trained in our age group to use setons, especially for high fistulas. They are very good, but the only thing is the patient has a lot of pain whenever we are tightening the seton every time. So nowadays, even instead of seton, the surgeons are what they're doing. Even if you damage the muscle, the main important is if we damage the sphincter. To prevent sphincter damage only, we are doing this procedure. So even if your sphincter is damaged, they resuture it, and that gives very good results. I have seen Dr. Parvez doing surgery where with the sphincter is damaged, he divides the suture sphincter, but he stitches it back, and it gives very good results. I have seen his surgery, so this is important. Again, lift has also been popular. It has to you have to have a good experience for lift, and waft is I'm not very convinced about waft, but yes, it is still there. um, Rich man's treatment, but otherwise I'm not. Laser, yes, has come into vogue, and as Shalu rightly said, it is very good. Only thing is sometimes you might require multiple sittings.
Hmm. Thank you, madam. I think it has been summarized as a whole in this. So, next, Dr. Shalu, can you tell us something about the next disease, that is the rectal prolapse, if the patient comes to you with rectal prolapse? Dr. Shalu?
Actually, rectal prolapse we divide in three. It may be partial prolapse, it may be complete, or internal prolapse. Actually, partial prolapse when there is only mucus and submucous is protected out and it is less than 4 centimeter in size. And when complete prolapse is said when there is a whole of the all the three layer is outside the rectum and is more than 5 centimeter. One term also internal prolapse, which is rectocele or rectal intussusception, which we are not able to see from the outside.
Outside.
And in the etiology, rectal prolapse usually in the infants, even in the infant we can see the rectal prolapse, and the common cause for the infants is the sacral curvature is not properly formed. That's why the infant develop the this rectal prolapse. In children, it is because of the diarrhea, cough, and in adults, it's more common in the women. Women are more commonly affected by the rectal prolapse, and it is because of the multipara, because of the repeated childbirth, there is injury to the perineal muscles, and it may be because of the decreased ischiorectal fat. It may be because of the weakness of the levator ani muscle. There may be weakness in the pudendal nerves and increase in the intra-abdominal pressure. They all are the causes for the rectal prolapse. Whenever patient come to us with rectal prolapse, commonly they present us with the in the emergency cases. Most of the time, patient
Yeah.
come in the emergency with the acute
Yes.
rectal prolapse, and he coming with a huge, large edematous rectum is coming out from the anus, and sometimes patient come in the routine also, and they complain us with the something is coming out from the rectum, coming out from the anus. They maybe complain of the fecal incontinence. Patient also complaining of the itching, and so whenever patient come with all these complaint, we have to examine the patient. And rectal polyps, we are very well we are seeing on the inspection. We ask the patient to give the pressure either in the supine position, or if patient are not
Squatting.
able in supine position, then we ask the patient to squat in the toilet, and that time we are able to see the rectal polyp very well. And we also go for the perrectal examination to find out the what is the condition of the sphincter, because most of the patient in the rectal prolapse, they are from the they history of the prolonged time, they a long history, and because of that they a injury to the nerves, and that's why they a incontinence. So, and perianal skin also macerated, and their skin is also edematous. So we see, and then we go for the some investigation where, because we have to rule out the rectal mass, colonic mass, and the rectal growth. So we have go for the colonoscopy, sigmoidoscopy. The most important investigation nowadays in the rectal polyps is the MR difficography, because in MR difficography is well delineated the anatomy of the lower part. We can see
Yes.
anterior compartment, middle compartment, as well as the posterior compartment. Because most of the time, whenever the female come to us with the rectal polyp, they are also having the anterior and the medial compartment polyps also. So, And second thing, in the MR diffography, we can see the weakening of the pelvic floor. We can easily see the rectocele and the rectal interception. Because whenever we are planning for the treatment is totally different for the rectocele and the rectal interception. So MR difficography is nowadays is a very important investigation. Then we also go the the anerometry to see the sphincter functions, and we can also go for the pudendal nerve investigations to see the whether pudendal nerve is functioning normally or not. And then I continue, ma'am, or
Uh, Dr. Tejasni, can you tell us about the management part?
So I think, ma'am, depending on the type, basically if it is a partial rectal prolapse or mainly predominant mucosal rectal prolapse, depending on the symptoms and the tone of the rectum and anal canal, either a simple excision or even the sclerosant injection definitely helps there, provided the tone of the sphincter tone is normal and there is not much of significant compromise there. But if the rectal tone is poor and it is only the partial rectal prolapse, excision, partial excision, and an attempt to improve the tone in the form of local stimulation by the nerve stimulator and other procedures, conservative exercises definitely help there. But if it is a full-fledged rectal prolapse, we have to decide the plan depending on the type of the individual, as what madam told earlier, whether there is a compromise in the pelvic musculature, one. Second, is there any associated intercompartment descent also? And the third one is whether it is a complete interception. Normally in such procedures, I think at present, the preferred procedure would be the abdominal procedure, either laparoscopic or open pulse procedure through the abdomen, lifting it and then putting across a good mesh. What we used to do earlier is called as wells, and now it's very nicely done with the laparoscopy. So that definitely helps, provided adequate hitching of the redundant colon is fixed to the posterior wall of the sacrum there. If this takes care, and we have to ensure that the local tone which has been reduced because of the large the intussusceptum which has gone into the anal canal needs to be again get back to its normal activity. The tone that it again needs post-operative local care there. The preferred, otherwise there are a lot of other options like perineal rectosigmoidectomy, especially this is preferred when, as madam was telling, when they come with edematous, gangrenous, compromised anorectal stump which has been lying outside for quite a good time, and patient general condition is also poor, especially old individuals with dementia and other things where they are not even aware that such a thing has happened. As an emergency procedures, yes, a few times we were forced to amputate it practically and then go for a through and through sutures and then ensure that it is put back into the abdomen and wait and watch for improvement. And where I think hardly now probably there is not much of role of other procedures as to my understanding. We'll be happy for some more inputs.
And also we need to evaluate preoperatively whether there's a constipation associated with the prolapse. So especially if the patient has constipation and then a redundant colon, then the resection part becomes important. If there is no constipation, then in that case a rectopexy could be adequate if the colon is not redundant. I think laparoscopic approaches are very popular now because this is one of the best procedures for laparoscopy as the access is very good. You can do very good dissection, placement of mesh can be done very properly, and especially if you are not resecting, you really don't require a bigger incision for removing any specimen. So I think this is one of the procedures which has found a lot of favor amongst laparoscopic surgeons. Dorsal rectopexy is what we used to do earlier, and I think we still continue to do it preferentially. Some ventral dissection may be if there is pelvic floor weakness.
Rightly said, all the approaches are there, and with minimal access surgery, of course, the anterior resection and suture rectopexy, these have become more prevalent nowadays, and because we don't have to give a large incisions in open cases in these cases. So I think these are the procedures which can be given. Dr. Kanan, we have time.
Having said that, I think as Dr. Tejaswini mentioned, in really old and morbid patients, I think a tertiary stage still has a role to play because many of these patients are not in any condition to undergo major surgeries. So just for
Especially the old age.
just for symptomatic relief and comfort, sometimes we really need to fall back on encirclement.
In old and debilitated patients, we can also go for the pioneer approaches because we can do pioneer approaches in the local anesthesia. There is no need of general anesthesia. So Altimire and the Delorme is also very important in the old and debilitated patients. And they will
Because
give the debilitated treatment also.
yeah.
Tears is only given just tears is having a very complication. It may cause the anal stenosis and patient develop more constipation if we are doing the
Yeah,
tears
if
wiring.
you don't do it properly. I agree.
Yeah.
Only thing is, I feel that Delorme is associated with some amount of blood loss. So if there is fitness for anesthesia per se, personally, I would still prefer a laparoscopic approach over a Delorme's. Obviously, if that is not possible, then a Delorme's or then a simple encirclement.
Or you can combine also. You can combine the laparoscopy and do this also. So in that case, madam, any points?
No, no. I think it is commonly seen. What we have said is that we can see this prolapse mainly in children also, and in children it is important to differentiate between a prolapse and interception. That's point number one. Even in children nowadays, we do not do encircling procedures. The wiring is not done nowadays, neither in children nor in adults. Even in adults, it has not been done. It has been abandoned because it causes more of constipation. More problems are there with that. Thirdly, if there is just a partial rectal prolapse, sometimes star procedure helps. It has been done, and the other points have been covered by the panelists. And only I would say when if the patient comes to us, this is mainly seen in psychiatric elderly patients, constipated. In that case, if the has an irreducible large prolapse with lot of edema, in that case, then only the Alzheimer's procedure helps. The Delorme doesn't help, and Alzheimer's is an easy procedure to perform even under local anesthesia. It can be done. It takes care of that edematous bowel has to be removed. So that is the only thing. The Alzheimer's is a good operation. If the prolapse is reducible and the patient is fit, laparoscopic approach is very good nowadays. Laparoscopic hernia repair, laparoscopic mesh hernia repair is very good.
Madam, what about your views about doing a colostomy till you can do a definitive procedure? When a patient comes in acute condition, acute prolapse condition.
Yeah, this is what I told you, Prabha, that if the patient comes with an acute, irreducible, large prolapse which is edematous, in that case, colostomy is not required. You do a Alzheimer's procedure; it will help. No need of doing a colostomy for this because that ends up into a second surgery of closure of colostomy. No, I think Alzheimer's helps very well. And I have not done a single case of colostomy in a incarcerated prolapse. I've never done a colostomy.
Dr. Sharada, have you joined?
Ma'am, can you summarize
She's
in
not
5
joined.
minutes, ma'am? Because it's running short of time.
Oh, yes. We can summarize anytime you want.
Yeah, ma'am. Yes, ma'am. Please summarize, ma'am. Thank you.
There were only a few conditions like perianal abscess, which has been dealt in fistula. This is the perianal abscess. Sorry. Different types, the true perianal abscess, one in the ischiorectal abscess, submucous abscess, perirectal abscess. So these are the things. And there's one another feature which comes regularly is rectovaginal fistula in our cases, and most common cause is the obstructed causes. And for this, it is because of injury in childbirth, Crohn's disease, or in radiation treatment or cancer, and complications following surgery in the pelvic area, hysterectomy, and all these patients always come to you with rectovaginal fistulas. And management, of course, Dr. Aparna, you can summarize this, the management of RBF?
Yeah, I think in fistula, plug or patch, but as Madam mentioned that whether it is how effective it is, we really don't know. And repairing the sphincter muscles if they have been damaged. So doing a MRI, establishing the muscle anatomy, and then attempting a proper repair of those muscles will be the best part to deal with the rectovaginal fistula. Of course, if there is an incontinence and there is a lot of leakage of stools, it is always better to have a colostomy in place, and then you perform your repair and allow that repair to heal in a aseptic environment, divert the stool, and then do the stomach fusion. So that may work best.
So I think all panelists, whoever is, I also Dr. Ambujam with from us, Dr. Sarada, who could not join us. And thank you very much, Kumkum Madam, for all the summarizing you have done. And most thanks to the proctoscope which is present for the for our anorectal conditions, which gives us all the diagnosis on the table.
And thank you, Dr. Prabha, for making the whole presentation. So we only had to look at it and answer the questions. So thank you really for putting in all the effort. Thank you so much.
Thank you so much.
Thank you, Prabhadi. Thank you, Kumkum.
Thank you.
Permitting us to be part of this. Thank you, Kumkum ma'am.
Happy Women's Day to all of you. Thank you all.
Thank you, ma'am. Thank you very much.
Thank you,
Actually, it is-
Kananka and Gangavar sir.
Thank you, ma'am. Actually, it is honor for us. Professor Kumkum Singh has chaired the session, and Professor Prabha Home brilliantly moderated the session. And we thank the panelists, Professor Shalu Gupta from SMS MC Jaipur, and Professor Geeta Kag from HBT MMC Mumbai, and Professor Abarnath Deshpande from Mumbai, and Professor Chedeswani Vallabha from BM Patel MC Solapur. Thank you once again for the brilliant session, ma'am. Over to next session.
Thank you, sir.
Madam Prabha ma'am, can you unshare your PowerPoint?
Sure.
Thank you,
Sorry.
madam. Thank you once again,
Sorry.
Kumkum ma'am and Prabha ma'am and the entire galaxy of the national faculty for making it a brilliant program. Now I would like to request my co-EC member, Dr. Pandi Raja, to take over the next session on the locally advanced breast cancer. Over to Dr. Pandi Raja, please.
Good afternoon, everyone. On behalf of Tamil Nadu Dr. M.G.R. Medical University, ASI Tamil Nadu and ASI Chennai City branch, we are going for a next panel discussion on locally advanced breast cancer. It is my honor and pride to introduce the chairperson, Dr. S.G. Balamurugan, who is a laparoscopic surgeon and the chairman of Guru Hospital, is an adjunct professor of Tamil Nadu Dr. M.G.R. Medical University, and is secretary of ASI Tamil Nadu and Pondicherry chapter. He is secretary of Nursing Board of IMA Tamil Nadu. He is a member and governing council member of various chapters. He received award from Tamil Nadu, Best Doctors Award from Tamil Nadu M.G.R. Medical University, an Achievement Award from Honorable Home Minister, and Golden Excellence Award from International European Continent, and Service Industrial Award from Madurai Trade Center, and Honorary Professor Award from IMA National. He also received a Medical Excellence Award and Medical Entrepreneur Award and President Appreciation Award. It is a very short time to introduce him, but still I tried my best. Over to you, sir.
Dr. Bala is joining us shortly. And in the meantime, on behalf of the Chennai SI, we warmly welcome the panel members and the moderators for the session. We have the most eminent person on breast surgery, who heads the breast unit at the KM Hospital, Mumbai. We have Professor Shilpa Sharma, and she has held many important positions in the various breast surgery societies of India. Warm welcome, ma'am. And we have the honor of inviting Professor Seema Khanna, ma'am. Professor Seema Khanna is a professor of surgery at the Banaras Hind University, Varanasi. we have the pleasure of having Professor Shanti Madam in the university. We have Professor Lakshmi Narayani Ma'am from Coimbatore Medical College, Kovai, Professor Ramya Ma'am from Sri Ramchandra Medical College at Chennai, and we have Koparin Devi Ma'am from Omadurar Medical College, Chennai. Now I hand over, I think Dr. Bala sir is going to join us shortly. Now I hand over the proceedings to Dr. Pandi Raja till Dr. Bala comes in. Over to you, Pandi.
Start the sessions.
Shilpa ma'am, please take over. Shilpa ma'am, we are able to see your slides. I would request you to make it a full screen mode, madam, please. The audio issues are now cleared. Shilpa ma'am, we are fine to go. Please carry on. Madam, we are unable to hear you. Maybe I think I would request you to remove the headset from the computer and directly speak to the computer, ma'am. We are able to see you well. You are perfect now.
Can you?
Absolutely.
Can you hear me now?
Absolutely, absolutely.
Okay.
Please go ahead.
Great. So it's indeed wonderful to have an entire male organizing committee organize such a fantastic all-women's program, on an active basis. I think 3 cheers to Dr. Kanagavel and all of you all there. It's a wonderful, wonderful gesture. And my co-team has been introduced. So we have Professor Seema Khanna from Varanasi. We have Professor Shant from Professor Lakshmi Narayan from Goa, Professor Ramya from Chennai, and Professor Dev from Chennai. Professor Jishen would hopefully be joining us soon. What I'm going to do is going to be very, very casual, and since it's going to be more of a practical discussion, I will direct questions randomly to the panelists, all of whom are extreme experts in the field, and we hoped to run you through the basic tenets of management of locally advanced breast cancer. So can I ask Professor Seema to take over the definition of LABC? Dr. Seema, please.
Yeah, thank you, ma'am. Good afternoon, ma'am. This is Dr. Seema Khanna from BHU Varanasi. So I think to begin with, locally advanced breast cancer is breast cancer which is a gross loco-regional disease, and there is no evidence of, at least clinically, there is no evidence of metastatic disease. So gross loco-regional disease in the breast would be defined as breast cancer. And if we go by the tumor characteristics, it could it is T3, that is tumor size more than 5 centimeters, and it would all locally advanced breast cancer would also include T4A, T4B, T4C and D, which implies involvement of chest wall, involvement of skin, involvement of both, and inflammatory breast cancer. And if we go by the node characteristics, it is either N2 or N3, that is bulky and fixed nodes. So coming to the stage, that would be stage 2B, stage 3A and 3B. So that would define locally advanced breast cancer.
Perfect, Seema. So the worrisome thing about locally advanced breast disease and the worrisome thing about breast cancer in India is that, I don't know how many of you would agree with me, but in my setup, more than 80% of our population comes with locally advanced breast disease. And I think this must be true of all government setups and a lot of public centers. And this is unfortunate because then the statistics show that 1 in 2 women would not live to see 5 years. And I'm hoping that over the next 5 years, we have better screening places in place, we have better methods of analyzing this, and hopefully the next session would be on early breast cancer in the Indian subpopulation. But yes, it is unfortunate that as for now, most of our patients present with
something more than T3N0M0. So that's the simplest to remember. Of course, you have something known as a locally operable breast cancer, but the NCCN guidelines mention that T3N0M0 onwards is considered as locally advanced breast disease. So moving on, let's move on to the first case. I'll have 4 cases that we'll be discussing of different varieties and permutations and combinations so that we have an idea of how to handle each of the cases. So this was a 65-year-old lady, post-menopausal, known diabetic on oral antihypoglycemics, who presented to us with a lump in her right breast since the last year and a half. So if somebody could, Shanti, if you could, take over the definition of menopause, because we have a lot of postgraduates also on our team. So Professor Shanti, if you could just define menopause for us, and then we could move ahead with the management. Is Professor Shanti there?
Yes, madam. So menopause is defined as the absence of menstruation due to the loss of follicular activity, and the amenorrhea for the past, after 12 months of amenorrhea, won't get the periods, madam. That is amenorrhea, and there is no other obvious pathological and physiological cause. That is defined as menopause, madam.
Sure. So, perfect. Is it's only that, I don't know about you, but we get a lot of patients who are in the perimenopausal age group. So is there any specific blood investigations or any hormonal levels that you would advise for these patients to decide whether they fall into the postmenopausal category?
We can take the FSH levels, madam. FSH levels.
Okay. So we do the FSH and the estradiol levels, both of which, if they show that the person is in the postmenopausal activity, it helps us understand and manage the treatment, especially the hormonal treatment for these patients. So we advise estradiol and FSH levels in our center, and that can pretty much define menopause. Otherwise, this is the WHO classification of menopause. So let's go on. This lady had a lump which was 6 by 7 centimeters, hard, fixed, with skin, with tethering and distortion of the NAC. There were 2 nodes present in the axilla. The largest was 3 centimeters, mobile. The mammography showed a BIRADS 5 with axillary nodes, and a core biopsy was performed, which showed an invasive ductal cancer, non-specific, moderate nuclear grade, a Chi67 of 15%, and she was ER/PR positive and HER2 negative. Dr. Ramya, how would you proceed? Dr. Ramya?
Yes. Am I audible? Yeah.
Yes, you are.
Yeah, so basically it really fits into the locally advanced breast cancer. So this is how it looks on clinical examination. So you have this obvious skin involvement with couple of nodules, etc. So with all this investigation done, I think she's a definite candidate for neoadjuvant chemotherapy.
Yeah. Is there something that you would like to do for her further beyond of what we've done thus far?
No, we have just
Dr.
done
Ramya?
for preoperative assessment. An
Yes.
MRI would be more helpful in follow-up to see the response of the lesion. So I would also suggest an MR mammogram, if possible under the circumstances, before we start the chemotherapy.
Okay. Dr. Shanti, Dr. Seema, Lakshmi, any other points of view as to the staging of this patient?
We can do staging. For staging purpose, we'll do a mammogram, and then
We can do a CT test.
Okay. So, yeah, so the NCCN guidelines mention that once one does a CT chest, ultrasound abdomen, and a bone scan. But the latest edition of NCCN has also mentioned that if PET scan facilities are available for locally advanced breast cancer, one can go ahead and do a PET scan, which is equally, it picks up the metastases as well compared to most of the other diseases. And MRI is better for chest pathology because a PET scan may not pick up chest pathology as well. But the standard of care in most centers today is a PET scan for staging. And of course, if you don't have that, then you can do as recommended by the NCCN guidelines. And this patient showed a metabolically active lesion in the right breast and right axillary lymph nodes. Okay. So what would be the next plan of action? Dr. Koparan Devi, are you there? If you can take up the next question. Is Dr. Koparan Devi there? Shanti, are you there? Can you take this question?
Madam, instead of PET scan, we'll do a bone. In some other hospitals, the PET scans are not available, madam. So we'll do a bone scan, ultrasound abdomen, and CT chest. That 3 is enough for me, madam.
Yes. Yeah, that's what we mentioned. So if a PET scan is not available, the NCCN guidelines mention that you can do what you mentioned. Perfectly all right. It's absolutely the way to go. But a lot of centers today have the PET scan, so under one setting it gets done. So in our institute and a lot of other institutes, we prefer to do the PET scan. But both are included in the NCCN guidelines for sure.
Okay.
How do we proceed with this patient? How would you now that you know all this information? How would you further proceed with this patient? She's an ER/PR positive, HER2 negative, 65-year-old postmenopausal lady, locally advanced T4N1
madam,
disease.
we can start her with the neoadjuvant chemo, madam.
Yeah. What neoadjuvant chemo would you
madam,
prefer in her?
Doxorubicin based chemo, 4 cycles.
Okay.
And then followed with MRM, and then we can give further cycles, madam. But nowadays, in oncologists, they are doing 8 cycles of chemo, that is doxorubicin based 4 and another 4 Taxol based, and then followed with MRM, madam.
Perfect. So we have an in-house medical oncologist of quite some repute. So what we did was we started her on paclitaxel, weekly paclitaxel, but because she's ER/PR positive, and we've seen that ER/PR tumors respond very poorly to paclitaxel. So after 3 cycles of pacli, we decided there was not much of a response. Her echo was normal, so we converted her to tax. So we added anthracyclines to the taxane, and this was the response that we've seen in the patient. So there was an excellent response. It came down to almost 50% and less of the tumor margins, and then we completed the entire 6 cycles of TAT, and her skin affectation was minimized. The nodes which were palpable became like just 1 centimeter palpable, and then we decided to take her up for surgery. So if somebody could, Ramya or Seema, whoever, if you could tell us why an MRM would be preferred, would you at all consider a breast conservation in a case like this? Further management, please. Seema, Ramya?
MRM, yes, ma'am. I think MRM would be preferred in this case because to begin with, it was N2 lesion and she had not responded to paclitaxel, so we had to shift to another chemotherapy. So it would be safer to go for MRM in this case because of the axillary lymph node involvement.
So, any other thoughts from the panel?
Yeah, I think.
Anybody disagreeing with this this plan?
No. Okay, I'm agreeing with it.
Okay, if everybody's agreeing, then we will go ahead. It's a good panel. Everybody's agreeing with everybody else, so it's nice to be all on the same boat. So yes, and because her nipple areola was also affected, we were not going to be able to do a conservative on her. We performed a medical radical mastectomy and cleared the axilla as well. And then she was subjected to radiation. Hormonal therapy, Dr. Koparan Devi. Is Dr. Koparan Devi there? I can't seem to hear her. Is she there? Okay. Lakshmi, if you can take this up for us. What is the I mean, obviously after surgery we finished the rest of the chemotherapy and we did radiation. What kind of hormonal therapy and for how long would you give this lady, and what would you give her in addition to hormonal therapy? She's a 65-year-old postmenopausal lady.
Since the patient is a postmenopausal lady, I would give oral aromatase inhibitors like letrozole or anastrozole. Letrozole 2 milligram OD for a period of 5 years duration. And along with this, we can give a LH-RH agonist like gozeril or we can give the another hormonal therapy.
Okay. How many of you would give a bisphosphonate in addition to giving letrozole to these patients? Anybody could take this question. The role of bisphosphonates in ER/PR positive postmenopausal women. Dr. Seema?
Yes, ma'am. There is definitely a role of bisphosphonates, but cost factor is also one thing which, at least in our setup, the patient profile that we have. But there is a role when we are giving letrozole for 5 years. There is a role for bisphosphonates in this patient, ma'am.
Okay. So there is, so what we do is we give a loading dose of zoledronic acid to begin with in the beginning, 4 milligrams. And then if the patient has bony evidence, we continue to give them monthly or 3 monthly, or then we put them on oral bisphosphonates like osteophos or whatever. And it seems to have a wonderful effect in protecting the bones from metastasis. So this is how we would generally plan on this patient. And is there anything else that you would like to add to this entire case scenario? Anybody who would like to add anything else that we could do or not do in this patient? Seema, Shanti, Lakshmi, Ramya?
The response to chemotherapy, can you just highlight how did you assess it? Is it just by physical examination, or what other adjunct did we use in this case?
Okay. So we do a very simple thing on our patients clinically is we have the transparencies and we kind of document the 2-dimensional volumes, but we also do an ultrasound on the patients every 4 cycles. And of course that would be, and before we take up the patient for surgery, we repeat a mammography and an ultrasonography to ensure that, the volume of response both in the breast and the axilla. Does that answer your question?
Yeah, absolutely. Thank you so much.
Yeah. Can we move on to the next case? I think this is a pretty simple, straightforward, and majority of our patients do come in this category. That's why I took that as a first case. It's going to get a little more complex as we go on. Let's move on to the second case number. This is a 37-year-old lady, premenopausal, who again presented with a lump in her right breast since a year. She had no comorbidities. And that's her triple assessment. So how many of you all would say, how good is clinical breast exam in the triple assessment? And I want each of you to answer this, because this is something as clinicians, we rely a lot on our hands and our experience to understand how bad or good a disease is. So how good do you think is clinical breast assessment in diagnosing breast cancer? Seema, I take each of you all individually. Seema?
Yeah. Dr. Shilpa, yes, I depend a lot on clinical examination of the breast lump, and gradually with experience you can really assess the size of the lump plus the consistency of the lump. That is the most important thing, and the fixity of the axillary lymph nodes, whether they are fixed or mobile. So with your hands you get a fairly good, you can assess the tumor size and the axillary lymph node important. So I personally depend quite a lot on clinical.
You give it 100% on your plan. Shanti?
Yeah, I do depend, yeah.
Madam, for the patient satisfaction also, the clinical assessment is very good, madam, for the patient.
Absolutely. Yes.
So,
anybody else who disagrees with it? Yeah, sure, go on.
Then we'll compare both the breast, madam. During palpation, we'll compare the normal breast also. And axillary nodes also will palpate along with the examination, madam.
Sure. I think you made an extremely important point. I think the patient will feel cheated if you don't actually address the patient and examine the patient. And I think one of the strong points of Indian medical system is that we still have this interpersonal, reaction and relations with the patient. And I think as our students and other people are saying, we should not depend only on technology. And Tata Memorial has come up with a real bang, and it's mentioned on a 20-year study that clinical breast exam is equivalent to a mammography in diagnosing breast cancer to up to 1 centimeter of lumps. So it's a hard-hitting, real fact that clinical breast examination is one of the best techniques to diagnose breast cancer, and it's an easy method to train. And with this, we can really go into the interiors and diagnose more and more of breast cancer. So that's a point I wanted to make. a radiology. This was a patient had come with an FNAC, so this was a BIRAD 6. She was a ER, PR. She was a triple negative patient. She had triple negative disease. So how would we go ahead on this? Anybody can take this. Ramya?
Yeah, I just wanted to add a little note on the point on the clinical breast examination. It's a very, very important that we do it correctly and patient is reassured that we're examining. But sometimes I found difficulties in an obese lady to make out the axillary nerve. So sometimes you are a little not too sure, but of course our mammogram is going to help us with that. But definitely clinical examination is an absolute must. I agree with all of you. This patient, if you take the second patient, she's young, premenopausal. PET scan seems to show only a regional disease, definitely locally advanced breast cancer. So a couple of issues in a premenopausal lady is family history is very important. So what was the family history in this lady before we actually treat her?
She gave no history of breast cancer in the family or of a familial type. Neither history was present in this patient. But if you could say a few more words and line on genetic breast cancer, maybe a little bit more information on this.
Yeah, basically, when would we suspect there is some mutation, especially BRCA and other things, when a young lady premenopausal develops, especially a very aggressive triple negative tumor, and many relatives, maybe a sister, aunt, whatever, they have either ovarian or breast cancer at an early age in the premenopausal age group. That is when we suspect there could be some genetic mutation in the family, and that's when we advise some genetic counseling and tests to be done. This is the broad thing, the intricacies we can go in, but this is how we should suspect that it could be worth doing a genetic counseling for this patient.
Absolutely. Anybody else wants to add to this? So genetic counseling is not really entered in a big way in the Indian scenario yet. But anything else that you would like to add in terms of identifying high risk factors in patients, young patients with breast cancer? Dr. Durga, are you also part of this panel? Please join in. We would love to have your inputs.
One more thing we want to know is whether patient already
Other than radiation,
it's coming a little broken, the whole the sound system. I can't seem to hear you. Dr. Kopran Devi is joined in. Can you hear us? Dr. Durga, I can't seem to understand who is. Dr. Shanti, Seema, somebody can take this question?
Yeah, I think in continuation for that genetic counseling, if again affordability is a thing, but for BRCA1, BRCA2 testing, we may go in this patient. And one thing, Dr. Shilpa, I would like to add for the regarding the clinical examination. When we do a clinical breast examination, quickly we also examine the extra axillary lymph nodes. We quickly put our hand and feel the supraclavicular, infraclavicular, and the internal memory. So that was also one point which I didn't make earlier. And regarding genetic counseling, we can go for BRCA1 and BRCA2 in this estimation. I think for this patient.
So I think it is important for all breast clinics to have a genetic counselor on board, because it's not just about genetic testing, it's about identifying high risk individuals with the first, second, third degree of relatives having the breast cancer, knowing what is the thing. So I think it's going to soon be an integral part of breast clinic, and as we see more and more younger patients coming with breast cancer, we will eventually have to incorporate genetic counseling into our set of patients. Can we proceed further? How do we manage this patient? Lakshmi, do you want to take this up?
Madam,
how would you manage this lady, 35-year-old, triple negative? Dr. Lakshmi?
Yes, the patient is having T3N2. It is a locally advanced breast carcinoma. So that I want to evaluate whether the patient is having any metastasis. So after completing my metastatic workup, if the patient is
Ma'am, the PET scan is showing negative. The PET scan is negative for a metastatic workup.
Yes, yes. Yeah. So I will plan for neoadjuvant chemotherapy and the response, because already patient is having Sybil negative, and if the patient is responding, how much she is responding, and the first line of
History of radiation and history of obesity.
So what kind of chemotherapy would you recommend for this lady?
We can adramycin and
You're not coming very clear.
She is responding the first line like adramycin, whole cycle of adramycin, anthracycline. Yes, group of that. If there is good response,
yeah. So that's an important point, because so triple negatives respond very, very well to anthracycline based and taxane based chemotherapies, and because they are young patients, they tolerate TAC also extraordinarily well. So we gave this patient 4 cycles of TAC, and she had an excellent response to that pre and her post chemo picture. And post chemo, her tumor size shrunk to 2 by 2 centimeters, and the disease became N1, very small lymph nodes. How would you now proceed, Dr. Ramya, Dr. Seema? Who is Dr. Kopran Devi with us? I can't see her again. I saw her for a bit, and then I can't see her again. Is she there?
Madam, she is with us.
Okay.
You can direct questions. Okay. Her video is having some challenges, madam.
Okay, but she can hear us, right?
Perfectly.
Okay, so Dr. Kopran Devi, would you like to take up the management of this lady now that she has responded so brilliantly to post NACT?
Kopran Devi ma'am, are you with us? Madam, I would request you to redistribute the question, madam. Sorry about that.
Okay, Seema, take it.
Yeah. So, as in the picture above, ma'am, which you have shown, it's a large breast, and now the tumor is small, 2 into 2 centimeter after a good response, and the tumor seems to be somewhat away from the nipple areola complex. So I think a breast conservation surgery could be given a thought in this patient.
Sure. So that's the transparency. So that is where it shrunk from the red margins to the green margins. It really responded very, very well. My other question would be, how many of you all would give carboplat to a triple negative young lady? If somebody is using carboplatinum as a neoadjuvant or adjuvant, if they can join in, how many of you all give? Dr. Lakshmi, Dr. Ramya, Dr. Shanti?
We don't have much experience in giving carboplatin to these patients.
Okay.
In our hospital also we don't have carboplatin.
Okay. So we have started doing this for over the last couple of years in young patients with otherwise no comorbidities. And the response to carboplat in terms of overall survival and this thing seems to be really, really good. And the toxicity is not very high. So we've started adding carboplat into our regime of chemotherapy for triple negative, very young patients. And they seem to be doing well. However, this patient, like we all mentioned, underwent breast conservation therapy, continued with the adjuvant. We gave her carboplat, then she underwent radiation. She wanted some amount of fertility preservation. So how important do you think is the role of fertility preservation in young women with breast cancer? Dr. Ramya, Lakshmi, all of you could take this. This is an important question. If all of you could give me a one-liner on the importance of fertility preservation in young patients with breast cancer.
Very important, especially much younger than this lady. She's at least 37.
Sure.
If she's completed her family.
Madam
Younger
Shilpa ma'am, that is before chemotherapy, we have to clip the tumor, madam. Sometimes because of chemotherapy, the tumor may resolve completely. So before
absolutely, yes, we have to do that. Yes, definitely. So after the first or second cycle, we do an ultrasound guided clipping of the tumor. Completely take your point, because sometimes the tumors can just disappear totally, and we don't know which idea to this thing. So yes, absolutely, point taken. Yes, definitely. Can we come back to fertility preservation? Anybody can advise as to what we can, how we can manage this aspect of the ladies' issues? Ramya, you were saying something? Would somebody like to add on to this fertility preservation? Okay, so I think for
chemotherapy and radiotherapy patient may not have their regular ovulation.
Sure.
Earlier we used to do oophorectomy, but nowadays we are not practicing that. And we are one more thing. Patient may have the chances of getting the ovarian preservation.
This is before the patient wants to obtain.
You can do a oocyte retrieve much before we start chemo or radiotherapy. Preserve it, and then once everything is over, she can go in for IVF or whatever.
Sure, yes, and it's an important this thing because we are getting lots more people in their 20s getting breast cancer, and I think it's only fair that they are allowed this dignity of and choice. So yes, it's again another thing that's getting more and more important in the management. Let's move on to the third case. This was a 54-year-old lady, again premenopausal, no comorbidities, who presented with a breast lump in her left breast lump since a year. It's a 10 by 8 centimeter fixed lump in the retroareolar region with skin involvement. Mammography shows a BIRADS 5, and the core biopsy shows an invasive ductal cancer, which is triple positive. So that's the PET scan report. That's the staging of the disease. Dr. Seema, would you like to take us forward on this?
So this is N4. T4N2N0. So I think we'll have to plan a neoadjuvant chemotherapy, and as this is ER, PR and HER2 new positive, so there is a role of Herceptin ma'am in this case. So I think taxane based therapy with Herceptin would be the way to go in this patient.
Absolutely. So we started her with neoadjuvant 4 cycles of Herceptin with weekly paclitaxel, and these tumors respond amazingly well. In fact, I think the PCR is seen the most in these tumors with this added combination. So like mentioned earlier, it is very important to clip these tumors because they completely disappear after trastuzumab and paclitaxel. And that's the NOAA trial, the neoadjuvant trastuzumab trial, which has shown amazing responses for neoadjuvant trastuzumab. So again, I would like to make a point here that most of our patients cannot afford an entire year of trastuzumab, but we've at least been trying to give them these 4 cycles in the beginning with NACT, and it seems to be working as per whatever our medical oncologists are saying on this. I would really like to have your points of view on the use of trastuzumab in an Indian setting. How many of you all give the entire course? How many of you all do this? Please let me know. Seema?
Very, very rarely at our end.
Okay, Shanti?
Patients are not able to afford.
Shanti?
Madam, trastuzumab regime is... Madam, can you tell your question, madam, again?
Do you use trastuzumab on your patients?
Yes, madam. In this patient, trastuzumab is necessary, madam, because...
So you are in your setup?
In our setup, we are giving, madam. We are giving trastuzumab.
Okay. The entire year, entire 52 weeks of trastuzumab you are giving?
Yes, madam. We are giving, madam.
Okay, perfect. Perfect. Lakshmi?
In my setup,
no, in our setup, if they put this only they will give, otherwise we are not giving that.
Ramya? Yeah, Ramya?
The same thing. We have not yet started using as a new adjuvant, but definitely adjuvant we are able to give for those patients who can afford or who have insurance, because I work in a private institute. So we have been using it as when required.
Okay. So this is a choice that we have been given with about using the 4 doses. We've been using it in a government setup because it's impossible for us to get the entire year of management. But something being better than nothing, so I thought I'd mention this here. So this lady underwent a modified radical mastectomy, radiation, hormonal therapy, obviously trastuzumab. Now here the role of oophorectomy. How many of you would advise her to undergo an oophorectomy?
No, madam, because her age is 34 years, no?
Mm-hmm.
The role of
How many
oophorectomy
of
is
you
not no needed, madam.
Okay. Everybody agrees with this, or somebody thinks that it is better to convert her into a postmenopausal status and start her on this thing? Is anybody who disagrees with what has been mentioned?
No, I don't agree on the role of oophorectomy, but I have seen a couple of medical oncologists now and then asking for oophorectomy in a young lady like this. So what is your practice, Dr. Shilpa, and what is the rationale or no rationale in it? You can just enlighten the audience.
We try and provide as much rationale as is possible. Sometimes we go by the gut, but yes, we have started doing laparoscopic oophorectomy on these patients because they respond much better to a post oophorectomy status, and then we place the patients on aromatase inhibitors. The PCR, the overall survival, the recurrence-free survival is definitely much higher in patients who've been oophorectomized and then put on AI. But we have, again, very few numbers on this to really comment on it. But we have started the process in the last 4 or 5 years. Certain specific individuals whom we feel would do well, especially if they're triple positive, then we do consider oophorectomy on these patients. Does that answer your question?
Madam, what is the role of tamoxifen in this patient? Tamoxifen in this patient, madam, what is the role?
So the standard of care in premenopausal hormonal positive patients is tamoxifen for so long, but tamoxifen in younger patients, it is shown to have other issues. Endocrine cancers happen, other things happen. The response is not as great, so there's a conversion. But of course, 80% of our patients will still go on tamoxifen in the premenopausal age group. And even 90% would go on tamoxifen, and then we convert them into letrozole after the postmenopausal status. So of course, it's the standard of care for premenopausal ER/PR positive patients. But they need an annual endometrial thickness, and they do other things. So that is still the standard of care for sure.
Thanks.
Yeah. Okay. Now, this is just something to complete the thing, and this is something that we get all the time. This was a 45-year-old lady, postmenopausal, presented with a lump in her right breast since 15 months. Ulcerated wound. I don't know how many of you all get to see ulcerated wounds in the private sector, but about 20-25% of our patients come to us with an ulcerated wound. This was again triple negative, high-grade ductal cancer. This is how the patient presented to us. I would like you to tell me how you would manage this lady. Shall we start with Ramya? Go on to Lakshmi, Shanti, Seema?
Yeah, I think what about this is the initial assessment, and we see one ulcer and the fixed chest wall we have to assess. But I think the local treatment of the ulcer and the wound it should be done first. Then you see how well it is. Obviously, it will not close up because it's malignancy, but at least infection, everything should be taken care of initially, and then proceed with as you would proceed for a locally advanced.
So, okay, Lakshmi? Dr. Lakshmi?
Ulcerative cases, actually, nowadays we could get a locally advanced breast carcinoma and metastatic carcinoma in our hospital. The number has increased. Earlier, when I worked as an assistant professor, early breast carcinoma was there, but nowadays awareness is already reduced. So the cases with metastatic and locally advanced breast carcinoma with the ulcer proliferative lesion, so I have to work up that the patient is extended. And if it is metastatic, definitely we want to knock up the primary growth. So as early as possible, we will decide if patient is not having metastasis, we'll do a simple mastectomy.
Madam, it's a case of metastatic disease. It's a palliative treatment.
No, this is locally advanced. This panel is on locally advanced. This is a locally advanced breast cancer, not metastatic.
Metastatic.
Okay. So, Dr. Shanti, Dr. Seema, who would you listen to of the two? Would you actually go on and do an MRM in this case or a mastectomy, or would you manage the wound as was mentioned, control the infection, sepsis, work up the patient, and then go ahead? Dr. Shanti?
We have to admit the patient and take care of the wound, and then start neoadjuvant chemotherapy, and then go on to, after the response,
Perfect.
then go on.
Perfect. Dr. Seema?
Yes, I said that.
Yeah. So I think the only point of showing this particular slide was, especially for our juniors, that, we are tempted to go and do a debridement or a toilet mastectomy in these patients. That's what we used to do when we were assistant professors or earlier in our district. But I think that's a crime in today's age and time to do any kind of surgical procedure on a wound like this. It is imperative, even before you try to get a tissue diagnosis, that you control the infection. You take care of the wound, you treat the sepsis, you try and reduce the wound. We've been using vacuum assisted wound closures for this, IV antibiotics. And once we've done all of that, we then we get a tissue diagnosis, which gets a better yield, and then we start the patients on neoadjuvant chemotherapy. And you see sometimes wonderful results, and you see the whole thing kind of shrinking, the skin healing, and the patient becomes far more amenable to surgical management once all of this is taken care of. So that's the whole idea of showing this particular lady. And that brings me to the end of my
Dr. Shilpa,
yeah.
Use of
Sure.
wax over breast wounds, since how long you have been using? Because I have the experience of using wax in other chronic wounds, but on breast, these ulcerated lesions, I do not. So that is new for me. So how long have you have been using wax?
About a couple of years now, but we make sure that the chest wall is not involved. We ensure that the chest wall is not involved, and it's a wound which is only affecting the skin and this thing, and then we apply wax, and we're getting really good responses with this. Patients are very comfortable because they don't have to have the daily dressings and the debridement. It's quite painful for them otherwise. So patients are comfortable. Our residents are extremely comfortable because they don't have to do daily dressings, and the response is quite good. So we've been using it regularly for the last couple of years.
Excuse me, Shilpa madam, what's your experience of neoadjuvant endocrine treatment in locally advanced breast cancer?
My medical oncologist has been pushing me to try and use endocrine as neoadjuvant. So I have used it
because the
patient
who is unfit for
Yes. So we had a lady who was 94 years old, and she had ABC. So in those kind of patients, we have used neoadjuvant endocrine therapy. But as a surgeon, I am still not I haven't yet accepted it in my modality of management. So if you have experience on it, I would love to hear about it.
No, madam, it's not like that. Just I want to ask because neoadjuvant chemo is a must. We are giving premenopausal, postmenopausal fit patient without comorbidities. We are trying. But neoadjuvant endocrine treatment so far we have not yet started. That's why I asked your experience in that.
No. So like I said, very little experience. I prefer to actually, the patient is operable, I would prefer. We've operated also on 90 plus women, and we've done MRM on them, and they have gone home pretty, well. So if the patient is otherwise fit for surgery, I think the best thing is to go in and do a surgery on them. But in patients who are extremely unfit, then we could try it. And it does work well, apparently. The response is good, but I don't have much experience in this. Yeah. Okay. So that brings me to the end. I think I've tried to cover all the spectrum of LABC as much as is possible. I've had an amazing panel which has responded very well to the entire thing. And the best thing is this panel has been on consensus on every question. So I think we're doing something right in the long run in terms of management. Yeah, I'll come to each of you. You want to ask something? Was there a question?
Role of
Good afternoon, Madam Dr. Roloff.
Reconstruction in these patients after mastectomy.
Of course. I think it is imperative, especially in younger patients. We offer them upfront. We've tried oncoplastic techniques in certain individuals. We do the LD flap or the tram flap. Maybe not as often as we would like, but of course, it is imperative that you offer the patient the choice of having an oncoplastic procedure or a reconstructive procedure upfront or maybe later on. It should definitely be part of the choice making for the patient.
Reconstruction the same sitting or in the
Ma'am, whatever we most playtimes we do it at the same sitting. It's easier to do it in the same sitting.
Then what about the implants, madam?
So we don't have much experience with implants. Being a government hospital, again, the cost factor comes into being. So, but of course, implants, people prefer the saline implants, or they place in the implant and then they dilate it later on. So the plastic surgeons have a variety of implants that they can use. Most times, they put in the tissue expander and then put in the implant after they finish the entire therapy. So, and they put it under the muscle so that the implants don't shrink, contract. And now they use saline-based implants, so the issues are less. So people are using it very commonly, but we don't have much experience of it in our institute. Yeah. So coming to the end of this thing, so if each of you could give a take home for locally advanced breast cancer, what in your view is the most important thing that you would think in a patient of breast cancer? Let me start with Dr. Seema. If you have to give a take home message, Dr. Seema.
Yeah. So if it's a young patient, then genetic counseling or family history we have to keep in mind. Because nowadays I'm seeing that the profile of the patient, we are getting younger patients more. So genetic counseling, and as you have talked about fertility preservation, these are the things which we are not paying much attention. So I think after this meeting, we should pay more attention to this. Thank you.
Sure. Dr. Shanti.
Madam, younger age group, that is neoadjuvant chemotherapy followed by M.R. madam. And the recent concept is we can do a breast conservation surgery in the LABC. That is, if it is T3 also, we can give a neoadjuvant. The tumor, breast tumor ratio is very less. We'll do a breast conservation surgery, madam. That is the recent. Younger age group will do a breast conservation surgery. In older age group, that MRM is enough, madam. Followed with adjuvant chemotherapy.
Okay, Dr. Lakshmi. Do you agree with her that there should be a criteria for deciding whether a patient undergoes BCS or MRM? I think as we are growing older, I think the definition of young and old is fudging up. And I think a lot of my older women also come and tell me that they would like to preserve their breasts. So should age be a criteria in deciding whether a patient should be given the choice of modified radical mastectomy or breast conservation surgery? Dr. Lakshmi?
In my setup, what I feel is if we are asking the patient for a breast conservation surgery after locally advanced breast carcinoma, we have to follow up the patient regularly. Whereas if we do the MRM and whether there is micrometastasis to the other part of the breast tissue. So what I prefer in our government setup, locally advanced breast carcinoma after neoadjuvant treatment, we can do the MRM. Whatever the age of the patient, and if the patient is willing to follow up and everything, then it may be possible for us to do a breast conservation surgery, madam. And one more thing, if it is an ulcerative growth, one more, if it is an ulcerative truncating growth, and if it is not involved in the pectoral muscle, so we can do the mastectomy, and then we can do neoadjuvant, because most of our patients are coming for the ulcer growth, and they are not knowing what is behind when we want to do the neoadjuvant. But if the lesion is extending to the chest wall, definitely if we are giving neoadjuvant chemotherapy, 2 cycles or 4 cycles, then we advise them for the mastectomy.
Dr. Ramya?
from the discussion, we can understand it's a heterogeneous group of disease. Even though we call it as LABC, each patient, we have to individualize the treatment options for them. And definitely more and more we should consider for young ladies. Uh, the other point I wanted to stress was always offer reconstruction to these patients, whether upfront or later on, that option should be given, irrespective of the age of the patient. But we all agree that neoadjuvant followed by either mastectomy or BCS is a way to go. Thank you.
That's a perfect sum up. And so just to end up, there's a lot of resistance amongst government hospitals and a lot of people about doing breast conservation in locally advanced breast cancer. There's a large series from TMH and there's a smaller series from our institute wherein post neoadjuvant chemotherapy, LABCs do as well with breast conservation therapy and radiation. In fact, they do a little better as compared to patients who undergo MRM. So I think we should keep our minds open and offer these patients a good, well-selected, like Ramya said, it has to be a la carte approach. Each patient has to be individually decided upon. But if our patients can be given a quality of life, they can be given a breast, and it does not compromise their overall life quality, I think today we should be able to offer all our patients all the dignity and all the choices that is available to them for even locally advanced breast disease. I thank all my panelists. You've been wonderful. We've been having, it's been a really good, coherent discussion that has happened. I'll hand over the mic to Dr. Kanagavel and they can decide whether they're happy with the proceedings. I am extremely satisfied. Thank you very much.
Okay, thank you very much, madam. On behalf of our organizing team, we express our grateful thanks for a wonderful presentation in locally advanced breast carcinoma by the moderator, Dr. Shilpa Rao, and the panelists, Professor Seema Khanna and Professor Jishan Ahmad, Professor Shanti, Professor Lakshmi, Professor Ramya, and Professor Gopiran Devi. Thank you for the wonderful presentation. Over to you, Chairman, Dr. Kanagavel.
Thank you, one and all.
Thank you, madam. Thank you, madam.
It's been a pleasure to listen to the wisdom of Dr. Shilpa ma'am, the entire galaxy of national faculty who've been with us from morning. Special thanks to Professor Seema Khanna ma'am from Banaras University. Thanks to Ajay Khanna sir for getting me the link of that. Then Professor Jishan Ahmed ma'am. Professor Jishan has been always helpful and she is helping us for the PG clinics and other things. In spite of difficult situation for her, she could be able to join us. Thank you, Jishan ma'am, for all the efforts. And our friends and our Chennai faculties, Dr. Shanti madam, who's there with us in the university right now. She is a professor and head of the department KMC. Lakshmi Narayani ma'am is from Coimbatore. She's the head of the department in Government Medical College Coimbatore. Ramya ma'am, Gopiran Devi ma'am, thank you one and all for staying with us. And we have a very short lunch break for about 30 minutes. And I'm sure I'm very happy to share all the sessions are going on time. And it is 1:30 now and we have finished the morning session. Special thanks to the moderators and chairpersons for helping us to keep the time. So we have two more brilliant sessions lined up in the afternoon. One on thyroid and especially it will be a very focused thyroid discussion on well-differentiated cancer. And the most exciting emergencies for the general surgeons come from the gynec colleagues. So that will be the highlight of the event. We look forward for all of you to stay with us. Let us get back to you in another 30 minutes time with a short break. Thank you. Bye-bye.
Thank you.
Thank you, Shanti.
Thank you.
Shilpa ma'am, can I request you to unshare the screen, ma'am?
Sure.
Thank you, one and all.
let's move on to next topic is a well-differentiated cartoon officer. It is one of the fascinating topic. I think all the panelists are very much interested. I would like to have the immense pleasure to introduce chairperson, Professor Dean Nirmala Madam, Coimbatore Medical College. So first she has joined in the Government Medical College Hospital in ESI. So that time she had rendered tremendous service to the coronary patients. So all the teams, medical team, Nirmala Madam's medical team, who saved more number of COVID patients. So our Honorable Prime Minister, Chief Prime Minister Ji, appreciated the Nirmala Madam. So across the country, it's one of the best hospital, government hospital, Coimbatore ESI. So the hearty congratulations to the Nirmala Madam.
Thank you, sir. Thank you, sir.
Yes, madam. So she is also my classmate. Both of us joined in Coimbatore Medical College in 1998. Just remember me.
Thank you.
So.
Yes, sir. Thank you.
So now I invite the Professor Dr. Ali Madam, Dean, Ramanathapuram, Professor P.S. Santi Madam, MMC, Dr. Sai Vishnupriya is a surgical endocrinologist. Now at present is working in MMC. Dr. K. Pungudi, GM KMC Salem. Dr. Malaruli, Stanley Medical College. Now I would like to call upon Dr. Chandrasekhar to introduce the moderator, Professor Surdi Kamal Madam. She is a professor of HOD Department, Savita Medical College.
Good afternoon to all. So after the lunch, we start the program now. It's my privilege and introduce my professor, my teacher, Professor Surdi Kamal Madam, to the chair. He's a well-renowned surgeon and a teacher for excellence in Tamil Nadu. Now he is working as a HOD of Savita Medical College, a retired professor from Madras Medical College, Stanley Medical College and Chengalpattu Medical College. Her period in Chennai as a Chennai City chairman is a very excellent and golden period. She did so many new things and innovations in Chennai City ASI. She got the best. She got the best chapter, and also she has the best teacher award from Savita Medical College, and she got the outstanding Women Achievers Award from Tamil Nadu Dr. M.G.R. Medical University, and we gave Chennai City ASI the Best Surgeons Award from our Chennai City branch to Madam. So again I welcome our professor and our mentor, Professor Surdi Kamal Madam, to this session. Welcome, Madam. Welcome. Thank you. Okay, Madam. Over to Madam.
Over to you, Madam. Sorry.
Good afternoon to all of you. Respected Vice Chancellor Madam, Professor Sudha Seshan Madam, who is a great academician who has given an opportunity and a steering force for this program today, so that it benefits all and not only puts the due recognition for all the women surgeons, along with the ASI Chairman Professor Dr. Kanakavel, Professor Dr. Muthukumar, Secretary Dr. Chandrasekhar, and Dr. Pandyanaraj and Professor Kannan, and I'm so happy, and all the women surgeons who have gathered today along with us in this panel. So we'll start off. My great respects to Professor Nirmala Madam, who is there amidst her
Thank you, Madam.
very
Thank
busy
you.
schedule. You are there, ma'am. I'm so very happy that you are also along with me, and it's a very difficult job for a moderator because is almost like conducting an examination for my panelists, but this is to benefit the larger gathering of all the young surgeons because they like to know what to be done, what not to be done. So with that few points, I'll start off, and I like to introduce my panelists. Our panelists will be Professor Dr. Ali ma'am, who is from Ramanathapuram, and Professor Shanti from Government Medical College and Hospital, and Dr. Sai Vishnupriya, who is endocrinology surgeon, Madras Medical College, Dr. Poongodi, who is in SKS Hospital, Salem, and also she is attached to MMC Chennai. So with these panelists, we'll start off, I think, a little about the introduction to this. Thyroid is a very vast topic, so I thought we'll just start off with the well-differentiated cancer alone we thought of discussing. Regarding the well-differentiated cancers, as you all know, it is the papillary carcinoma thyroid, the follicular carcinoma thyroid, and all their variants and subtypes, and also the Hürthle cell cancers which we have. So most of these questions have been framed keeping in view that the audience is mostly the postgraduates and young surgeons out there to have a clarity of thought as to what to be done. So with a small introduction like that, I want to first ask my colleague, Professor Shanti from Madras Medical College. I'd like to know what are the potential biological factors that can cause these thyroid cancers, and what is its, why is there such an increase in incidence also?
Thank you, ma'am. First of all, I think well-differentiated thyroid cancers, mostly the most important causes is familial. We have to take most of the thyroid cancers, familial background is there, so we have to ask for the family history, and that to any first-degree relatives, 2 or more first-degree relatives who are suffering from thyroid malignancy, that has got more importance regarding either papillary carcinoma or follicular carcinoma. And the second most important is whether they are having any history of irradiation and any radiation exposure, not even radiation treatment, maybe irradiation exposure like Chernobyl and some other radiation exposure events would have happened in a childhood. Maybe that the chances of getting malignancy is only after 20 to 30 years later. So any history of radiation exposure, radiation therapy for any thymoma or adenoids or tonsils, everything we have to take. And also any history of iodine deficiency. In some places, iodine deficiency is one of the factors for getting a follicular carcinoma, whereas iodine rich is for papillary carcinoma. And also any thyroiditis. History of thyroiditis also plays an important role. And the increase in its incidence may be because of our lifestyle modification and the food habits and our stress, and all the factors may add more number of thyroid cancers we are seeing at present, I think.
Absolutely. Thank you very much for that a very lucid thoughts on this thing. Could I, if you permit me, maybe I could add some more 2 points. When the dietary nitrates, especially the higher consumption of beets, the beetroots, which are very high in nitrites, also can be causing this. And also smoking has got some kind of relationship to this. And also the obesity, whenever the BMI is very great, more than 30, they have an incidence of this malignancy that is there. So these are the things, obesity per se, not only for breast cancer, but also for the thyroid malignancy. So we do have this. So excellent, ma'am, you have covered everything. So then next, I'll go on to the next one. See, this question I will put to Dr. Ali, ma'am. What is the radiation exposure that is causing these differentiated thyroid cancers? I like to know, is the age at which the exposure happens, is it very important? Is there anything to do with this dose dependency? And how many years after an exposure one could get this malignancy? Dr. Ali, ma'am? Is Ali, ma'am, online?
Madam, I think Ali, madam is yet to join.
Okay.
And they have Actually, I will ask you to request to put the question to the other faculty, ma'am.
Yeah.
We have Dr. Pumudi and Dr. Shai
Shai is
Vishnupriya, they
there.
are available.
Yeah,
Or we
okay.
have the next session faculty with us, Professor Dakshayani ma'am and Gayatri ma'am around
Yeah.
here. Maybe we can accommodate
Yeah.
them.
How about Dr. Pungodi is there?
Pungodi.
Dr. Pungodi, madam, or Dr. Sai, whoever is there, could you take up this question?
Pungodi is there. Madam, Pungodi is there, madam.
Yeah, can she answer this question?
Pungodi, please.
Are you able to hear me, ma'am?
I can.
Pungodi.
Yeah, I can
Radiation
hear.
exposure,
Yeah.
especially radiation exposure within 5 years of age increases the risk of thyroid malignancy.
Okay.
Both ionizing radiation as well as radiotherapy increases it. So there are documented cases that 5 years after the exposure to radiation, but the risk increases with duration. Like it's usually after 10 years of. Are you able to hear me, ma'am?
Yeah, we are hearing you. So what madam is saying that less than 5 years of age, that's what you said. The exposure is very important, and also if more than 10 gray and more than 20 to 30 gray, if it is the patient is exposed, they do have an incidence of developing a cancer. And also even less than 1 gray also one could get, though incidence is less, but if it is confined to the neck alone, even if it is less than 1 gray but it is confined to locally to the neck, there is an increase in that thing. So you have answered that. Thank you very much for helping me
Madam,
with this.
especially the history of Madam Shruti madam.
Yeah. Yes, ma'am.
You have to ask whether they had it in the childhood or whether there is any.
Yes. Yeah, childhood, you especially the
Hello, madam.
rhabdomyosarcomas, which are very common in the head and neck tumors, in the head and neck when they get the radiation,
Yes,
or
madam.
lymphoma for that matter, thymoma for that matter,
Lymphoma,
and also
madam.
the bone marrow
Especially lymphoma.
yeah, the BMT, bone marrow transplants, when they have the whole body radiation, also there is an increase in this kind of cancers. So, thank you very much, Dr. Pungodi. Can I go to the next everybody? Yeah. Next stage. Third. Can he help me? I want to go on to this other slide. Third slide.
Professor Nirmala madam, please use any one system madam. There is some sound.
Yeah,
madam. Please
too
madam.
much of sound is coming. Hang on, bro.
Welcome, Professor Ali madam also. Ali madam also joined, I think. Welcome, Professor Ali madam.
Yes.
Ali ma'am, welcome.
Yes, ma'am. Good afternoon.
Panel. Yeah, thank you.
Good afternoon, madam.
Yeah. This question I will put to Dr. Pungodi. What is the actual relationship of the thyroid cancer to this autoimmune disease, Hashimoto's disease?
Recent studies have shown.
Yeah.
Recent studies have shown that this incidence of coexistence of thyroid cancer, especially carcinoma, they have found that especially the molecular signatures, as you see that the most common genetic alteration in thyroid cancer is BRAF mutation, whereas in patients coexisting thyroid cancer and autoimmune thyroid, especially Hashimoto's thyroiditis, they have a different common mutation. Like RET PTC, RET1T is more common, and they have found that the incidence of lymph node metastasis is relatively high in subjects with coexisting papillary thyroid cancer. But although the lymph node mets is high, in one of people, one of study they say that the aggressiveness of the disease increases. But at the same time, there is another school of thought that immunity preventing, decreases the incidence of cancer.
it some kind of an inflammation that is producing a neo-angiogenesis in this Hashimoto's disease? Is it because of that?
Yes, exactly.
Is it because of this HLA genes and also the thyroid specific genes that are there that leads to an atrophy of the gland and replacement of fibrous tissue and neo-angiogenesis? Is something to do with the vascular endothelial growth factors also that is found in this Hashimoto's? Do you think so?
Yes, ma'am. In thyroiditis, there is, as we know, it's a spectrum of autoimmune disease. One end of it, you have this Hashimoto's thyroiditis. On the other hand, you have the Graves' disease. In between, you have chronic lymphocytic thyroiditis. So there is infiltration. There is bringing in of cytokines and other growth factor, vascular endothelial growth factor. All these induces neovascularization, and the check in the is also arrested at some point of time. This number of mutations, and of the commonly identified genetic conflict that PTC rearrangement. So this vascular endothelial factor already increases the neovascularization, and over a period of time it may progress to papillary thyroid.
That's a very great answer. I'm so happy. And
so this vascular endothelial factor already increases the neovascularization, and over a period of time it may progress to papillary thyroid.
That's a very great answer. I'm so happy. And I would still pose one more question to you. What is your approach to a thyroid nodule? In very simple words, you tell our people how exactly to approach a person coming with a nodule in the thyroid.
Simple thyroid nodule, first is thorough history taking and physical examination, as the previous speaker told. The history, high risk history with regard to childhood exposure to radiation, then the rate of onset, rapidity of growth, recent onset, rapid growth, and the new response. All these things are very important during and the next is non-invasive ultrasound of the neck, especially surgeon added ultrasound high frequency and see whether it is how it is appear. Now we have sonographic pattern to talk about the risk of malignancy, like solid, hyperechoic, taller than short, taller than height, the presence of changes in the intracoilotic vascularity, punctate calcification, which does not cause posterior shadows. It's all favorable for the malignancy. Usually we take free T3, T4, TSH, that is the thyroid. So sonographic pattern, especially the FAC, is features. You can go ahead with the effect.
Madam, excuse me. Audio is not at all good, madam. You are not able to hear.
You are not able to hear, ma'am?
Yes, it is not clear. You are able to hear, but it is not clear, I think so.
Madam, it will correct soon, madam. No issue, madam. Pungoli, madam, please, please. Pungoli, madam, please go ahead, madam. It's clear now. Please, madam. Pungoli, madam.
So, one thing is we high frequency ultrasound of the neck. We see for the sonographic pattern. So this thyroid nodule, which are solid, hypoechoic, punctate calcifications are present, taller than wide configuration, and presence of any suspicion, such is more likely to have hyperpregnancy. So we go for the present recommendation is ultrasound guided FNAC. So
Dr. Punkudi, the more questions on ultrasound we are having. In a very simple manner, just how to approach a thyroid nodule. So what you said was you will do a T3, T4 TSH, and if the TSH is going to be very low, you want to find out whether it's an autonomous nodule or not. If it's something like a hot nodule, you're going to do a radioactive iodine uptake scan and then proceed further in the evaluation of a nodule. Thank you very much for that. And yeah, and next I will go on to the next question. What kind of a history should be taken for patients with well-differentiated thyroid cancers? And so this question I will put to Professor Malarvili from Stanley Medical College.
What kind of history should be taken for patients with well-differentiated cancers, ma'am?
In patients with well-differentiated cancers, they may come, of course, with swelling in front of the neck, which is either detected by her physician or by a general physician, or by someone who is close to her in the family may have discovered a swelling in the neck instead of the patient herself noticing it. That could be one presentation. Then regarding history, we are supposed to ask history of head and neck irradiation, as we already discussed in childhood. Then family history of cancers, mainly thyroid cancers, but also other cancers like those of Cowden's or Gardner syndrome. Other cancers in the family should also be taken into account.
Yeah, that's you have answered everything. The chronic complex also can add up in that. And also, like you were saying, the family history is very important, because you have these papillary cancers. If more than 3 relatives, the first degree relatives have it, so they also can have that. It can go in the family. Excellent, ma'am. So the next question will go. What are the clinical features that would suggest a malignancy? Do you think a good clinical examination still scores over, in making a diagnosis? This is for our Shanti ma'am.
Yes, madam. I think clinical features of malignancy is very important, and a good history taking as Dr. Malavi told, good history is also very important. History of any sudden increase in size of the swelling. From history, we should ask whether increase in size of the swelling, or any pain over the swelling, or any sudden increase in the pressure symptoms, or any change in the voice, or any other nodules like any lymph nodes if they are having. We have to ask for the history first, and then followed by a good clinical examination is still important, because if there is a sudden increase in size or hard, gritty, solid nodule is more in favor for a malignancy. Along with that, if there is involvement of the pressure symptoms, like involvement of the surrounding perithyroidal tissues with change in the voice, or involvement of the recurrent laryngeal nerve, or any palpable lymph nodes are there, or if there is involvement in encasement or invasion into the surrounding structures like carotid, berry sign is positive. All this makes us think it is more in favor for a malignancy. Now, I think we can add ultrasonogram, which is nothing but an extension of the clinical examination nowadays. We can always add ultrasonogram, which gives us more features of malignancy. I think so. A good clinical examination we can make a diagnosis, madam.
So by far, when it is gone extra thyroidal and it's very large, you still can make a diagnosis. Only thing is, when the nodules are non-palpable, still the patient may be having yet a malignancy being harbored inside, for which you said an additional, as a part of our clinical examination, ultrasound is very, very important. Excellent point for these juniors to take home. And the next one. What are the clinical features of follicular cancer and Hürthle cell cancer? This question I will ask Professor Malarvili ma'am.
Hürthle cell, of course, as we know, is quite rare, and it's a variant of follicular carcinoma. The main clinical features which tell that it is Hürthle cell is there is more, patient may present with a painful swelling, plus all the pressure symptoms may be present, like recurrent laryngeal nerve involvement, so hoarseness of voice. Even Horner's syndrome is supposed to be more common in a Hürthle cell cancer than any other papillary etc. As well as there can be a bulky cervical metastasis also in Hürthle cell cancers. So that is the differentiating point.
That's a very good point actually, which you have said. Most of these Hürthle cell cancers will present with lymph nodes, So that's why when we get lymph nodes, we have to think about Hürthle cell malignancy, the PAPCA, medullary carcinoma, and also the Hashimoto's with PAPCA. These are the things. That's a very nice point which you have said. And yeah, and mostly these Hürthle cell ones, it's malignancy, they are very aggressive, like you said, a tendency to fix up there. But in a follicular cancer, it's more of like a nodularity which is there, and also it is very dense. That is what I thought. Very good. And they go hematogenous. And when we come to ultrasound features in a thyroid malignancy, so it's a very nice point actually. Many points are there for interpretation of ultrasound. I will pose this question to Professor Ali ma'am. Are you there, ma'am? What is the role of ultrasound in imaging?
Madam, Professor Ali, madam.
Are you
madam,
there,
please.
Yes,
yes.
We are able to hear.
Yes, madam. Yes, madam. Please, madam.
Yeah.
Yes, madam. Yes, yes.
We are hearing.
Please go ahead, madam. Please. Go ahead.
Yes. Ultrasound is a must for all patients with the swelling, sir. Actually, suspected thyroid node or typically patients when comes with thyroid swelling. First, examination of examination is the ultrasound. Actually, it can detect undetected in 20% of the cases. 20 to 70% can diagnose. Yes, we are
Your voice is breaking, madam. Your voice is breaking. Madam, Ali ma'am, kindly switch off your video so the audio quality can definitely improve, madam. Now you speak, madam. You are good to go. Yes, madam. Ali ma'am, please go ahead.
Yes, can you hear?
Yeah, clear.
Now I am audible, sir.
Madam, perfectly, madam.
Am I audible now?
Perfect, madam. Perfectly
Yes,
okay.
Yes, yes, sir. Yes, sir. Ultrasound is the first palpable patient coming with swelling. Have to do
So I நிறைய இருக்குது அவங்க நிறைய இருக்குது நிறைய எக்கச்சக்கமா இருக்கு. So
madam, please.
Can I proceed, madam?
Yeah, madam.
Yes, madam.
For a long time we are getting some problem with your audio. Can you set it right, ma'am? Is it okay now?
Yes, madam. Can you hear me?
Yeah, we are able to hear you.
Yes, madam. Very clear. Please go ahead, madam. Ali madam, please.
Clinically non-nodules in 20 to 7% of the cases. Actually, it helps in diagnosing the swelling, number of the nodules present in the thyroid gland, and the character of the nodule, which whether it is a solid, stick, or viscid. And also it helps in the efficacy from where the efficacy has to be taken, whether it is from the most dominant nodule, the most affected nodule. And also you can diagnose the lymph node status, whether the lymph nodes are involved or not. Madam, there is a
yeah. So madam has said for the younger people, whenever you do an ultrasound, you need to see three things. One is the nodules, the number of nodules, whether it is gone extrathyroidal, the surrounding area, and the involvement of the nodes, whether it is benign or malignant. So when it is a benign, it is going to be a spongiform or cystic lesion that you are going to be there. And also if it is going to be a malignancy, how is the edges of this nodule? Any irregularity is there? Any microcalcification is there? Is there an extrathyroidal involvement that is there? Is the nodules taller than wider? That is very, very important. That is going to be. And the most important is the vascularity that is there. The internal vascularity which is there, that is going to tell us. And as regards to the nodes, you need to see in the central compartment, if any, what is the shape of the lymph node. First of all, it becomes abnormal, it's going to be spherical, and loss of fatty hilum that is there, in addition to the microcalcification which we see. So with this, because of the audio, we are not able to, so I'm just sticking this across. Thank you very much, ma'am, for that input. And next I will go for certain recent advances. We do hear about certain words like, elastography in the case of thyroid cancers and the contrast enhanced ultrasound. Now I would pose this question to the endocrine surgeon, Professor Dr. Sai Vishnupriya. Can you take it, Sai, for me?
Yes, ma'am. Yes, ma'am. Very good afternoon to Chairperson, Moderator, other professors, and my dear colleagues. It's a pleasure to be here. So I'll go directly to the question. The first thing is about elastography is a recent advance which is not really available in a lot of places. But still, for the postgraduate sake, it is basically virtual palpation. It helps to find out the stiffness of the tumor. So if you know that in cancer's thyroid, it gets more harder, firmer, harder. So in cases where like FNAC is not able to give you the diagnosis, it's an add-on. So basically there's the strain elastography and shear wave, but just touch it like there are gradings, 1 to 4, it could be color-coded or gray-coded, and depending on the stiffness of the tissue, you could have the gradings, and the more stiffer and harder it is, it points towards malignancy. But of course there are things like thyroiditis and all, where there is a lot of fibrosing and all happening. There are like issues. Still it can be added as an add-on investigation.
Maybe you think that it will be an add-on for the long-term follow-up of your patient whom you're thinking it is benign?
Yes. Yes, yes. For long-term follow-up, yes. It is like when you do an ultrasound, this has an add-on, but especially when you're following up benign tumors, yes, ma'am, this could be added on.
Regarding my question, the contrast enhanced ultrasound, how beneficial is it?
Contrast enhanced ultrasound, actually we now go on for Doppler basically, ma'am, more than contrast enhanced. You can actually find out like it in the ward itself. It's very easy to do the Doppler one where you can see the carotid and the IJV, and especially in older patients also we can go up to the upper part of the neck. So we prefer Doppler ultrasound more than the color, contrast enhanced.
Some of the things they say that you can give this sulfur hexafluoride, in the form of micro bubbles, you just give them and it enhances, especially the peripheral vascularity which you are seeing in this contrast enhanced CT, the ultrasound. It helps a lot, that's what. Yeah. So this is just in case what's happening, around. Okay.
Yes.
Next, another question. Is it same to sign the list? Yeah. I also want to continue with Sai. What is your thoughts on this FNAC of the nodule, the primary in the thyroid, and also the FNAC from the lymph node, and you take it and you do a thyroglobulin washout? How helpful is this test?
FNAC is the prime investigation for as far as thyroid nodules are concerned. But recent add-on is the thyroglobulin washout that we have added on, especially for lymph nodes, where the direct FNAC is not very conclusive. So when you do the thyroglobulin washout, and if it is less than 1 nanogram per ml, it is actually very reassuring. And they say if it's like around 32, the specificity and the sensitivity of malignancy increases. So it's more useful like in cases where FNAC is not very sure of.
That's a very nice point, valid point you have got. That is, when the primary thing is inconclusive, but if the lymph node is showing some positivity, that is going to help the surgeon in deciding about the further course of management. Thank you very much, Dr. Sai.
Thank you, ma'am. Thank you, ma'am.
I would go to the next row. What is the role for this molecular diagnostics in the evaluation of a thyroid nodule? I would ask Professor Malarvili, ma'am.
Again, thyroid nodule as assessment of a thyroid nodule has a set algorithm. Where the olden days, the textbook, they say that after the physical examination, then ultrasound, then FNAC is not going to be conclusive. So next is diagnostic lobectomy. But instead of diagnostic lobectomy, this step is come in now, where you do a molecular testing to find out whether you're going to monitor the swelling or you're going to straight away do a resection. So that is how molecular testing helps, and there are two molecular testings which are approved by the American Thyroid Association, like this AFFIRMA gene expression classification and the ThyroSequence. I think ThyroSequence 5 is the latest, I think. Of course, all this is only theoretical knowledge for us because we don't have personal experience about molecular diagnostics. But this is what I have gathered from the theory.
So. Yeah. So it is always helpful for this atypia of undetermined significance.
That's an indeterminate, Bethesda, indeterminate cytopathology.
Undetermined significance. Yes. And also, like you were saying, the BRAF, the genetic mutations, yes. And the RAS and other things, which can be studied in this molecular, because it helps us to identify what is the type of malignancy we are actually dealing with, and how exactly to go further from then. And the next question to Dr. Sai will be, we always do FNAC, but sometimes people ask, is there a role for core biopsy in a thyroid malignancy? Is there a core biopsy?
There are very few indications. Yes, we can do MEM, and very few indications, especially like it because it's for postgraduates. I would say in a case of malignant lymphoma, if for IHC purposes, anaplastic carcinoma, because it's very difficult, like FNAC will not give you much tissue. And the other thing is, some cases of medullary carcinoma, thyroid also we do, and we do calcitonin assay. So these are the main indications I would say for.
Would you recommend in a follicular CA?
Actually, there are cases where atypia is there. There are certain studies that say that we can do, but regarding guidelines, we actually don't use it for other tumors. But yes, for unidentified atypia and all that, yes, a core biopsy can be done.
Thank you very much. I will go on to the next question. What is the role of CT, MRI in thyroid imaging? And is there a role for FDG PET at all? This question is for Dr. Pongudi. Pongudi, ma'am. Dr. Pongudi, are you there on the line?
Yes, ma'am. Am I audible? Because I changed to the headphones. Yeah. So CT imaging, like high frequency ultrasound of the neck is the best imaging. However, since there is an air column, the central compartment lymph nodes will not be visualized so much. So contrast enhanced CT, previously because of this iodine interference it was taken. But now the materials which we use have improvised. Therefore, contrast enhanced CT, which provides a roadmap to tell us about the retrosternal extension as well as the presence of central compartment lymph nodes in a better way. Of course, besides that, we have this blood vessels, encasement of the carotid vessels, and prevertebral fascia. The soft tissue resolution will be better in MRI and CT. The FDG PET comes to play a role, especially in the follow-up of the patients after papillary thyroid cancer, especially post-operative status, after total thyroidectomy with or without neck dissection, especially equally differentiated thyroid cancers and Hurtle cell carcinoma, where the uptake by radioactive iodine is relatively less. There is a phenomenon called TNMGRMU syndrome, thyroglobulin elevated non-iodine avid syndrome.
Here what happens is usually differentiated thyroid cancer, after completion thyroidectomy, we monitor them with serum thyroglobulin and iodine scintigraphy scans. So since here thyroglobulin may get elevated, but iodine tapping will not be there. This is called Ender syndrome. But it indicates that the cancer is progressing. And one point of time what happens is indicates that this is the differentiation. So that is the place where this PET FDG PET plays a role. Here, the iodine scans will not show the uptake in the thyroid bed or the distant metastasis, whereas FDG PET will pick up. So this is called flip-flop phenomenon. So therefore, in order to in differentiated cancers when there are METs, so FDG PET plays a role. FDG PET CT fusion image plays a role in picking up these distant METs which are not iodine avid.
So something that is not iodine avid or not taken up by the radioactive iodine, FDG PET has got a use, and the CECT especially more information about the vascular encasement of the carotid artery, the lymph nodes, and all that, whatever extrathyroidal involvement, substernal as you were saying, it is going to help us a lot. Now, I would like you to say a few points on what are the variants of papillary cancer, what are the subtypes of follicular cancer, and what are the pathological hallmarks of a PAP-CA. If you could tell.
Yeah, thank you, ma'am. Papillary thyroid cancer.
Since we are running short of time, just only some key points if you say, carry home light, that would be great.
So, papillary thyroid cancer is a follicular cell-derived tumor with classical nuclear features. So, the most common salient features are the papillations. When these follicular epithelial cells are thrown around the papillae, around the central fibrovascular core, this papillation is a salient feature. And samoma bodies, its calcifications at the tips of the papilla, and often anenucleate. There is a characteristic nuclear clearing which is compared to often of a cartoon character. Pseudonuclear inclusions, and there is chromatin clearing, thin granular it becomes. These are the classic features of papillary cancer. This is conventional papillary thyroid cancer. We have other subvarieties, namely follicular variant of papillary thyroid cancer, tall cell variant, columnar variant, trabecular, diffuse sclerosing. These are more aggressive variant. Besides that, we have solid insular type, papillary thyroid cancer with coexistent medullary thyroid cancer, hobnail variant, etc.
Oh, that's good. Now I'll go on to this prognostic scoring for this well-differentiated cancers. Tina. Professor Malarvili, ma'am.
Prognostic scoring for well-differentiated cancer, as we all know, has these depends on the age, the grade of the tumor, the extent beyond extrathyroidal extension, and size. So AGES and AMES. M is metastatic. MASIS. So those are the factors, prognostic indicators.
So a little about this Bethesda's system of reporting the thyroid cytopathology. How useful it is. This question will be to Dr. Punkodi, or you will take it, ma'am, Shanti, ma'am. Okay, Dr. Punkodi, just in points, if you could tell that. The Bethesda system of reporting the thyroid cytopathology.
Yeah, the Bethesda system for reporting thyroid cytopathology is a standardized. In order to standardize the reporting of FNAC throughout the world, it's a sick thyroid system. It also tells us about the escalating risk of malignancy associated with each category, and also helps us to tailor the management, make a clinical decision. So there are 6 types. First, number 1, category 1 is cystic fluid only, that is non-diagnostic or unsatisfactory. So the risk of malignancy is around 1 to 4%. So that if you have, it should be less than 10% in any system. So you call it as an adequate cytology only if there are well-formed follicles containing at least 10 thyroid follicular cells. You call it as adequate cytology.
So if this is present, in such a case, you have to proceed with ultrasound guided FNAC, which improves the yield of the cells. Number 2 is the benign. Category 2 is benign. So the risk of malignancy is 0 to 3%. And according to the type like thyroiditis or adenomatous hyperplasia, you either wait or proceed. 3 is atypia of undetermined significance or plus. Plus means follicular lesion of undetermined significance. Next category is suspicious of follicular neoplasm or follicular neoplasm. These two will come under the indeterminate category. So in this atypia of undetermined significance, the risk of malignancy is around 5 to 15%. And in the follicular neoplasm, the risk increases from 15 to 30%. These are indeterminate. And in order to make a diagnosis, you have to go for a minimal procedure of surgical lobectomy and completion lobectomy, or you can go for total thyroidectomy based upon the risk, like familial history or risk of increased risk, like history of radiation, etc. And then comes the fifth one, which is suspicious of malignancy. Here the risk of malignancy is around 60 to 75%. And final category is sixth category, which is it's very diagnostic of malignancy. So, as you know, in FNAC, you cannot make a diagnosis of follicular carcinoma. That is where the indeterminate category, suspicious of follicular neoplasm comes. So, the minimal procedure will be diagnostic lobectomy and such as.
So, right from category 3 to 6, we got to be very careful. 1 and 2, you can be a little relaxed. That is what this Bethesda's cytopathology system is helping us. Suppose next I will go to Dr. Sai Vishnu Priya regarding this. Suppose you have a FNAC proven PAPCA, when will you do a hemithyroidectomy? What are the indications for total thyroidectomy? Just in 2-3 points you tell.
Okay, yes. So any FNAC proven PAPCA, it's only total, it's surgery. There's nothing else. So when do we decide? Say, if there is any lesion more than 4 centimeters, if there is gross disease, extrathyroidal invasion, and if there is still lymph nodes metastasis, we will always opt for a total thyroidectomy. We will not go for of course, there are other risk factors also like family history and male sex, age more than 45. But this is like total thyroidectomy. In other words, there are also indications when you will go for lobectomy. If it is unifocal, it is intrathyroidal with no invasion. And if there are lymph nodes, there are no lymph nodes. And if there is no family history, you can very well go for a lobectomy. So these are the two things, and there is an in-between class also, 2 to 4 centimeters, where there is a little, you'll have to decide.
Okay. So that's very clear. So next I would pose one more question. When will you do a prophylactic central compartment neck dissection? What is the indication for a therapeutic central compartment? And just in 2 points if you can tell us.
Yes. Prophylactic central compartment dissection we do when if there are T3, T4 tumors, we will add on a prophylactic even if there are no lymph nodes. That is the usual criteria. But as of now, we do prophylactic normally, but this is the criteria. So when we will do a therapeutic is when there are lymph nodes in the central nodal compartment, you will do a central nodal compartment dissection. And if there are proved nodes in the lateral compartment, then you will go ahead with a modified neck dissection. So this is the criteria.
So the first echelon group of nodes of the central compartment naturally. If the lateral nodes are there, definitely it has to be removed. That is one thing.
Yes.
And when it is proven either by a frozen section biopsy or macroscopically it seems to be suspicious, you go ahead and do a therapeutic. But
or a bigger tumor, thyroid tumor.
Yeah. And for something that does not involve the capsule or extrathyroidal and all, routine prophylactic central compartment, will you recommend for a PAPCA or you will
not? Not yet.
You will not. Okay.
That's what, if it is less than T1, T2 or less than that, actually it is not required. These have not proved that it is efficient enough.
What are the preoperative or intraoperative features that make you decide on a total thyroidectomy? And what is the indication for completion thyroidectomy? Are we running out of time? Yeah, we'll finish
Okay.
off one. That's a
So, preoperative, as I told you, ma'am, anything which is more than 4 centimeters, a cross disease, extra infection, anything that preoperatively you know, any distant metastasis. And intraoperative, if you suddenly find nodes, you suddenly find that there is bilateral disease, you find an extra, all these features are the same for preoperative, intraoperative. So in case for, yeah.
When we are doing a completion thyroidectomy, for you have done a hemithyroidectomy or a lobectomy, you want to do a completion thyroidectomy, what is the timing of this procedure? When will you do? Are you doing it in the first week or you want to wait for 4 weeks and do it?
No, I will do it immediately as I know, because that will help you in easier surgery. So anytime, the first week will be easier.
Suppose your pathologist takes a little longer while and he gives it after the second week or 10 days or so. Will you do that time?
Anytime that I know. Yes, anytime that I actually, yes, we can wait for 2 to 3 weeks, but nowadays we don't wait.
Because
we take this patient immediately.
Yeah, the inflammation,
Yes.
other things, injuries,
The fibrosing and all that.
are going to be there. And
Yes,
also
yes.
the parathyroids and so on. So probably I think it within a week's time you do it or you wait for 4 weeks, right?
Yes, ma'am, but actually wait for that criteria. Now we go ahead as soon as we see. But yes, actually if you are late, the pathology gives you late, you wait for 3 to 4 weeks.
Okay. So when we come to this post-surgical management of these incidentalomas and micropapillary CA, which you get, you have done a hemithyroidectomy, and what do you advise, Dr. Ponkodi? Just in 2 minutes or 3 minutes, if you can answer, because we're running short of time, that's why.
Following hemithyroidectomy, yes, ma'am. So we generally routinely in Madras Medical College or in our setup like India, where the follow-up is difficult, we go ahead with completion thyroidectomy, even though it is PTM, because papillary thyroid cancer is known for multicentricity. But if logistics permits you, you can proceed with hemithyroid, just hemithyroidectomy, follow up the patient serially with ultrasound.
Okay. Regarding the post-surgical management of a well-differentiated cancer, thyroid, the radioactive, I want you to highlight on this, the thyrogen, the thyrotrophin, alpha, which we give, what is the dose of T3 and all that?
Yeah. So,
for detecting.
After complete, the question is posed to me, ma'am?
Yeah. You want to just tell in few points? You don't want to? Okay. Malarvili, can you just highlight a few points post-surgically? So we want to find out whether there is a residual thyroid tissue or not. For that, what you want to do? Very simple. One thing is, don't give them thyroxine for about 4 to 6 weeks. Allow the TSH to rise up to 30 units, international units, like that. And then you can give the I-123 or I-131 you can give. The dose is 2 to 4 microcuries you give. And then of course you see the residual uptake is there or not. And in case you don't want to give that, some of these elderly individuals don't withstand this hypothyroidism for a very long time, not giving them the L-toxin for a long time. Such people we can give this thyrogen, but very costly though, thyrotropin alpha. It should be given intramuscular, 0.9 milligrams you give in 2 doses you give, and after 48 to 72 hours you do the uptake. And you for the plan for giving the radioactive iodine treatment for detecting a residual disease. What is the stunning of thyroid and how can it be avoided? Malarvili ma'am.
The stunning of thyroid is quite controversial. There are some people who don't, it's not very clearly understood. But the main thing is here there is the uptake of the therapeutic radioiodine dosage is diminished by whatever remnant tissue or
just
functional
blocks
metastasis.
The follicle gets blocked by the isotope that you are giving.
We have done for a diagnostic, you would have given diagnostic scan you would have done. So it blocks the uptake. So that is called stunning. So to avoid this, what we can, what is suggested is you can either abandon the diagnostic scan, or you can use iodine 123 instead of iodine 131, and also the shorten the period to almost 72 hours between the diagnostic and the whole body scan. So these are some steps you can take to prevent stunning. But they also say that stunning doesn't have much of an effect on the patient outcome.
Okay, that's good. So when we come to this radioactive iodine ablation, when is it typically not recommended, when it is selectively recommended, and when it is typically recommended?
It is typically recommended when the tumor is more than 4 centimeter, or if it is extra thyroidal invasion is there, and if there are involvement of the lymph nodes, and thyroglobulin level post-operatively is more than 5 to 10. It is recommended typically. Where it's not recommended is if the size of the tumor is less than 1 centimeter, and if there is no only intrathyroidal, there is no only capsular invasion is there is no vascular invasion, and antithyroid TG will be less, no antibodies, no detectable lymph nodes are there, we don't recommend. Selectively recommended is in between. It is the size is between 1 to 4 centimeter, the lymph nodes are less than 3, and it is a taller variety, the variant of follicles like tall variety, columnar cell. In those things we selectively recommend, and if there is minimal vascular invasion is also there, we selectively recommend to take up radioactive iodine.
Okay. What is the dose of radioactive iodine for the neck metastasis, pulmonary metastasis, skeletal metastasis, and how do you manage a skeletal metastasis? You want to take that? But Ali ma'am, you want to answer this question?
Yes, madam. For the neck, for the remnant mention. Hello, am I audible, madam?
Yeah.
Yeah, ma'am.
For the remnant lesion in the neck, we give 30 to 50 MCA of radioiodine. That is for the thyroid bed. For the extrathyroidal disease, it may go up to from 100 to 150 millicurie. For metastasis, obviously, which occurs in follicular carcinoma, the dose may be increased up to 100 to 200 millicuries. If there is no response, then we go for cardiac chemotherapy or external beam radiation.
Pulmonary metastasis, probably you give 150 millicuries. Okay.
Yes, madam.
It can cause some fibrosis also, right? Okay, ma'am. Thank you very much for that. How do you, the gross residual disease, no? When, if it is resectable, how it is managed? The unresectable, how do you manage this? The question is, ma'am, Ali ma'am. The question is for you, ma'am.
Yes, madam. For clinically gross residual disease, after imaging, that is, after contrast enhanced CT or MRI, we decide whether it is resectable. If it is resectable, do surgery, and then after 6 weeks, do an imaging. If it is radioavid, do radioionization. Then if it is unresectable, radioiodine tumors, radioiodine ablation.
Okay.
If it is radio refractory, we go for MGR, external beam radiation therapy.
Yeah. External beam, you can give this intensity modulated radiation can be given, focused radiation can be given. Okay, ma'am. Thank you. And I would like to ask Professor Shanti, ma'am, what are the principles of TSH suppression? Clear guidelines are there for TSH suppression.
Yeah, TSH suppression is a must before we give any radioactive iodine. We either follow suppression by stopping the thyroxine given for the patient, but it takes a long time, minimum 4 weeks.
No,
so nowadays,
what I meant was, after surgery, I'm sorry about this clarity on this question.
Yeah.
What I'm asking is, post-thyroidectomy, we need to suppress the TSH, no?
Yeah.
So when there is a residual disease, how you do it, and when So what actually I think the other suppression, no ma'am, was about the suppression for the thing, no, she understood. So I'll take this one. So when you have a high risk group and also there is a residual disease that is there, your TSH must be really kept low, less than 0.1 it must be kept. Otherwise, if it's not a risk group and also good prognostic indicators are there, and it's only a suppression that you are giving, you can keep it somewhere near 0.1 to 0.5 you can keep. But then when you keep it very low, like 0.1, of course you are going to have the features of hyperthyroidism they will get, and also all features of thyroid toxicosis they will get, and these patients will have the hypocalcemia, and vitamin D has to be supplemented, calcium has to be supplemented. But what they say is, you are keeping it very low also, you keep it for 1 or 2 years and bring it to the basal levels. That is the principles of this TSS suppression. Thank you, ma'am. Sorry for that mix-up. Yeah, I'm finishing it off. The follow-up of thyroid cancers, thyroglobulin and antithyroglobulin antibody. Sai, just tell us only 2. We are running short of time. Just one point.
Okay, ma'am. Yeah. So basically, there are 3 things: TSH, TG, and the anti-TG bodies, anti-TG antibodies. So if it is an excellent response, the suppressed TG should be less than 0.2 nanograms per ml. And if you TSH stimulated, the TG should be less than 1 nanogram per ml. So this means there is an excellent response, and the patient is, this is the follow-up. When do you say that there is an incomplete response is if the TG is more than 1 nanogram or stimulated TG more than 10 nanograms, or if there is any rising anti-TG antibody levels. So this is very short about...
Thank you. Thank you. What is the cause for this pulsatile metastasis in follicular cancer? And how do you manage it? What is the cause for this pulsatile metastasis? Dr. Purkodi?
So
Dr.
follicular
Purkodi,
cancer is spread.
Just one point you tell us.
Yeah. So as I told you previously, like vascular endothelial growth factor, derived growth factor, hepatocyte growth factor, most importantly, VAGF is present very high. New vascularization is the cause of increased vascularity, which manifests as a so damnable process to go for medication. Otherwise, since it's a well-defined thyroid cancer, like go for the active iodine. If
I'll ask him. Yeah. Of course, the kinase inhibitors do have a role in the treatment of well-differentiated cancers. So a few questions for this endocrinology. Now, Sai, you want to take this question? When you have, how do you spare the recurrent laryngeal nerve from an injury?
Okay. Basically, I just want to mention 3 things, ma'am. So one thing is recurrent laryngeal nerve. You will have to find out there are some points. Like one thing is when you are tying the ITA, be very careful because it could be either above, in between the branches, or lower. The other point is be very careful. Now the suspensory ligament of Vitti, that is the place where the nerve, when you hook it, try to take it off, you will try to injure. The other main landmark is the tubercle of Zucker candle, So that actually is a pointer for the recurrent laryngeal nerve entering. So when you hook and you take the Zucker candle, you will see the recurrent laryngeal nerve. So these 3 points alone I would like to mention.
How about a capsular dissection you can do? And also the nerve stimulators can be used. And in case you damage, what do you do?
Stimulators.
You can suture you can use the ansa cervicalis. You can use the ansa cervicalis to suture the perineurium that can be used. Okay. Suppose I would like to ask Shanti ma'am, suppose a patient comes with an advanced MAPCA to the casualty with stridor. How do you manage that?
First of all, when the patient is coming, we have to maintain the airway first of all. So for maintaining the airway, first of all, I like to do an indirect laryngoscopy or an office laryngoscopy to see what is the lesion, where is the lesion, and try to intubate by using a flexible endoscope. and try to intubate the patient with local anesthesia and if possible with a pediatric laryngoscope. And if not possible, do at stenting to maintain the airway first.
Excellent.
And then followed by evaluation of the patient by doing the imaging, and later we can manage by doing whatever resection, extensive resection can be done.
So what we have to do, ma'am, what trying to say is self-expandable tracheal stents are there. Immediately, if it is available, that's the best thing to do. Thank you very much for all the panelists, the chairperson, and the ASI, and our Madam Vice Chancellor Madam for giving us this great opportunity to be here and take part in this session. I hope it was useful.
Thank you, Madam.
Thank you, Madam.
Thank you. Thank you. Really fabulous. This is a really fabulous discussion, interactions among the panelists. So, hearty
Thank you, Nirmala Madam Chairperson, and also the two wonderful surgical endocrinologists and general surgeons are trying to survive here. Thank you very much.
So, wonderful, fabulous discussion, interactions among the panelists. So, hearty congratulations especially to the moderator, Professor Sudhi Kamal Madam, who prepared the questions like proved as a tough examiner. So, all the panelists to come forward to sharing of your experience. Very good, it's excellent manner, especially Professor Santi Madam and Dr. Ali, even though it's very busy schedule, and the Dean Madam away from the academic activities, even though they come forward and participate in these meetings. So congratulations to the Dr. Ali Madam and Dr. Nirmala. So really extremely very happy, successfully we had conducted this panel discussion. Very good. Thank you, Madam. Thank you.
Thank you.
Let's move on.
Thank you, ma'am. Thank you, sir. Thank you. Thank you.
Thank you, ma'am. Thank you, Shruti ma'am, and the faculty for this session. Dr. Shanti ma'am, Dr. Sai Vishnupriya, Dr. Pungadi, Dr. Malarvidi, and the entire galaxy of the faculty for contributing this session. Now we move on to the firewire session, or I would say the live wire topic of all the general surgeons, which I'm sure all of us as postgraduates, DAS, and once you become a professor also, still the most challenging one is when there is a call from the gynec department. You keep your lights on. So I'm sure this will be a lot of fireworks, and of course this is a lot of learning. You have to be sharp in making decision. Now I hand over the proceedings to Professor Shamita. Professor Shamita is the professor and head of the Department of General Surgery at the Institute of Postgraduate Medical Education and Research at Kolkata. And in fact, I should thank Dr. Arunima for assembling this brilliant panel. And I also now hand over to Professor Shamita Madam to give her welcome remarks, and later move on to Dr. Arunima for the moderation. Over to you, Professor Shamita.
இது மறுபடியுமா என்ன கேஸ் இது
Shamita, unmute yourself.
கைனக்கா வா வா
Dr. Shamita, please unmute yourself, ma'am. You are okay, ma'am. We are not able to hear you, ma'am. Do you use any headsets, madam? If that is the case, please remove the headsets from the computer. We are able to see you. There is a challenge in the audio only. Have you logged on with the mobile phone or a laptop, madam? Not yet, ma'am. Madam, I would request you to log out and re-log in, madam. Most of the time the issues will get resolved. Madam, you are okay now, I think.
Can you hear me now?
Very well, very well. Perfect. Over to you, ma'am.
Thank you so much. Good to begin with a H. It means that your day is going to go well. Thank you, Dr. Kanagavan. Thank you so much for the invitation. When I got this invitation from ASI Chennai City branch, I felt really excited. Excitement had 2 or 3 contributors. When I first saw that beautiful pamphlet that you sent me, it felt good to be pampered on Women's Day. But at the same time, I felt that being a surgeon itself is a pampered feeling. You don't need to be a woman to feel a surgeon. So I'm a surgeon in my own capacity. I don't have to be a man or a woman to be a surgeon. Second thing that we said in the pamphlet was women in leadership. I think history proves that as far as India is concerned, women have been in the leader's chair from time immemorial, and it shall continue. The Western world is catching up with us now in leadership, but we've been leaders from way time immemorial. Right. Even ASI had its lady president in the 90s. Professor Deshmukh was the president. So I think ASI is also not far behind when it comes to leadership. The most exciting thing which, triggered my imagination was the program of our panel, Gynec Emergencies for General Surgeons. Even as a resident, we used to love to believe that a general surgery resident is somewhere more elite than a gynec resident. So we like to believe that we are a better lot. But I think the humbling experience comes when during a general surgical procedure, you're encountered or challenged with a gynec procedure. And I remember very well in my SR days, on the same night, I had to perform 2 surgeries. The one was a typical acute appendicitis in a 30-year-old lady. We were so confident, let me tell you, in the late 90s, we were not doing USG for every patient who came down. So clinically, it was thought to be an acute appendicitis. We went in, it was open surgery in the 90s. And what we found was it was a torsion of the ovarian cyst. So there was one googly to begin my night duty. So by the time I finished that surgery, I got a call, as you said, from the gynec OT. There's some chaos here, can you come over? So when I went over, I found there was this lady who had been treated by a quack in some village, an attempt at an illegal abortion. And by the time she came to the gynec ER, she had loops of intestine hanging out of her vaginal orifices. And somebody, in haste to be useful, had tried to push it back into the vagina and had aggravated the problem. So I had the second googly of my night, and I realized for once that no, we are not elite to the gynecologists. We are at par with them. But to be, if you really want to think you're elite, you have to be trained in also identifying and tackling these gynec emergencies. So I'm sure we're going to have a wonderful panel tonight. It's exciting to meet Arunima and Maninder, who are old friends. But I'm even more excited to meet all these new friends who are the esteemed panelists. And I'll hand it over to you, Arunima, to introduce all our new friends to us. Arunima, it's yours.
Thank you very much, Shamita, for those opening sentences. They are very useful, I think. Dr. Kannagavel, can I share my screen?
You rights, madam. You please share. You are already allowed to permitted to share. We are able to see your slides, ma'am. Yeah, make it full screen and go ahead, ma'am. Thank you.
So, we begin with that a very good afternoon to all of you. And at the outset, I would like to thank the organizers, Dr. Kannagavel and the TN Dr. M.G.R. Medical University for this opportunity and this wonderful initiative on Women's Day. As Shamita said, it's pampering us, and I think, Shamita, man, woman, whatever, whenever you are pampered, you should take it. I'm very happy to be pampered on Women's Day. And the whole morning has been almost an academic feast, and now we move on to a very broad yet interesting panel on gynec emergencies for general surgeon. And we have a very good panel. The chairperson, Professor Shamita Shetty, I'm the moderator, and we have wonderful panelists. Shamita is a professor in the Department of Surgery, IPGMER SKM Hospital, Kolkata. This is myself, and I am leading the Department of Surgery at Tata Motors Hospital, Jamshedpur at present. Professor Dr. P.P. Dakshayani, she is a professor and HOD of Geriatric Surgery at Rajiv Gandhi General Hospital, Madras Medical College, Chennai.
Dr. Shrikala Prasad. She is MCH Urology. She has all the designations we could think of. She is MD Obs Gynae, DGA, MCH Urology, and she is Professor and Head of the Department of Urology, Chengalpattu Medical College. Dr. Maninder Kaur Chhabra, she is Consultant Surgeon and In Charge Breast Clinic at Deen Dayal Upadhyay Hospital, New Delhi. Dr. Professor S.P. Gayatri, she is a Professor of General Surgery at Madras Medical College and has a lot of teachings to her attributes, and she has been an examiner to various colleges, and she has operated successfully on a 22 kg giant uterine myoma. She has a DGA as well as a MS degree. Dr. P. Sumati, she is from Kumar Mangalam Medical College, Salem, and her interests are gynae and breast oncology. So I welcome all my esteemed panelists to this panel. And to begin with, gynecological disorders are a common cause of morbidity among women of reproductive age group worldwide. And in developing countries, they become more important because of the weak infrastructure. Now, I would not put India as a developing country now. We are, I think, somewhere in between the developing and the developed nations, but our infrastructure, as far as the health is concerned, are yet not that strong. But both the developed world and our world have got their own challenges when dealing with emergencies. A report from US says that 1.4 million gynecological emergencies visit to the casualty. That accounts for 24.3 visits per 1,000 women in the reproductive age group, that is between 15 to 44 years. We do not have equivalent data for most of the developing countries, and you would come across various articles in literature where the endocrine surgeon in these emergency situations is well defined. And this is one of the articles from Karnataka itself, which says that this study says that a general surgeon in gynecological emergency has an important role and offers significant benefit not only from diagnostic and therapeutic point of view, but also in terms of reducing morbidity, mortality, post-operative complications, and length of hospital stay. So I think if we look at our panelists who have had DGO degrees and then gone ahead to learn MS degrees also, I think it does prove to an extent, though I'm not yet contributing, or as Dr. Kanagavel said that it would be fireworks. I'm not going into the fireworks of whether we are elite or not, but yes, there are multiple literature which shows that definitely a general surgeon would be better at handling a few of the gynecological situations. So when I talk of role of a general surgeon in gynecological emergencies, I would like to divide it into three settings. One is the acute emergency setting, one is surgical call in gynecological operations, and one is gynecological encounter in our surgical practice. So the best way ahead would be taking it case-wise so that we have a better impact. And since this is what we are discussing from general surgery, now each of the kind of gynecological emergencies that involves a surgeon basically is quite specialized. Whether it is a bladder injury, ureteric injury, then it's a better thing is done by a urologist. Then there are bowel injuries or rectal injuries, maybe handled better by GI surgeons. But then there definitely is a role of general surgeons, because throughout India, if we look at, general surgeons are catering the emergency duties more than the super specialists. So it is very important for us to discuss this particular role of their contribution in gynecological emergencies, because they would be the caregivers in that situation. So I will move ahead with this acute emergency setting. And here it says that this is a paper from Lahore, which again is very close like our country. So gynecological encounters in surgical emergency, it says that it is not infrequent that an acute abdomen primarily thought as surgical pathology has an underlying gynecological cause, and this can range from 4 to 35%. So I would just put this broad question to our panelists, that what is the approximate patient load of female patient in surgical practice in our part of the world? And I would go ahead with our senior most Dr. Shrikala to answer this question. Ma'am, could you please take this question? Ma'am, please unmute yourself.
Am I audible now?
Yes, ma'am.
Hello. Yes. We run both a female OPD as well as a male OPD. The female OPD will be roughly around 20 to 25% of the regular male population which we see. Right. And I think most of us would agree that we do have a whole team of patients. So breast already has been excluded, but coming with even gynecological issues, all the issues have already been dealt with in the morning. So we will not go ahead with that. And if we come to what are the common gynecological encounters which present at acute abdomen in our surgical practice, I would just go ahead by answering this. So they would be acute inflammatory disease, miscarriages, menstrual disorders, sexual assault, ectopic pregnancies, and complications and unsafe abortions. And these are the various situations in which the surgeon definitely is called. So I would go ahead with the first case where a 25-year-old married female presented with fever for 1 week, with lower abdominal pain, absolute constipation for 2 days, and vaginal discharge since 2 weeks. On examination, she was febrile with tachycardia, with her pulse BP of 112 by 56. Abdominal signs were there. There was tenderness, guarding, and rigidity, which was more on the right lower abdomen. On ultrasound, she had bulky uterus, but right ovaries were not visualized, and she had features of small bowel obstruction. Total count was very high. Hemoglobin was 10.5. So with this, when it comes to a general surgeon, this is an acute emergency that you get a case like this. Dr. Gayatri, would you take this question? What would be your provisional diagnosis in a case like this?
Yes, Aruna, thank you for this. And the most common infection in females in our part of the world is pelvic inflammatory disease. And amongst that, 15% are going for tubo-ovarian mass. I think the right ovary is not visualized indicates that. And it's a case of acute abdomen. The patient has got temperature, tachycardia with a low BP, and tenderness, guarding, and rigidity, and especially right lower abdomen. So I think it will be a case of, yes, ovarian abscess, tubo-ovarian abscess.
Okay, but when a surgeon sees this, because this would come to a surgeon first, because this patient has presented with features of small bowel obstruction as well, because she has a
yes, but I would have definitely done a PV for her because I'm already a gynecologist. So always I'm more focused when a female patient comes, I want to rule out a gynecological issue. So she's got a vaginal discharge. So that will make me...
A very good point brought by you. That as gynecologists or as surgeons, we get tubular vision. So surgeon would always look at it as a obstruction. We would not think of the vaginal discharge as a very important thing. Definitely, every surgeon would do a DRE in this patient, and I think most of my panelists would agree on this. Anybody who would agree or disagree with both of us? Any opinion on this? Would you think it as a small bowel obstruction, or would you go ahead thinking that okay, this is a PID?
Avinuma, can I come in?
Yeah, please go ahead.
Can I come in, Avinuma?
Yeah, please.
Yeah. See, being a general surgeon, this patient in my ER, I would definitely not think of it as a gynec patient in the first place. I would just tackle it like a small bowel obstruction, begin the resuscitation, start the IV fluid, start the UBC, it's 33,000 counts. I would see it's a small bowel obstruction with obvious elements of sepsis. So I am going to run along that line, stabilize the patient, resuscitate the patient, and if this USG I'm not too happy with, I would, if the patient is stabilized, I would like to go for a CT. If that facility is not available, I would probably like to intervene even before a CT. But then the vaginal discharge as a surgeon probably will not ring a note in my mind to begin with. Maybe in retrospect, that comes in.
Right. Absolutely. I do agree with you. And as general surgeons, we do have this tubular vision of always thinking about the surgical problems.
But this is a case of small bowel obstruction. Small bowel obstruction never presents with rigidity and all that.
If it is perforated, yes.
And the count is increased.
Yes, obviously it's perforated. 33,000 count is obviously.
Yes.
It's with
I always rule out gynec and O pathology before I think of a surgical pathology in my practice. Because all others are males along with me, so I am destined to differentiate between a gynec pathology and a pure surgical pathology. I'm very particular about that.
That
It
is
is a must.
We'll take this further from there, that okay, fine, this is a learning for all general surgeons, that okay, when you have a case like this where your ovaries are not visualized, do keep in mind gynae pathologies as well. So here it was, this is what was found when the exploratory laparotomy was done, and this basically was a ruptured right tubo-ovarian abscess with inflamed ileum adhered to it. So, Dr. Gayatri, what would be your management approach on this?
Yes. Now, having thought of a tubo-ovarian, a pelvic pathology, mostly a gynecological one, or as a surgeon, I would have also thought of an appendicitis because it is on the right side. So, my diagnosis would have been PID or TO mass or an appendicitis. I would have confined myself to it. And again, I would have taken a CT which would have showed me all this. I would have opened up the abdomen with a midline incision, and having seen this finding, and I want more, the bowel looks a little bit alright here, but then again, if it's going to be a flimsy adhesion between the tubo-ovarian ruptured abscess and the small bowel, I'm going to try to separate it. If it is not possible, then I'll have to think twice. It may maybe a limited resection, maybe I'll have to remove the tubo-ovarian part of it along with the bowel that is sticking onto it, and go in for an anastomosis, resection anastomosis. And in our part of the world, they say tuberculosis is more common, but this doesn't look like a TB gut. So this must be a bacterial one with addition of the bowel. So without injuring the bowel, I'll try to separate it, and if the bowel is compromised, then maybe I'll go for a limited resection and anastomosis.
So I think you have rightly made the points that okay, because of the findings that we have, obviously you would think of an appendicitis, and obviously a perforated appendicitis in this case with such high counts, guarding rigidity, more on the right lower abdomen, but it is more, it is generalized. And when we come across any tubo-ovarian pathology involving the bowel or the appendix, definitely it has to be dealt with as the condition of the bowel is. Appendix, definitely, if it is involved with tubo-ovarian mass, I think all of us would agree that we take that appendix out because it is also inflamed. It can be secondary to the pathology, or it's about the chicken and the egg. So whatever, it is already involved, so it has to come out. And here definitely it is not tubercular because the rest of the gut looks fine. It is only the part of the gut that was adhered to the tubo-ovarian abscess. That is what is inflamed, as well as it is showing a very unhealthy looking bowel. So this would go ahead with a resection and anastomosis. And do you think there is any possibility, since you have in your mind that this is a pelvic inflammatory pathology, would you at any stage conserve this patient, go on for conservative treatment and not go ahead with because you think its bowel obstruction is not there, the primary pathology is ovarian. So would you go ahead and conservative? Yeah. Would you give her any conservative trial with medication, antibiotics?
No. The patient has already got guarding and rigidity, and with features of bowel obstruction. And the counts are also increased. So I will start the antibiotic, and I think it's I'll straight away open it.
Okay. So coming to conclude this particular case, bowel involvement in tubo-ovarian pathology is not uncommon, and there are various publications on this. And if you look at management, it is said that in clinically stable patients who have small bowel obstruction associated with pelvic inflammatory disease, you can go ahead with conservative treatment, which includes antibiotic therapy without operative intervention. But definitely, as Dr. Gayatri rightly mentioned, that when the patient is unstable, like this patient who is very febrile septic, you have to go in for control of sepsis, that is source control. So you will open up this patient. And is there any idea on laparoscopic intervention in such?
Yes, Arunima, if the patient is a little stable, then we can think of laparoscopic approach. But then again, depending on the expertise of the surgeon also, and the availability of laparoscope in an emergency setting, I think we can proceed with laparotomy.
I think
there is a role for laparoscope also if the patient is stable.
So, Yeah, because not only about patient being stable, in small bowel obstruction, you would have distended bowel as well. So at times, going in laparoscopically, though it is not contraindicated, it definitely is an option at advanced centers where they are doing laparoscopy for almost everything. But I think as general surgeons, that is at advanced laparoscopic centers, that you might attempt a laparoscopic one in such a case, because with small bowel obstruction, even having the pneumoperitoneum in itself would be a challenge. And so I would suggest for general surgeons, I would suggest go ahead with an open surgery, especially when the cases are complicated and patient is, such patients. So with this, we come to our next case, where a 28-year-old Lari Paris female came in with sudden onset of generalized pain, lower abdominal pain followed by per-vaginal bleeding. There was protrusion of mass per vagina, notably during defecation and micturition. Initially, the mass was reducible, but later it became irreducible. She had significant nausea, bilious vomiting, pre-syncope and palpitation with a low BP, mild tachycardia, abdominal findings, rigidity, tenderness, and guarding. And in perineal examination, she had non-reducible intra-abdominal contents, which were clearly visualized protruding from vaginal os, though DRE was normal. And interestingly, this patient initially did not give any history of any sexual contact, but later on she mentioned about a consensual sexual activity following which she had this problem 2 days before she has had. So this is what was found in this lady. There is almost full evisceration of small bowel. It's a post-coital posterior fornix perforation with vaginal evisceration. I would request Dr. Shrikala ma'am to take this question, that how would you manage a case like this, ma'am?
Now, this patient, first of all, am I audible?
Yes, ma'am, you are.
Now, you have said that she is given history of a consensual sex. That we have to really take into matter, because there's a separate topic that if you see a younger individual, say less than 18 with this kind, you have to, make it an MLC and get ready for the consent for examination, consent for taking specimens and all that. Now she's an adult, it's enough, and in less than 18, you need to inform the police also. But here, you don't need to do all that. We have to, after taking a proper consent, here the factors which are of great concern to us are the duration of the injury is not very recent, like not both the sexual trauma she has come, she's spent a little time on it, and she's come with a little tachycardia, fall of BP, and you can see some obstruction with nausea, bilious emesis, as well as a rigidity, tenderness, and guarding. So I will stabilize the patient, put her on antibiotic simultaneously. I will not wait for the antibiotic effect to take over and things like that. So simultaneously, I will evaluate her. And this is a case which needs to be taken to the theater under anesthesia. We have to visualize what is wrong. Now, this again is a 2-day-old injury. So it is better to go ahead by a laparotomy, visualize the entire bowel, and then go in for suturing of the posterior fornix. We always see that the posterior fornix is the one which gets, posterior fornix only is the place where perforation occurs, because anteriorly you have the whole of bladder and everything there. So this posterior fornix is the one which is very weak. There is very poor endopelvic fascia, and with the contact, what you understand is, there is tightening of the lower vagina and the upper vagina gets ballooned, and there is an increased pressure. So the thin endopelvic fascia in the posterior fornix can give way and the entire bowel can come out. And there is a little time lag also. So after proper evaluation of the patient, simultaneously correct the patient, take her up for surgery. If you are a very good laparoscopic person, you can visualize the bowel laparoscopically. Otherwise, by and large, I would advise using a midline vertical incision. Go through a midline vertical incision, you look for the entire viability of the bowel and then close the posterior fornix tear.
Ma'am, here you mentioned very rightly that since this is 2 days old, we will go ahead with a laparotomy or at advanced center maybe laparoscopy. So what difference does it make between, suppose this patient had come immediately after the injury and it was an immediate bowel collapse, what would be the difference in the management plan then?
One, the sepsis is not there. It's just a short duration. And, we can be more sure that about the safety of the bowel here, if they have come immediately. If not for this bowel, by and large, the postcoital tears which we see more often are not full thickness tears. We will be able to suture them from below itself without having to do a laparotomy. But because this involves the bowel coming, if it is a recent tear, then I think instead of putting a midline vertical incision, we can go through a laparoscope, visualize the safety of the bowel and then close this. But once the bowel entire is outside, we have to be guarded about the safety, the viability of the bowel. We cannot push it inside and suture and come out. We need to be sure that we are not causing further damage.
That's a very important point, because what happens then when there is evisceration and it has stayed out for a long time, then the bowel is edematous. So along with edema, what develops is that if you are trying to push it from below, there will be serosal tears which may be unrecognized. And that is the reason why it is very safe. Definitely when it is a recent one, you can go in with a laparoscope. Once you have put it inside, you can trace the bowel through and then see that, okay, the bowel is safe, and then you can go ahead with the laparoscopy itself. But otherwise, in a case like this, because this bowel is all edematous now, so the serosal tear would be very common in such patients. So these patients would definitely do well with laparotomy, and general surgeons definitely. Yeah, general surgeons, would you advise general surgeons to at any stage take up laparoscopy in this, or go ahead with a laparotomy? Because this is a topic specifically for general surgeons. At advanced centers, yes, laparoscopy can be done almost in everything nowadays. But for general surgeons, what would be your advice?
See, for the vast majority of the general surgeons, I think laparotomy is a definite easy procedure. But if your skill is good, you can walk through the bowel nicely. You're very sure of the integrity of the bowel. It depends on what your take is. You know your own strength and weaknesses. If your mind says, yes, I can tackle that, I can visualize the bowel in entirety safely, you can go ahead for laparoscopically. Otherwise, a simple midline vertical incision, we would be able to do a good visualization and then closure and come out.
Correct. So, if we look at the management of small bowel evisceration through the vaginal orifice, they are a surgical emergency. It is challenging for a surgeon who has not dealt with it much, and especially in an emergency situation. And surgical procedure performed depends upon the viability and contamination of the herniated bowel and associated comorbidities and general condition of the patient. And the eviscerated bowel should be thoroughly cleaned with normal saline, gently reduced into peritoneal cavity with simultaneous support and guidance through the vaginal orifice. However, attempt to reduce the bowel without laparotomy is difficult, as we discussed with Dr. Shrikala. And at times it is unsuccessful, it results in higher mortality because what we discussed, because there might be serosal tears which you have missed, and patient may land up already a patient who has had sepsis, may go further sepsis, and sepsis today also carries a very high mortality up to 40%. So there might be a need for diverting stoma, and this is again based on the case-to-case basis. Suppose you have had a tear or a bad segment of bowel which you have repaired, still patient is in sepsis, you may do a diverting stoma. Is that right, ma'am?
Yes. Then only one point I wanted to add. If we are not bothered whether they are living, they are separated, divorced, anything. According to the history, if there is an attempt at rape, then it becomes an MLC. If it is not in adult, I'm talking. If they say an attempt at rape, we have to follow it as an MLC. Otherwise, we can do the regular way. But anybody less than 18 is equal to a medico-legal, where you have to take consent for examination from the patient, from the parent, and mandatorily inform the police. Even if they are not willing to file a medical or illegal case, we have to inform and get it written that they don't want. So that saves our skin.
Yeah, that's a very important point, ma'am. That's a takeaway, good takeaway point. So the second section becomes surgical call in gynecological operation for the surgeon on call. So what are the common reasons for which a general surgeon is called in gynecological operation? I would say the injury to bowel bladder, rectal injury during delivery, difficult adhesions with intra-abdominal organs with difficulty in reaching the pelvis, and very rarely you may get a vascular injury call as well. Is there any other reason for which you would get a call from gynecological operation? I would put it open to all my panelists. Anyone can take this question. Anything that I have missed for which you have been called by the gynecological surgeons? Okay.
Ureteric injuries. Ureteric injuries.
Right. Yeah. So urological injuries, right? I think I have put it as bladder, so it actually should be the urogenital injuries. Thank you, Shamita, for that. So here we come across the next case where a 47-year T2L2A1, and for the comfort of general surgeons, I would, because I had to look up at what T2L2A1 was. So it's a para 2 living children and 1 abortion. Post-hysterectomy patient with left complex ovarian cyst taken up for laparoscopic cystectomy. The general surgeon was called for sigmoid adhesions to the cyst. Sigmoid was reflected by surgeon and patient handed over to the gynecologist. Yet there was bleeding for which it was converted. Post-op period was uneventful. But 2 weeks later, the patient comes back with pain abdomen with CT scan showing urinoma and ureteric injury. And this is the CT scan, the urography of this patient. So, Dr. Dakshayani, I would want you to take this question. What went wrong? Dr. Dakshayani, are you there?
No, the first surgery when they were doing, it was a huge left complex ovarian cyst, and there was adherence of sigmoid to the cyst. The sigmoid was retrieved by the surgeon, and the gynecologist had proceeded with oophorectomy or ovariectomy. The patient has already undergone hysterectomy. There would have been some sort of distort in anatomy, which was led to the bleeding and all. At that time, the bleeding was controlled and the patient was stabilized. Post-operatively, they have found collection in the abdomen, and patient has developed symptoms of peritonitis. Probably there would have been a left ureteric injury because the left ureter traverses through the sigmoid, and only 25% of ureteric injuries can be diagnosed intraoperatively. 75% will be taken up only post-operatively.
A very important point that you have made, Dr. Dakshayani. And here when we talk about, it's not just the left complex ovarian cyst. This patient is a post-hysterectomy patient. So a previous surgery already changes the anatomy. Yeah, it causes adhesion, but as well as it changes the anatomy. That's right. Yeah, so the anatomical variations are also there. So definitely the caution should be more in such cases. And as you rightly mentioned, these patients are diagnosed more often in the post-operative period. So what would be the signs with which you should suspect that, okay, this patient might be having a ureteric injury in the post-op period?
Patient would have developed abdominal pain, fever, pain in the loin, and tenderness all over the abdomen, and urination would have been less.
Okay. Dr. Shrikala, she is MCH urology, so I think if she wants to add something.
The only fact I wanted to tell madam was, in a regular patient doing oophorectomy, when the uterus is there, it is very much mobile. You can just lift up the tube, the ovary, and then put your clamp and go. It will be easy. It's like a child's play. But in case where we have done a residual ovarian or a post-hysterectomy patient, we always see, or we most often see, the ovary is attached to the lateral pelvic wall, or it is stuck onto the peritoneum. So there, when you try to put a clamp, you can inadvertently include the ureter. So it is better to open the peritoneum a bit there and then see where your ureter. Actually, in these redo cases, where post-hysterectomy, where the ovary is stuck onto the lateral pelvic wall,
Or in cases of para-ovarian cyst also, if you just open the lips, you inflate the ovary, you can be safe. So when it is attached to the lateral pelvic wall, make sure that you are not clamping the ureter. You need a little more dissection. You have to think that the ovary can be adherent there. Just below your ovary may be the ureter sitting. So I think you have made the point. The surgical caution that I would have asked, you've already made that point. And yes, ma'am, you are very right. In this particular case, the complex ovarian cyst was attached to the left lateral pelvic wall. It wasn't lying in its normal position as you mentioned. Dr. Dakshayani, so once the patient...
Arunima, can I come in for a moment? Arunima?
Yeah,
can I come in for a moment?
Please.
Yeah,
please.
I think there is one very important information that you've given on your slide, that immediate conversion due to bleeding. I think what very commonly happens in such cases is that when we attempt to achieve hemostasis, particularly in the retroperitoneum, we might end up doing lateral heat injury to the ureter. So this may go unnoticed intraoperatively, and post-operatively, if you have a drain, you might be a little luckier because you might get urine coming in your drain. Otherwise, if you have not put a drain, that this becomes the usual post-operative picture. So whenever you have to open up to achieve hemostasis, I think we have to be extra cautious in the region of the retroperitoneum. Otherwise, we may have these diaphragm injuries to the ureter as well.
Yeah, you're very right, Shabana. That one word, avoid down clamping.
Yes, definitely, right.
Yes, that is a very important thing, that you should not panic. Any bleeding will stop, pack, wait for some time, and then wait. See your specialist. Yeah, pack and wait, all bleeding stop, because you are not bleeding, the surgeon is not bleeding. So you have to wait, you have to have the patience. What I was saying that definitely when you have such complex cases, I think we would go ahead with putting up a drain. But in this patient, the drain was put, yet there was nothing that was coming in the drain, and post-operatively. So what other thing is there, that the drain had serous fluid. So what would be the caution? Dr. Dakshayani, the patient has serous fluid, but it can be taken as that, okay, it's just the ascitic fluid. Would you take out the drain, or would you, because the patient had a complex surgery, would you go ahead with any imaging immediately in the post-op period? Dr. Dakshayani, are you there?
Imaging, I would have asked for a CCT abdomen, which would have revealed the continuity of the in CCT abdomen itself. We can find out the pyelogram study of the left kidney and the right kidney, and the leak also would have been picked up in it.
So, would you do it routinely in any patient who has had a complex surgery? Would you do it routinely in the post-op period?
No, with the features of pain, increase in count, and the pain and tenderness all over the abdomen post-operatively.
Dr. Shrikala wants to add something.
Drain the urine cleaning in the drain.
You can do a drain fluid analysis. We were talking that it could be a serous. It could be urine also. So if you do a creatinine of that drain fluid, if it is like your plasma or your serum point less than 1, it is therapeutic. But if it is many points, then it is a urine. That's a very important point, that in case we have undergone a complex surgery like this with bleeding, as Shemek mentioned, so if in the post-operative period your brain is pouring out a ascitic fluid that you are thinking, please go ahead to rule out that it is not the urine that's draining. So just to sum up, the incidence of urethral injuries in various procedures range from 0.0 to 6, and it is more in the gynecological procedures. The diagnosis of iatrogenic urethral injury is not easy, and it can be difficult and delayed in most cases, as rightly pointed out by Dr. Dakshayani. 65 to 80% is usually delayed. In post-op period, typically it is discovered by flank pain, urinary incontinence, vaginal or drain urinary leakage, hematuria, fever, azotemia, or urinoma. Clinical diagnosis is usually supported by imaging studies, and a retrograde or antegrade urography is the gold standard for confirming these ureteric injuries. The extravasation of contrast medium in CT or intravenous pyelogram is a landmark fault in the ureteric injuries, but you may also have hydronephrosis, ascites, urinoma, or only mild ureteric dilatation. So I would just wind up this case by looking at the various statements that ureteric iatrogenic injury is 0.02 to 6%. Injury is mostly to the distal third of ureter. Pre-operative prophylactic stents do not prevent ureteric injury but may assist in its detection. Endourologic treatment of small ureteric fistula and stricture is safe and effective. Major ureteric injury require ureteric reconstruction following temporary urinary diversion. And as far as recommendations are concerned, the grade A recommendation is that visual identification of ureters and meticulous dissection in their vicinity are mandatory to prevent ureteric trauma during abdominal and pelvic surgery, which was very rightly pointed by Dr. Dikshani and Dr. Shrikala that we should not be in a hurry to clamp this. And prophylactic ureteric stent insertion and intraoperative cystoscopy can be used in selective case, but definitely not in every case. For prevention, again, intraoperatively prevention by identification of ureters is the best. Routine prophylactic stenting is not cost effective. You have to select the patients with risk factors. And secondary prevention is doing an intraoperative cystoscopy by using intravenous endocarbon, which offers confirmation of ureteric patency. You have to look at cost effectiveness as well as your expertise. So these are things which you can do for the prevention of these. Treatment, we have discussed that, I mentioned it in my previous slide, depends on the nature and location of injury. And ligation injury can be managed by deligation and stent if you have immediate diagnosis. Partial injuries can be repaired immediately with a stent or urinary diversion by a nephrostomy tube. And when you diagnose it later, as in this case, you would treat it by a nephrostomy tube with or without stent. And surgical repair is necessary depending on the location and degree of injury. There are multiple surgeries which can be used, but ureteric reconstruction usually can be done by ureterostomy and ureterocystostomy. Dr. Dikshani, anything else you would want to add in this treatment?
You have completed everything, madam. Thank you.
Okay, so we move on to the next case that, sorry about this. So, G1 patient with difficult labor and episiotomy wound suspected to have rectal tear. Surgeon has been called for rectal repair. Here I would want Dr. Simati to take ahead with how she would deal with the case of rectal tear in ops and gynae.
Yeah, there's really a case which has to be tackled.
I'll just play your video. I'll play your video.
I can play my video because I just made a small video. Because this is not so commonly seen nowadays, because more of patients, when we have a problem and they go for an elective LSCAs or indication for C when there is a prolonged labor. But this is common in a patient to opt for a vaginal delivery, and when there is a prolonged second stage of the labor and there is the head is in there for a longer period, or improper time of giving an episiotomy, or when it is not given in a proper manner, when the posterior wall is not supported, the patient goes for this type of problem, where it is a complete perineal tear, that is 4th degree perineal tear, where the rectal mucosa or the anorectal mucosa has been opened out, has been involved in this injury. So, it's like, so whenever we have been called for this type of an rectal repair, we have to find out whether how is the anatomy there. You have to look out whether the rectal mucosa is in rectal wall is intact, rectal mucosa, anorectal mucosa is intact, and you have to identify whether the external anal sphincter is intact or the internal anal sphincter is intact, and how is the tear been affected. So this should be done better if we suspect it is a complete perineal tear, and for first time proper repair gives a better results than going for a delayed repair for these patients. And the patient should be given a good anesthesia and area should be very much clear. So better shift the patient to an operative theatre. Not this repair is not better done in a labor room itself. Because where it should be full aseptic area should be there, and hemostasis should be there. Patient should have a good anesthesia so that these muscle areas that has to be dissected will have a good relaxation because of this anesthesia. I'll give you a small video on this presentation identifying the. Madam, please play that video, madam. Am I audible?
Yeah, you're audible. This is the only video that was shared by Dr. Kanagavel.
There is one small video running, madam.
This is the only video that I had. Anyways, we can still discuss.
Madam, you keep discussing. I will show the video in less than a minute's time, madam. You please continue to discuss. I will share the video. Arnima ma'am, can you momentarily unshare your video, ma'am, so that I will be able to play the video.
So, whenever we call, then already the physician will be more annoyed having the resuscitation of the baby, and so everybody will be busy in the OT in the labor room, and there will be a profuse bleeding coming out from the vagina through the uterine area. So we have to first pack the vagina, see there is no internal bleeding, there is no PPH, and the patient is stabilized, and try to shift the patient to OT and inform the anesthetist with the good anesthesia. This area has been cleared properly, and we have to identify the rectal mucosa, the anal area, anal verge, external sphincter, and internal sphincter. And this has been classified as OASIS, that is obstetric anal sphincter injuries, by the RCOG guidelines. And this is better with the good anesthesia, either regional or a general anesthesia. The area is dissected, do a parectal examination, a gentle parectal examination, identify the apex of the tear, where it has happened, and now we have to mobilize this from the suturing should come from the apex of the anal orifice, anal area where the rectal area where the injury has happened, in an inverted suture material. So inverted suture, best with the 30 vicryl, it has to be sutured from there, come down to the anal verge area, and then dissect out the rectal mucosa. Be complete that the whole of rectal mucosa has been sutured in the proper manner, and this areas has to be identified. And then after suturing the rectal mucosa, the vaginal the muscle layers over that area has to be identified. Internal sphincter has to be identified. The internal sphincter should be approximated in a manner that we don't put an overlying suture over the internal sphincter. It should not be more tightened. So you have to go for an end-to-end suturing for the internal sphincter areas. This is a muscle layer that is dissected, and then planning for suturing of the internal sphincter. After repairing the internal sphincter, try to identify the external sphincter areas. After dissecting out the external sphincter areas, the external sphincter should be well sutured, and if possible, we can go for an overlapping suture in the external sphincter, so that this external sphincter gives the continence for the anal continence is preserved more by the external sphincter, and in same importance should be given to the internal sphincters also. And after mobilizing the external sphincter, if the external sphincter is better sutured with 3 PDF, that is a prolonged absorption time is prolonged there. And then the anal verge has to be closed before the external sphincter has been sutured, so that we doesn't make any tear over that verge area. And after closing the external sphincter, the transverse perineal muscles and the puborectalis muscles has to be sutured, and then the vaginal wall, the deeper vaginal wall and the anterior vaginal mucosa has to be sutured, and then the labial skin areas has to be sutured, and it should be more more gentle, so that this patient should not have any hematoma or infection chances should not be there, because the development of a buttonhole opening in this repair can happen in future, which has to be avoided.
So as Dr. Sumiti has been talking about this rectal repair, there are just few things that as surgeons we do not read the obstetric classification. What we read is the extraperitoneal and the intraperitoneal rectal injuries. So as far as I understand, gynecological injuries or obs injuries are usually extraperitoneal, because the anterior part of the rectum is mostly extraperitoneal. So, is there any cause for which you would want to do a diversion in a patient like this, Dr. Sumit?
Mostly these patient doesn't need a diversion unless it is very high, that is the tear is very high in the rectal area, across the dentate line, and a very big finger entering into the POD areas, high up, then they may need an diversion. But in an obstetric tear, up to 4th-degree tear, where it is at least 4 centimeter from the anal verge, the primary closure is more than enough. But keep the patient for 2 days with the IV fluids and liquid diet, and then start the patient with oral with laxatives, where the improvement is better. Very rare, very, very rare they require this. If the delivery, because nowadays all the deliveries are hospital deliveries, and previously when it was delivery was conducted by untrained person, this had happened.
Thank you, Dr. Sumati, for that wonderful video and presentation. So I think most of the things were clear in that. I would just mention a few things about when we talk about, as surgeons, when we talk about rectal injuries, when you do an abdominal examination and a DRE, and if it is unremarkable, you may go in for a CT or a rectal contrast. Definitely, it's not for the ops patient. I would just mention about extraperitoneal and intraperitoneal rectal injury. When the extraperitoneal rectal injuries are destructive, more than 25% circumferential or associated pelvic fractures are there, then you need a fecal diversion. Else, most of them, as you rightly mentioned, you can go ahead with a primary repair. Historically, it was managed with the 4 Ds, that is debridement, drainage, diversion, and distal irrigation. It is no longer followed. The current is what the algorithm that I have shown, and future you can have minimally invasive techniques like TAMIS, which is transanal minimally invasive surgery, where you have a direct visualization up to distal 15 centimeter, and this may be a viable option for extraperitoneal repairs in non-destructive, even intraperitoneal rectal injuries. So we come to the next case, that is a P2L2 with previous 2 LSCS, presented with swelling at LSCS site for 5 months, following LSCS 9 months back in a peripheral hospital. CT showed a complex right tubo-ovarian mass with abscesses, and she was taken up for laparotomy after right ureteric stenting. Surgeon was called intraoperatively for suspected bladder injury. And here I would like to just play, this is the CT, and this is a video where you can very clearly see how you move the CT, and this is the mass. And what you see is that, okay, you can see the planes very well. So here I would like Dr. Maninder, that in a case like this, bladder injury in gynecology or obstetrics, what a general surgeon needs to do, because you know what, when we are called in, it is during the surgery and we have not seen these CTs before, so we are not aware of the situation, so we directly land in having a bladder injury. So how will you go ahead with a case like this? Maninder, can you take this question?
Yeah, sure. So my time starts when I receive a call, and the call is generally by the junior most person in the team, and the call is like, some problem is there, please come over. So if you ask any more questions, it will be, ma'am is calling you, please come over. So the time I take from going from one building to the other is wasted, because I can't make up anything if I can prepare mentally on the way. So as I go, I take deep breath, and then I tell myself to focus on what I have got to do there, rather than focusing on the noises and the chaos around. When I land up in the OT, I first turn to the anesthetist and ask how is the patient, whether it's stable, dipping, or what is the general condition of the patient. And thereafter, I turn to the gynecologist and ask what it is about. A quick look at the pre-op CT scan and pre-op history given by them. Mainly the CT scan and what condition patient has been taken in. Then I go for washing and then recovery. So I believe that precautionary part of putting a stent before any surgery doing in that area had been taken care of. And since it is a laparotomy and a complex right tubo-ovarian mass with abscess, so it would not be a localized abscess, it would be, there has to be the sepsis, generalized sepsis, or some trickling into the peritoneal cavity that would have warranted a full laparotomy for this case, and see if urine is coming from the gynecologist is already suspecting bladder injury, so I wait for a while to see if urine is coming from somewhere or not.
And without meddling too much into that area, I would also look for if Foley's bulb or Foley's catheter is visible from somewhere. Look at the Eurobag if it is having hematuria, and then maybe after doing that, do a gentle exploration and find out if it is coming. When there is a confusion, it is coming or not, then it will be a good idea to fill up the bladder with betadine. At the time we use betadine 1 to 2%. The dyes tend to stain the surrounding tissue and will hamper in further dissection. So at initial point of diagnosis, I would prefer to use a betadine colored solution. Though literature have also mentioned that sterile milk can be used, but in my personal experience, I haven't used that. So doing a retrograde filling of the bladder may show bladder injury if it is there. And how much amount to be filled? Around 300 to make bladder full in an adult patient should be enough, and we can give a pressure over that area as well. So as if there's a injury and it starts showing up, then I need to see what is the extent of the injury. The temptation of finding a hole with one end showing up and starting suturing, I would resist that, and I would first make complete assessment of how much is the extent of injury. And the extent of injury is by defining the edges and also trying to peep inside and see if any posterior injury is there, and if it has gone to the area around the ureter or in the trigonal area, because those are the areas that would be calling for further exploration of the wound. So if it is a small injury in the bladder only, then doing a 2-layer suture using absorbable suture for the both the layers, and if at all silk is to be used, it should be used on the outside. But personally, I don't use any non-absorbable suture so that it doesn't form a nidus in the bladder. And if it is small bladder rent, it can be repaired by that, and Foley's can be put, which will be taken off in the post-operative period in the 7 to 10 days. But very nicely. I'm not finished because
Sorry, we were running short of time, but anyway, just wind up your yes.
The second thing is that in this area, because it is on the right side, and I have to rule out ureteric injury as well. So for that, follow the stent. If stent becomes visible anywhere, then that would give a lead. But even if it is deeply buried into the adhesions and I'm not able to reach up to that point, then I would like to do going in the virgin area and putting the dye to see if it flows out from there, or asking the anesthetist to give indigo carmine if it is available. To rule out the point I want to highlight is that finding a rent in the bladder will not be the end of it. We have to see for the ureteric injury as well. So that
very well pointed out, and very nice practical technical tips that you pointed out, Manindra. Thank you for that. And I would just end this case with that the incidence in various operations varies, and it's fine, ops and gynae. And looking at the statements and recommendations, the bladder is a urologic organ most commonly injured during surgery, with ops and gynae procedure being the main causes. Intraoperatively, visual inspection is most reliable method of assessing these injuries and integration of the bladder. And cystoscopy is recommended after urethral sling operations via retrograde. So there are certain operations for which they have, mentioned that cystography and cystoscopy should be done. Extraperitoneal bladder perforations not recognized during surgery caused by endourologic procedure should be treated conservatively. Peritoneal bladder perforation should be treated by surgery. And the technical tips have already been brought out by Maninder. And just coming to the last case, which we will wind up in 2 minutes, ecological counters surgical practice. Just 1 minute, Dr.
I will request you to give a very brief note, because Madam has to leave for another assignment very shortly. The next team is already waiting. If you can quickly sum up by yourself as a message.
Yes.
That would be fine.
So if it is okay with you, skip the last case, because I think Dr. Kanakvali is constantly giving us messages. If it is okay with you.
Yeah, thank you so much. I think each of the cases were full discussion in themselves, and we have just tried to wind up in one single panel. But however, I think a lot of takeaway messages have been there. I would have wanted to take a takeaway message from each, but the takeaway message that I would say that general surgeons should be well versed with gynecological emergencies, and they should be taking note of few of the technical tips that we talked about. And the most important thing is find out the right anatomic structures and then repair, because that is the first. And the first surgery is the best surgery, because multiple surgeries always causes more complications. So with this, very happy Women's Day to all the super women present here. And thank you very much for your patient hearing and the organizers for this opportunity. Thank you very much.
Thank you. Thank you.
The only thing I would like to say is I remember when I was doing my MS in KEM hospital, the Gynec MD PGTs used to come for a 2-month rotation to the surgery. That was what was told to them, the briefing that was told to them. But I feel it's equally important that surgical residents should also have a small tour of emergency situations. If you have a gynecologist friend at hand with you, you may be bailed out, but more often than not, you have to bail out yourself. So I think we also need that Gynec exposure so that, we do a better job in tackling these emergencies. Thank you so much. I'll hand it over to the organizers to continue with the next program. I think the valedictory is awaiting. Thank you, everybody.
Thank you, Professor Shamita. In fact, it has been a lot of learning from you. I think this topic alone warrants a day-long meeting for us to cover up the entire issues. Dr. Arunima has brought in such a wonderful galaxy of patients to be discussed. Absolutely. So I thank formally the chairperson, Professor Shamita Chatterjee from IPGMR Kolkata, Professor Dr. Arunima Verma from Tata Motors Jamshedpur, Professor Shrikala Prasad, Professor S.P. Gayatri ma'am, Professor Dakshayani ma'am, Professor Sumati ma'am from Salem, and Dr. Maninder Kaur Chobra from Deen Dayal Upadhyay Hospital, New Delhi. Thank you one and all. Now as a chairman of the Chennai City branch, I formally thank everyone, and I now call upon Dr. Sanjay Jain, our national secretary, to give the closing comments before we get the final closure from Vice Chancellor Madam. Dr. Sanjay Jain, sir, please. Over to you.
Thank you, Dr. Kanagavil, respected VC ma'am, and all the respected faculty, esteemed participants. It's really give me honor, and I feel privileged to be the part of this very, I would say, very important and long sought program. And what I would like to say, just a quick comment, that I am observing that more and more girls are taking career in surgery. Probably the present surgeons or the faculty which we are just in front of us, they are playing the real role model for them, and they will continue to do so. I wish all the very best for each and everyone who is taking, and I will request the current people to continue to guide them, even guide us to do best for the humanity. Thank you very much. Thanks for calling me, and I feel humbled. Thank you very much.
Thank you, Professor Sanjay Jain. It's been a lot of inspiration from you for us to host and assemble unique programs like this. Thank you, National ASI. Thank you, State ASI, for permitting all the potential days deliberation. Thank you for the faculty, and thank you all the participants online, offline, virtual and YouTube of university channel and other modalities. Thank you one and all. Now I request Professor Sudha ma'am, the Vice Chancellor of the Tamil Nadu Dr. M.G.R. Medical University, give the closing comments.
Thank you, Dr. Chandra. My very sincere pranams to all the experts who are being part of this national conference, the various panelists and participants. A day of brainstorming is drawing to a close, if I may be permitted to say so. But I'm very happy that this National Women Surgeons Conference was thought of by the Chennai City ASI and then
approved by the state ASI and the national ASI. Come March 8th, come International Women's Day, every year, there had been hours and hours of talk on the empowerment of women. But this is one occasion I find empowerment of women had not been merely talked about, but then put into real practice. I take this opportunity to commend the Chennai City ASI for this wonderful effort. I believe very sincerely women are not equal to men, but women are women. Equality to me is something different. Equal opportunities, equal platform, equal level, all that is fine. But then there are certain areas where women are women and they stand up primarily because they are women. I only wish that every woman realizes the divinity which lies within herself and expands on that divinity. I would go to that extent of saying godliness, when it wanted to pervade the earth in a manifestable form, probably thought of the form of a woman. Let's salute this divinity in women and take this opportunity to make her more and more a beacon, more and more a light. Thanks very much for the wonderful opportunity, and wishing all women and the world a very, very happy International Women's Day of the year 2021. Thank you.
Thank you, madam. I would now request all the faculty across the country for the national anthem to rise up, please.
तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
Thank you. ஒரு photo எடுத்து one photo.